And he has been invited as faculty to numerous live operative workshops, invited lectures at multiple conferences. He has also delivered 13 orations, including the prestigious DK Sen oration at SACON in 2019. I welcome you, sir, and I now request you to go ahead with your presentation.
Thank you and good morning. And it's always a pleasure to be with KLE, both as examiner as well as a friend of all of y'all during evenings with y'all after the examination. The topic that has been given to me is laparoscopic solid organ surgery. It's a huge topic, but given that I have been given only 15 to 20 minutes to talk, I have concised it. The topic basically is to spread awareness about solid organ surgery as well as let the PTs know what is laparoscopic surgery, especially solid organ surgery. So let's go on to the history with Tobias, Varies needle, insufflator, camera system came into picture, and slowly and surely laparoscopy came into picture. We started our laparoscopy with nothing but surveillance cameras, which are used as a security system. And today we have high definition cameras, 3D cameras, and even learning through Operation Lindbergh and e-streaming. Initially, people called it futureless surgery or circus surgery, or a person who performed laparoscopic surgery was known as a tightrope dancer. And nobody ever imagined that minimal access surgery will reach heights. Way back, we thought of doing cholecystectomy and appendicectomy. Mind you, appendicectomy by suture technique was first done by none other than Kurt Sem, who was basically a gynecologist. Professor Muhe actually was astonished looking at Kurt Sem and took up challenge of doing cholecystectomy. Today, we have specialized in minimal access surgery with GI surgery, colorectal, bariatric, reduced port, no ports, and even robo has. And that's how solid organ has also become a partial specialty. Cholecystectomy, which was first performed in 1985 and 1987 by Muhe and Murray, had a lot of patient benefits and hospital benefits too. We graduated through specializing in equipment, developing our own skills with learning curves and learning from complications. Now, if you broadly see, we have 6 or 7 organs which are solid or considered solid. Kidney, adrenals, pancreas, liver, thyroid, parathyroid. These are the organs which are known as solid organs, which I will deal upon. Michel Gagnon is credited with almost all surgeries on solid organs through minimal access as the first surgeon to publish, though may not have performed the first solid organ surgery. Let's look at thyroid and parathyroid, how it goes. If you see the history and timeline, Felix Mandel in 1925 was the first one diagnosed to a parathyroid adenoma and underwent surgery. Theodore Cocker is credited with the first thyroid surgery. Everybody knows about it. I do not have to go into detail. 1996, Michel Gagnon was the first one who did parathyroidectomy by minimal access surgery. However, the reports are that the patient had a lot of surgical emphysema and had to be put on ventilator. It was Mikoli in 1998 who introduced video-assisted surgery, also known as MIVAT. And then came what is known as true endoscopic thyroid or parathyroid surgery. Nowadays, even robotics has come into picture. So if you see this picture, it used to be a large incision for a thyroid or a parathyroid gland. Then came radio-guided surgery, focus surgery specifically for parathyroid adenomas, came video-assisted surgery as by Mikoli, then endoscopic surgery to breast and axilla. And now we are into the era of not only robotic or also transoral surgery, transoral endoscopic thyroidectomy and parathyroidectomy. A lot of papers are being published on this approach. If somebody, it's a totally different anatomy, you get confused when you get in. So one has to actually see, learn, and then perform these sort of surgeries which are there in literature. What is the acceptance of thyroid and parathyroid? Cosmesis, definitely. Recurrent laryngeal nerve rate injuries are comparable and claimed to be in some series lower. Mivate surgery is more accepted as compared to transaxillary or trans breast approach. Extensive dissection in endoscopic approach is a big bugbear because the patient post-operatively has a big tunnel pain that is there and is of more importance in Oriental countries where the necks are more exposed as compared to Indian population. What are the restrictions for endoscopic surgery? Any nodule which is more than 3 centimeters is a contraindication, less than 25 cc in volume. In Graves' disease, particularly, the volume has to be less than 20 cc. There should be no thyroiditis, neck surgery, radiation, which has given rise to fibrosis. So the planes have to be absolutely clear. And malignancy, some reports in 2020 are slowly coming up, but still not authenticated. Parathyroid surgery, the contraindications are reoperative surgery and obviously comorbid conditions where actually parathyroid adenomas, having done more than 150 now, I can tell you, can be done even under local anesthesia through a very small incision. So endoscopy for me is no for parathyroid surgery. Let's look at liver. It started with liver biopsy, tumor staging, fenestration of cysts way back in 1991. Hydrated cyst unroofing versus peritoneectomy was a big debate. Resections in benign and malignant diseases were reported way back by Ganier again and others. These were technically demanding during very good systems and should be performed were performed in only high volume centers. Then came a revolution where, because of development in technology, these came as the indications. Simple cyst deroofing and fenestration or resections, hydrated cyst as you see in this video, careful deroofing. Nowadays, papers are coming up with pericystectomy and even hepatectomy. Abscesses like aspiration is the choice, but if at all it's a rupture, it's a good thing to do a laparoscopic surgery. Advanced sepsis and some patients of cyst adenoma. This way back in 2000, I published the article on laparoscopic management of hydrated cyst, which was done through nothing but Dr. Palanivelu's initial introduction of the cannula. What are the acceptance for resections? Nowadays, yes, laparoscopic donor hepatectomies are being done, but one has to be very careful that the learning curve is about 60 cases. Way back in 2008, Kentucky consensus statement approved hepatic resections provided it's being done in a proper center with proper technique, and obviously good pair of hands. This is a patient on whom I had attempted, I will be very fair about it, had attempted a left hepatectomy, but unfortunately had to be converted because of bleeding. Recent trends, as I said, everything depends on learning curve, large tumors, centrally located tumors, donor hepatectomy, pure laparoscopy, hand-assisted hybrid, and now robotic. Just about 2 weeks back, there was a wonderful webinar where hepatectomy was shown by one Dr. Sudendran from India itself. He showed donor robotic hepatectomies. He showed his own complications, which was very highlighted, a highlight of the show that what can go wrong. So learning curve and proper training is important in taking up hepatectomy for sure. Let's come to pancreas as an solid organ. Initially, we used to do staging of pancreatic cancers, which led to avoidance of exploration. Preoperative CT, MR, and EUS are definitely effective, but ultimately the present trend is to put in a scope to look at metastasis, small metastases which could have been missed. Stenting and lap GJ is inoperable and do not require big incisions at all. Pancreatic pseudocysts came into picture, and resections like distal pancreatectomy or even Whipple was described again by Ganier in 1992 and 1994. Acceptance of pancreatic resections or pancreatic surgery is definitely pseudocyst of pancreas as a drainage procedure. necrosectomy in selected cases if one has good experience, enucleation of insulinomas and gastrointestinal stroma tumors, distal pancreatectomy with or without splenectomy has been described. And here is a case way back again in 2002 or 2004 that I had performed. Uh, Distal pancreatic with splenectomy obviously assisted and removed through a small incision. But nowadays in my institute, Dr. Rege has been in forefront of pancreatic surgery, performs, I think he's performed about 40 plus Whipples with good success. And it's the way to go if one acquires skills with adequate technology. The issues are whether one should do pancreatic resections in malignant conditions. One has to have paraphernalia of the pathologies, frozen section, margin, etc., etc. Skill and technology, as I have already told you. The stump, how do you close it? Ultracision, suture, or staples? I have seen a wonderful technique again introduced by Dr. Palanivelu, where there is gradual compression of the staples. The principle is very, very clear. Gradual compression with stapler removes the water content from the pancreas and then allows a secure stapling leading to less chance of leak. This compression, gradual one, goes over 10 minutes in a normal pancreas. So one has to have patience to do this compression. Large volume centers are the key to success in preventing mortality. What are the contraindications for me today in pancreatic surgery? Non-availability of intraoperative technology and proficiency, or rather non-proficiency in advanced skills in laparoscopic surgery, because one has to remember that even pancreatic leaks have a lot of morbidity and even sometimes mortality. So consensus in solid tumors is proper preoperative evaluation, distinguish low and high grade cancers, especially as far as pancreas cancer. MIS intervention, please go ahead in benign tumors or functioning neuroendocrine tumors like and low grade malignancies, at least in the initial stages. Spleen and adrenals are the two organs which I love. Delater and Malini in 1991 reported the first laparoscopic splenectomy in supine position. Alfred Kusheri, the doyen of laparoscopic surgery, initially said, do not try and do splenectomy if it is more than 500 grams. Definition changed quite rapidly. Nowadays, up to 4,500 grams of spleen has been removed laparoscopically, obviously with hand assist and through an incision for which this spleen had to be removed. The what approach to take? Anterior versus lateral. Lateral was the one which was described again by Gagnier. It's the posterior approach. You go through the lienorenal ligament and then open the gastrocolic and just fire a stapler, preventing injury to the pancreas. Most of us are open converted to laparoscopic surgeons. We prefer the anterior or anterolateral approach, and because if patient requires conversion, it's easy to convert. In the initial period of our experience, conventional instruments are enough, but now with availability of ultrasonic scissors and ligashure, splenectomy has really become very easy. Way back again, sometime I think in 2004, we had published this article on laparoscopic splenectomy using conventional instruments and had introduced a concept of hand port. Please read it. It's good sometimes. The recent developments are to do splenectomy in very large spleens, portal hypertension, residual accessory spleens, trauma, abscesses, and partial splenectomy. I'm not going to get into this video of splenectomy being done in trauma because there are specific indications where you should be going in and not otherwise. Lastly, coming to the adrenal glands, Higashihara in 1992 was the first person again doing adrenalectomy in supine position. Gagnier published his article in 1992 showing the distinct feasibility, but also said that at least 30 adrenalectomies should be done to be a master in adrenal on either side. Today, it has become the gold standard in almost all benign conditions of the adrenal gland. Endocrine evaluation when you are posting a patient for adrenalectomy is extremely necessary. Approach, it's up to you, transabdominal or retroperitoneal. We do usually transabdominal approach. Recently, we have started doing retroperitoneal. There is a controversy whether to take the vein first or the gland first. My suggestion would be that you take vein first in all benign non-secreting tumors, but obviously dissect the gland first, especially in pheochromocytoma. If you put a clip on the vein, the gland is going to get engorged if the arteries are not taken first. Size of the gland becomes a limitation in the initial period, but let me tell you, the larger the gland, the easier the dissection becomes if the gland size is not more than 5 centimeters. There is a controversy whether to do adrenalectomy in cancers or no. Let's discuss about the approach. Majority of the surgeons do a transperitoneal approach because you are familiar with anatomy. It's easy to learn and teach and easier for larger tumors, and obviously in case of conversion because you are well versed with transabdominal content. Retroperitoneal, I was no all the while till about 2 years back when I visited Martin Walls, who has done more than 2,000 adrenalectomies in by retroperitoneal. This, I was really very happy to see and learn these things. And I think last about 24 cases, we have done retroperitoneal surgery for adrenal, but we are very choosy about all this. This original article which we did, gaining experience by graded approach, is that we follow even in retroperitoneal tumors, that we take non-secreting smaller tumors in the initial phases so that we know exactly what is happening, and then only we will go on to future. The size of the tumor has been a debate. We have already published this article for large tumors greater than 6 centimeters, not feasible beyond 10 centimeters because it's increased incidence of malignancy. The lead article says 8 centimeters should be cut off in solid tumors if at all you're sure it is not malignant. But cysts up to 14 centimeters have been done, including I have done one case. Larger sizes, definitely benign conditions, one can actually this. So one has to study the investigations properly. Uh, Adrenocortical malignancy has definite CT findings which one has to know. And if there is high suspicion, one goes ahead with an open surgery. In current consensus, surgeon experience remains the key. Retroperitoneal approach seems to be more direct and good in my concept right now for smaller tumors, but is difficult to learn. Transperitoneal is better in larger tumors and organ confined, even if it is malignancy. If it is small and within the capsule, there is literature that has been published. Open surgery should be done in overtly suggestive of malignancy only because it gives good clearance. Because you've got to go and remove the nodes, which is difficult in adrenocortical malignancy. There are secreting tumors arising from neuroendocrine cells are known as paraganglioma. These are usually easy to remove, but sometimes can be in difficult locations like this one, where it is absolutely retrocaval. All that I could do is separate the cava from this tumor and then took an incision, obviously much smaller incision as compared to what otherwise would have required, and could remove it. And this was done in a workshop in Kolhapur. Paragangliomas, as I said, we have published, we have now good experience of more than 40 cases. One small thing, let me tell you, anything that is para-aortic or paracaval and being treated as a lymph node and being posted for biopsy, please keep paraganglioma in mind. Investigate this patient properly. Just to share with you, we had one such case which was posted for biopsy. Moment position was given, lateral position was given, the BP went up to 300. We had to abandon, then investigated this patient, turned out to be paraganglioma. So lessons are hard learned. So don't just take up. And these tumors are extremely vascular. There is neovascularization. So hemostasis becomes extremely difficult. So it has to be done by a good team and a skilled team. Recent developments are robotic adrenalectomy, which is taking, and cortical sparing adrenalectomy in bilateral pheochromocytoma, so that we save the cortical functions, that is the gland. So the status report is open surgery for solid organs. It started with MIS evolved since 1991-92. There was expanded scope for minimal access surgery with improved technology skills, team effort recognition, and dedicated centers of excellence. Experience definitely is required in larger spleen and adrenals, pancreatic duodenectomy, donor hepatectomies, complicated liver resections, thyroid, and parathyroid surgery. I think another 5 or 10 years, robo is going to come into picture. And to all the juniors who are listening to me here, look for a robotic training, minimal access surgery training, because that's going to be your future. Our future is now limited. So with this, I visualize a time when we will be robots to what dogs are to humans. And I am definitely rooting for these machines. Said Claude Shannon, I entirely agree with you. Man is a robo with defects is my definition of a skilled laparoscopic surgeon. And let me take this opportunity to thank the chairpersons, Dr. Gopte, the dean, and the vice chancellor of KLE. Thank you very much. I'm always there with KLE whenever you all want. Thank you so much.
Thank you, sir, for your enlightening presentation. If there are any questions anybody wants to ask, can ask, sir.
Excuse me, sir, I have one question.
Yeah, go ahead.
You can ask me. Please introduce yourself and ask the question.
Is roll number 29.
Please sir, you had mentioned about sir, you had mentioned about performing thyroidectomy under local anesthesia, sir.
I said parathyroid under local anesthesia. But if you want to get into theory, thyroid also can be done under local anesthesia. The nerve to block is the transverse cervical nerve, which is the midpoint of the sternomastoid muscle. Bilaterally, you inject about 10 to 15 cc of combination of lignocaine and sensorcaine, and you will have a good, you will have a very good anesthesia all around the neck. The trick is you should know where is the transverse cutaneous nerve. So, do you know where it is? I told you midpoint. Am I clear?
Yes, sir. Yes. Dalvi sir, thank you very much for your excellent talk. And as usual, the teacher in you always inspires all the students and the postgraduate students, and also a lot of faculty. Thank you very much for sparing your time, sir.
Thank you. Thank you so much. With your permission, I will leave because I have to take my post-emergency round.
Yes, sir. I think you can join us for the inauguration ceremony, sir.
What time is it? What time is it?
10:30, sir. 10:30.
Okay. I'll try my best. Thank you.
Thank you very much, sir.
Now I would request our co-chairperson, Dr. Pallidev Hanukar, sir, to throw some light on life and achievements of our next guest of honor, Dr. S.S. Suprimat, sir, Chairman, KSASI. We welcome you.
Good morning, sir. I would like to take the privilege of introducing Dr. Sadashiva Suprimat, sir. To tell in brief about his achievements, he finished his MBBS from King's Hooghly in 1985. Then he did his DMB surgery in November 1989. After that, he finished his MS general surgery in March 1990. Post his MS surgery, he has worked at various hospitals in Mumbai for 8.5 years. Dr. Shrikande, Dr. Panushali, Dr. Nande, and Dr. Maidev have been his mentors. He has held different positions in ASI, AMASI, and KSCSI. Presently, he is the chairman of KSCSI. He is the zonal vice president of South AMASI. He has organized various state level and national level conferences. He has few publications on his name. He has been faculty for various state and national laparoscopic surgery workshops. He has presented many posters, papers, and videos at state, national, and international meets. He has conducted endoscopy training programs, trained more than 100 surgeons from Karnataka and adjacent Maharashtra. He is the first to bring wide awareness, and he has popularized safety and advantages of various therapeutic, endoscopic, and laparoscopic or thoracoscopic surgeries in the entire North Karnataka from late 1996. He was a faculty at SDM from 2005 to 2014. He's been a part in establishing the endoscopic unit and laparoscopic unit at SDM Hospital, Dharwad. Well, we welcome you, sir.
Now I request Dr. S.S. Soprimot sir to present his topic for the day.
Thank you. Thank you for your kind words, chairpersons. Can I share the screen now on my presentation?
Yes, sir.
Let me just exit now. I will go to the first page. Yeah. I think my first endoscopic exposure was in the summer 1985 when one VIP patient got admitted in Hubli in one of the senior surgeons with whom I was working. And that time we had no endoscope in Hubli. So only person our senior doctor could think of was Professor S.V. Dept from Belgavi, as you all know. So, and we remember him as one of the very senior person in this North Karnataka, a professor who established a GI unit. In fact, he was the first person to have endoscope in the entire North Karnataka as credited. And it is nice of KLA that he still remembers him very well and gives all the respect for whatever he has done in the department of endoscopy. My path actually, it started somewhere way back in, say, 1986 when I actually got to see scopies. And somewhere in 1990, I learned to do scopies and therapeutic procedures. And in 2000 onwards, I started doing ERCPs. Well, we conducted various training programs for different people. And these are the topics which we are covering when we are covering the basics in endoscopy. You know that the topics are huge, so it is not possible to cover in this period, whatever we are talking now. But Professor Gokte requested that I should talk something on that so that people get motivated to take up this field, which surgeons are losing interest in. In fact, I must say that this one field which all of us should take interest and also teach our youngsters. All the standard training programs do teach about how to take care of the scope, how to clean everything and all that, what all things, that's what we need to know. And this is how the endoscope unit looks like. So you have a processor, you have a light source, and that is fed to the monitor. And of course, it can be recorded also. So these are all the things which the unit contains. In a scope, you know that this is likely anatomy in most of the scopes, that you have a sheet which goes inside the patient body. And this is what the inside structures contain. It's like a external view of the building, and these all wires, cables, everything run into the building, including the wall and everything and all that. So we need to know about that. If I go in detail, it will be like introducing many people in a marriage where you won't remember anyone later on. So it is like that, because unless someone is interested in this field, takes up this, it is difficult to remember all these parts, and people will get bored when I talk about all these things. But we also should remember that though the sheath is just around maybe 10 millimeter, 9 millimeter, now they come as a pediatric scopes also. But the cross section of that sheath, which is about 9 millimeter or 6 millimeter sometimes, contains all these vital structures inside. That is the reason we have to handle with care, because the light fibers, the optic fibers, the image, but this one will be carried by these wires, where the tip is attached to the the camera is attached in the tip. There is air channel, there is other water channel, and there is suction channel. All these channels will be available in this small compact tube. So it is very specifically designed instrument. This is how one need to handle the instrument like a baby. Otherwise, the scope is likely to get damaged. If you look at all these innovations in the past of all these procedures which have been done, let me tell you, all these people are surgeons, and these people invented all these procedures in the past. But now I think it's become a little difficult because people are losing interest. So all these people have devised and invented all these procedures. What has happened now? We have lost little interest. What are the procedures that can be done apart from diagnostic? I think there's foreign bodies can be removed, dural ulcers, whether the bleed, whether it can be conserved, whether it needs to be intervened, whether suppose if there is a narrowing because of ulcer, does it need dilatation, does it need surgery, and you can pick up early malignancies. Achalasia, so many times they are being often missed, and you can pick them up. Lymphomas, tuberculosis, malignancy, especially in malignancy, surgeons need to know what is the extent. Are there any nodules? So that you know exactly what is the extent of a lesion, so that you can decide what kind of surgery you can do. That is of immense help. And again, in bleeds, I'll just show you some of the things. So now I'm not going to talk about the basics now onwards. I just want to motivate people to see what all can be done. Suppose if a upper GI bleed comes, you can just go and see what happens and inject, right? And then where there is an active bleed, either with a glue or whatever you have, sometimes the clipping can be done. So all these procedures can be done as a surgeon. So this is what we need to know. And also foreign bodies, see, most often you can take them out. Even if there is a little perforation laterally, these are all infected foreign bodies. And surgeons, how to, to manipulate all these things inside, how to jiggle out, how to wriggle out. So this is impacted and perforated. This one, which I think somebody is handling this screen, please. So you can see that this can be taken out, and then literally you can disimpact that and take it out. So that is a possibility. When you go and you can see the perforation on side, both sides. These are all localized abscesses, which you can treat because it's not a spread is there, and with antibiotics and all, the patient will settle. If you fail, then you can always open it out. You can always make a gentle opening. This is a pseudocyst of the pancreas. We didn't have a UUS. We didn't have anything else. It's a localized. There is no lot of necrosis on CT scan, and you can puncture and then open and enlarge with a CRE balloon and create a cystogastrostomy kind of thing endoscopically. Again, you can drain out everything. The only thing is, if there is any necrotic tissue, of course, now the newer stents have come. The technique has developed so much that you can clear even the necrotic tissue going inside, or a lumen occlusing stents which are available. So this kind of opening you can create where there is not a lot of necrotic tissue, and you can put a stent and come out. But as an endoscopist, you can make out what actually is the lesion. For example, in this which patient came, there is a lesion multiple in the pre-pyloric region. You know that it doesn't look like malignancy. It is something different. And it's almost infiltrative kind of lesion in the stomach. And when you go across the pylorus, you see that the pylorus is involved. And beyond the pylorus also there is a lesion. We know that pylorus acts as a watershed line. Any lesion which involves stomach and duodenum has to be a lymphoma together in this. So we can make a confident diagnosis. In fact, our pathologists were not tuned to diagnose GI lymphomas. So a lot of lymphomas you can pick up so that the things are not missed out. And when in a malignancy, as I said, you know the extent when you do it. Say, for example, though it appears like a pyloric lesion, a pre-pyloric lesion, it extends all along the lesser curvature. Hardly there is any space. So when you take up this patient for surgery, this has to go for at least, that minimum surgery, what you can do is a total gastrectomy. So this only information you can get, how much is the infiltration, the extent. Suppose if the patient comes with a bleeding, and suppose if you go in and see the visible vessel like this, at the same sitting, with a minimum instrument, you can do a therapeutic procedure like injecting the ulcer, 4-quadrant injection. A saline, you can add a bicap or a bipolar kind of thing where you can heart bipolar forceps where you can coagulate the vessel also. So you are assured, added with this antacid therapy will almost assure you that the bleeding is not going to recur in this patient, because elderly patient, this patient is around 59, and with this kind of visual vessel, they stand a very high chance of bleeding. So this is how you can manage. And suppose if there is a duodenal ulcer, what you get to see? When somebody else go in and see, they will see this kind of narrowing. They say it's duodenal narrowing. So patients straight away go for surgery or some other intervention. But if you are a surgeon, you can actually look into what is happening. There is an ulcer there, but much more than that, you can go across this edematous narrowing. And this is possible narrowing because of the ulcer. So you're confident that when you treat them with, a medical therapy, they will definitely recover and they will do well. And colonoscopies, of course, these are all things what you can pick up: evaluation of altered bowel habits, tuberculous lesions, IBDs, and non-resolving appendicular masses, bleeding piles. Many of them have been operated as bleeding piles because there is some sigmoid lesion or rectal lesion, which you all know, hyalocecal masses, post-operative follow-up. It's nice thing to know when you go in and see after colectomy what kind of anastomosis you have done, how beautifully it has healed. Is there any recurrence? So all these things, lower GI bleed, it's a very important investigation. Polypectomy, palliative stent, like derotation, sigmoid, all these you can do as an endoscopist. As Professor Dalli was telling, the robots are coming. I'm sure the endoscope is also invaded in most of the field. And these are all tuberculous rectal ulcers, which you never imagined that it's possible. So because of this classical appearance, it can be diagnosed clinically. This is also tuberculous narrowing of the rectum, so which the patient underwent surgery. Suppose if there is lower GI bleed, you can straight away take them off. You know that it's a child with lower GI bleed. You can see the polyp. It's a very, very simple procedure. You can inject and then just snare it off. It's a very just daycare procedure like, and by evening, you can send the patient. So you can see that there is a stalk which is elevated by injection by saline adrenaline and put a snare around and snare it off. And it's such a beautiful procedure and it's a daycare like. ERCP, of course, you can clear the CBD stones with or without sepsis, gallstone pancreatitis, which don't resolve in the next 24 to 48 hours. Biliary leaks you can attend, and pseudocysts you can drain, as I said. Pancreatic fistulas and leaks, you can stent them, and palliative procedure many times, like stenting and other things, can be done. It's the gallstone pancreatitis where you can see that there is an impacted stone there, and there is a cholangitis. You can see pus around, inflamed bile around, and just releasing the stone will just clear off. Pancreatitis settles very fast. In majority of the patients, of course, the stone passes out, but sometimes even a small stone gets stuck, as it is in this. So you just do a pre-cut, you see the size of the stone is such a tiny stone, but when it blocks that small papilla, the damage what it causes is tremendous. If you are a treating surgeon of this patient, you can assess next day and decide to take the patient for intervention, and then the patient will settle rapidly. And many of the times we feel that the big stones cannot be taken off by ERCP or whatever it is. But with a proper technique, with a proper understanding, it is possible that you can take off even the bigger of the biggest stones sometimes. Of course, you have to make individual decision based on the anatomy and the team what you have, the resources what you have. So you can always think of delivering such kind of problem. And how you can see inside is something beyond. We don't even imagine it, what kind of job we can. You say, of course, the purulent bile, what you see, it's a septic patient with a large impacted stone, which was delivered. And what kind of papillotomy you can do if you're confident about the anatomy is something mind-boggling. This is a very, very, very big stone, which can be taken off and released in that. You can see the size of the stone, and you can confidently do that. If you are confident about doing a procedure, you can literally look into the CBD, look into how it divides and all that, and so much of clarity you get. So it is something which you can't even imagine. Miriges. So you know that this kind of findings you get it, and you just stent them when they come in cholangitis, it immediately settles. You can go in laparoscopically, shave it off, take off the stone, you make an incision here, and then just close it. I think that's what you can do. So, and even with this, the leak is likely to be very, very less. In pancreatic interventions, many times this patient, a child presented with a pancreatic pleural fistula. You can see that it is an irregular dilated pancreatic duct, and there is, of course, is a leak, and you can see the chest tube. And what can be done? You just stent it, and then everything settles. And later on, you can go in for surgery. You can see, you can demonstrate a fistulous communication, do a pancreatic jejunostomy. Of course, the pancreatic pleural fistula gets stopped immediately after stenting. The leak stops. You can send them, call them for a planned procedure like this. So you can do this. I don't know how many of you people have seen hematophagia. There's a bleeding from the pancreatic duct or this papilla. So these are the patients, when we investigated, this turned out to be a pseudoaneurysm, or aneurysm for that matter, with a bleed. It's the pancreas, the blood clot, everything and all that. When we went in, it was like a mass pseudoaneurysm, chronic pancreatitis, spleen, stomach, everything got like en masse, and we had to do a surgery. It was like en masse resection with a stented. So these all things you can do. And of course, bronchoscopy is another very useful procedure. Many of us think that it's a very complicated procedure. It is not so. It is a simple procedure. Only thing is you have to have exposure for that. You can do, say, undiagnosed pleural effusion. You can know whether there is bronchial lesion. You can do bronchial needle aspiration. Nowadays, that EUS, has come in the endobronchial ultrasound with fine needle aspiration. Hemoptysis patient, you can know exactly from where the patient is bleeding. And esophageal malignancy, especially in the middle third, I think you need to know that whether the bronchus is involved or not. And post-operative collapse, or if there are leaks, or this for closure, how you have done it, all this can be done. And of course, now we know very well that in difficult intubation, the bronchoscope plays a very important role in guiding for the intubation. So these are all things can be done. These are bronchoscopic findings that you can see the infected purulent here is a cox, the sputum. You can see the tubercles here, which otherwise you cannot see this kind of tubercles on CT scan. You can see the scarring because of tuberculosis after treatment. And you can see that the bronchus is destroyed here. Most will they will end up in narrowing after treatment. You can take a biopsy. These are all malignancies where the biopsy is being taken. And you can see from which bronchus actually the bleeding is happening. As you can see in this video, it is limited to a particular segment of a bronchus. So once you identify this kind of bleeding in hemoptysis patients, which cannot be controlled with conservative treatment, you can just go and knock off only that particular segment. You don't have to do a major surgery because you have identified very clearly from where the bleeding is. So much thing in post-operative especially is very, very useful. Many patients land up in respiratory problem post-operatively. We don't even bother what is happening. Sometimes it may just mucus plug. It may be a lot of secretion just pented up in that, as it has happened in this patient. This patient had undergone some spinal surgery. Post-operatively, patient needed a lot of oxygen support and ventilation and all that. When we went in, the whole bronchial tree was flooded. So repeated cleaning had to be done. And this patient came out of that, and you can see the X-ray changes. This was the thing, immediate post-op, and this is after repeated clearing. The patients can recover faster, and you give them better chance of recovery and going home. And this, of course, you all have seen this kind of typical discussion, that is sun-ray appearance in X-ray chest, a typical finding of bronchogenic carcinoma. It was labeled bronchogenic carcinoma. Confidently, it was just sent for a biopsy and if required for surgery. But when we went in, this is the finding. You can see that you don't see this kind of picture in malignancy. So immediately tuberculosis was suspected, and this came as tuberculosis, and patient could be saved. All these procedures are coming just like in robot. You know that you can do a stir, that is you can go into the submucosal layer, you can take off leiomyomas. Poem is being done this way, and endoscopic ultrasound has come in a big way. So all these things are very, very, very important. We need to know about that. Now I will deviate. First thing I told, what are the simple things? I didn't mention about that. Second, I have told you what all things are possible that you can achieve if you take up this field out of your interest and grow it. Next, I am going to show you some interest where these things have really helped in managing these patients. How different patients we have seen a set. I must thank Professor Gogte. He helped me to dig out some of these patients, and this is how it helped. So this is a patient which was almost labeled as a CA esophagus. You can see in the CT there is a thickening. There is a thickening here, and it was biopsy had come positive somewhere else as squamous cell CA. It was sent for endoscopy too. But I thought, let me repeat the endoscopy. When I saw the endoscopy repeated, this is what you can see that I'll show you. So having seen so many malignancies, there was a doubt this is not likely to be malignancy. Appearance is not so because it's not friable, it's not vascular, it's not bleeding. And this kind of tunneling we don't see in the esophageal malignancy. So we took a biopsy, and I went to the pathology department. I requested them, this is not malignancy, please look into. When they looked into and said, this is a tuberculosis of the esophagus. Believe me, it was tuberculosis of the esophagus because we treated this patient and did follow up. You know, this is in the August. You can see the date and everything is there, and everything had healed. Entire thing had healed. This is a scarring in the lower end of the esophagus. So this is how you can, as a surgeon, as an endoscopist, can make a tremendous difference in the management. Because most of the fields nowadays are not very serious about the one, and reports sometimes may not be trustable. So it purely depends on what you are exposed to, what you can do. This where we fail to do a cannulation in endoscopy, there's something different, which is, it can be called as little dangerous, but with experience it can be done. There is flat, papilla is totally flat. You cannot cannulate. So what we did, we just snared as part of that area, submucosal resection kind of thing, or a snaring kind of thing. Then we could identify the papilla. Then we could cannulate. It's totally a flat papilla. there is an adjacent diverticulum is there, then you can go in. So these are all things as a surgeon you can think and do when it is required, and take initiation and think something differently. This other patient who had gone into a resection, undergone a stricture resection of the rectum, who had done an anastomosis, but the patient leaked. We had two options, to go in or to do. There was a collection also, as you can see here. This patient had a contrast leak here, as you can see, and a collection is there, and there is a air pockets. So what we did, we just did a percutaneous drainage and we placed the rectum. After counseling, they opted for endoscopic treatment. And this is how the stent was placed after percutaneous drainage across the leak. And sorry, I think there is some problem with the video. We placed the stent and the leak stopped and patient went home. These are all things we can do. This other lady who came with a history of cough, everything. She had taken some tablet. After that, she developed some problem, chest problem. She was admitted. You can see that there is some lot of bulge is there. And then when we went, there's a lot of air pockets, pus formation. It's this all inflammatory signs, mediastinitis. You can see that gross mediastinitis is there. Then we took a bedside endoscopy. We found out there is a perforation. Then we did an endotherapy. We didn't operate on this patient. I'll show you what we have done. A follow-up endoscopy shows complete recurrence. And this work, in fact, was published. And this has been cited also as one of the paper. This is the perforation, as you can see. And we went, what we did immediately, we did a peg for nutrition, because nutrition was very, very important along with the antibiotics. Since it was a localized, since it was 5 days, we went into the perforation, went into the mediastinum, went into the cavity, and cleaned up all infected material, sloughed everything in. You can see the septations, pocket formations, this all in the mediastinum. So well walled off, extensive mediastinitis. So all things could be cleared with washings and all that. It almost was going almost up to the diaphragm. So it was cleaned thoroughly by this endoscopically. Then after that, what we did was we placed a rise tube in this through this guidance so that we can do an irrigation post-operatively after this cleaning of this pus. And we went on irrigating post-operatively. The whole cavity got cleaned. Under a guide wire guidance, we placed the rise tube and then we came out. Then we cleaned up the thing regularly. This is how we did. And post-operatively, it got a little cleaned up. As you can see here, there's a minimal fluid coming out after this. So this is how it was treated. And post-operatively, when we went in, everything is scarred and healed. This is the perforation site. So everything is healed up. There is scarring. I am trying to probe it. Everything is obliterated. This is a scar and totally recovered. So this kind of work, out of the box thinking, as a surgeons, we can think. This is a follow-up. This is the air pockets which are resolved. This is all mediastinitis which has resolved. And this is how patients did well. This other patient, tachycardia, tachypnea, all that, this patient was thrombolized. In fact, when it didn't improve, they sent it to us. What it had, again, extensive mediastinitis. I'll just hurry up because these are all rare cases and you expect they don't survive at all. You can see kind of mediastinitis, the kind of inflammation here. So these are all rare cases. But as a surgeon and endoscopist, you can think so many things. What we did, this was the kind of thing what we saw. A perforation, and we just didn't do anything because we know that these are all friable. So what we did a peg for this for nutrition, and we drained it from the substernal root. The whole mediastinum was drained. You can see the drain being placed in the mediastinum after substernal clearance, and after that we did a follow-up and everything has healed. It's something which you don't believe that it can happen in these kind of patients. But as an endoscopist, you can think so many things. In fact, we had done a thoracoscopic clearance, this substernal approach. We approached from many ways. The PEG, other things all helped in nutrition, and everything could be cleared off. So treatments can be individualized. Now, recently, this patient had a recurrent pain abdomen, and they went to different places. Twice CT scan was done. Both sides it was mild acute pancreatitis, idiopathic pancreatitis, CTs at different dates. One of the premier institutes they have gone. And this is how they reported focal pancreatitis. So they just didn't think anything beyond focal pancreatitis and they went on treating conservatively. When the patient came to us, then we thought that possibly it was something else. Got a MRCP, which is the image I showed, it was a pancreatic divisum. You can see this is the main papilla and this is the minor papilla. So this minor papilla could be cannulated and stented. Now the patient is pain-free. So why you should take up endoscopy? Because you know that in all the fields, the endoscopy is taking over. Most of the fields, this is the list, what all can be done endoscopically, what all things are being done. So in the days to come, I think it's going to play a very, very important role. As Professor Dalve has said, he mentioned about robot. I am going to mention about endoscopy. It is just taking over. So this itself can be a specialty. We know that lot many surgeons have initiated, even in India, Professor Krishna Rao and Amit Maidev and Amol Bapai, and there are few Ramesh Ardhanari and few more surgeons who are doing endoscopic work. But the number is dwindling because the youngsters are not taking up this as a specialty. So I wish that this should be taken off. This is for seniors, which I already referred to the written to the ASI, that the curriculum has changed because most of the surgeons have kept quiet. We are losing interest. The youngsters are losing interest. The teaching faculty is losing interest. The PGs are losing interest. The whole curriculum which was there in NMC earlier, this was the earlier Medical Council of India curriculum, MS curriculum, you can see. But what has changed? The NMC has changed it totally. Just this is one line that comes in this in NMC website. It is there. You can check it up. What line is there? Management of bile duct stones, including endoscopic, open, and laparoscopic management. Beyond this, there is no mention of endoscopy. I think we need to get up. We need to wake up. We need to give a. Otherwise, I think we surgeons are going to lose this forever in our field. We have to make a strong representation in endoscopy to the National Medical Council and everything. We have to make a strong presence felt. So these all things we have to do. And what we achieved, more than training many people, the Kidwise sent their own people to Hubli for training. I think we took a lot of interest in training people of this area, and even the people from Kidwise are sent here for training. I think this is important that most of your people take interest in this endoscopic field. Complications, yes, like any other procedure, there are likely to be complications even in our field, but you should know how carefully to avoid them, how to handle them. And as a surgeon, I think we all are better equipped to face the complications and handle them in a much better way. What has helped me, or what will help if you take up as endoscopy? Well, it will help you in making a holistic approach to a problem, be it biliary, be it GI, everything. You'll be more confident. You will think what can be done in this patient, what can be minimized, what procedure I should choose. If I fail in laparoscopic, sorry, ERCP wise, I can take it for lap CVD exploration. So you can decide what needs to be done in which patient. So all these things are possible. What are my regrets? Well, so much of work is there, so many patients are there, varieties are there, but we have not published our publication because of our laziness, maybe because we don't have a teamwork to work. And newer techniques like POEM and stuff, those I got trained, but I have not yet started, like US. And I have not been able to build a team where I can say, take it to the next level. Of course, training, I wish I should train more people. I should have trained more people, and I hope it's going to be a possibility in future. So this is what I think we need to open up our mind and see what changes are happening. We need to change our mind. We have to learn the newer skills. Endoscopy is not the same endoscope. Many of us don't want to waste time for that because we think that surgery is more challenging, but endoscopy is equally challenging. And of course, all this, whatever we have done something new, is came out of limitations of our resources, whatever we could do in our procedure. These are all the things I think our limitations teach us a lot of things in India, and many new things will come up if all of us think alike. Fine. I do enjoy life also. This is one of my snap. I go out. I love to see birds flying, nature around. And my sincere thanks to Professor Gokte, entire surgical team, and the people, organization, the chancellor, the principal, registrar, and everyone there, the deans. So I must remember and sincerely acknowledge the contribution of my mentors in this, parents and well-wishers, and my patients, who with a lot of confidence came to us, and they didn't go anywhere, many of them. Even when we give them an option, they said, no, you do whatever you want here, we cannot go. That's how we could do some of the things. And you all who are giving us an opportunity to share all these thoughts, and especially Professor Gokte, because I had to dig out some of my cases from my old collections and I had to make this presentation. Thank you. I just wanted to make this as an overall view. I cannot go into the depth of basics. Any questions, anything, or any contribution, I think I am willing to share.
Thank you, sir.
Thank you.
Thank you, sir, for sharing sharing a piece of vast knowledge with us. There are many questions. We would like to start with Dr. S.C. Methu, sir. He wants to ask some questions to you.
Good morning, Dr. Supriman.
Good morning. Good morning.
Just request you to, for the sake of the young surgeons and trainee surgeons here, kindly elaborate on timing of cholecystectomy after ERCP. There are different views. What is your view? I would like you to kindly elaborate on that.
Yeah, fine. I'll tell you how things changed and how in my practice it has changed. Earlier, before 2000, when I was not doing ERCPs, I was sending them somewhere else for ERCP. By the time the patients come, it used to be weeks. And I used to go in somewhere around second or third weekend, and it used to be a mess, for me to do, because it's all inflammatory changes, adhesions, everything. And the patients, sometimes they'll come after another 2-3 weeks, so 4 to 6 weeks. So I used to find a way. Once I started doing ERCP, suppose if I'm confident that I handled it smoothly, nicely, and cleared everything, I go ahead next day. Suppose if there is a lot of handling, everything, if I have taken a long time and all that, I delay it for a day or two to see whether the patient develops pancreatitis, whether any complications. Suppose if there is a lot of cholangitis, sick patients and all that, then I wait for the delay the procedure. In all other patients, in 80 to 90% of my ERCP patients undergo cholecystectomy next day. That's how we counsel the patients who come to us primarily. Sometimes they get referred only for ERCP. In that time, I talk to the surgeon and I tell them, this is the policy. You follow whatever you want, but I would prefer to do it in the next 24 to 48 hours. This is my take on this. And 80 to 90% of our patients undergo that. That's how we plan our ERCP. Everything OT is booked in advance provisionally. That's how we plan our procedures. Because I'm sure about how I have cleared, whether left behind something, whether it is smooth, how much handling I have done. I will know everything. So that's advantage. So I think you are also some postgraduate should go and attend the ERCP is being done. Then they will know how smoothly it has undergone. Then you can decide to take them next day itself. If everything has gone on well, everything has been cleared.
That's one of the reasons, as you rightly said, we surgeons should start our own ERCPs. Yes,
of course. I fully believe in that. Because sometimes I fail. Then I call them second time after 24 to 48 hours. And then it succeeds. So you would know. So I think we must make all efforts. Yeah. And I can decide to do pre-cut. I can decide to do whatever I want. So many options will be left to you as a surgeon when you do endoscopy.
Yes. Thank you, sir. So there's one more question from Dr. Dayanand, sir.
Yes.
He's asking, in this COVID era, is RT-PCR mandatory before doing endoscopy?
Well, earlier we were doing it for all patients. Now in Hubli, Dharwad area and our area, it is very well settled. Routine endoscopies, I don't do RT-PCR, but for therapeutic procedure, we do. Either it has to be RAT with CT chest, the anesthesia people ask, or it has to be RT-PCR. One of the two combinations depend on that. If it is an emergency, they undergo RAT plus CT chest. If it is a planned procedure, next say 2 or 3 days, then we do RT-PCR. This is the protocol.
Thank you, sir.
Thanks a lot.
Morning, Supriman, sir. It was an excellent presentation.
Thanks to you.
Yeah. And what I feel is the postgraduate, at least, like you have been on the forefront in the
sorry, I couldn't hear you. There is some disturbance. Yeah, please. Yeah. Can you come again, please?
Yeah. Thank you very much for an excellent talk, sir. And you have been on the forefront in North Karnataka from the surgical point of view and the endoscopy point of view. What do you think about the basic upper GI and lower GI scopy to be put in the curriculum? No doubt it is there in the curriculum, but I think we should insist all the surgical colleagues and departments to insist that at least when the PG passes out, we should know a basic upper GI and lower GI, and then sky is the limit for it.
Yeah. Actually, one thing is that, as I mentioned, the NMC has taken it off the curriculum. So NMC website doesn't show that. I just mentioned that. But we must insist that is number one. Number two, I think last year, this Gastroenterologists Association has come out with a position paper in 2019, where they have described level 1, level 2, level 3 kind of procedures. I think, as you mentioned rightly, level 1 procedure should be diagnostic and minor, say, taking out foreign bodies, other things and all that. I think that's what we should be initiating. The first year, I think they should start the training right from first year itself. what is before important is that we must train the trainers kind of thing, because unless the younger staff don't take interest, because I don't expect the seniors to devote that kind of time to learn this, because you have to devote some time. So we are willing to accommodate and train them free if they spend about, say, 3 to 4 weeks with us, come as observer. Say you can choose one youngster from each department, younger staff. And that's where you can start, because unless the staff knows, the PGs cannot be exposed. So the PGs right from year one, I think they are allowed in tube insertion, diagnostic procedures. I think first year they should learn. Second year they should learn colonoscopy. Third year they should learn a basic procedures like foreign body removal, sclerotherapies, banding, basic procedures. Advanced procedures, of course, they can learn later on, ERCPs and all that, once they start learning. Once that fear goes of handling the scope, how it has to be handled, how it has to be maintained, I think the things will go on next. Somewhere, some beginning has to be done. It's just that you don't get into that. That's all.
Yes, I think that's the message what we wanted to give to the postgraduates. A lot of undergraduate students are logged in. So I think many of them will be stimulated with your talk. And thank you very much, sir, for an excellent talk. And we'll be having inauguration at about 10:15. So if any other questions are there, Sopimat sir is there to answer.
Any questions from the audience?
I must thank you. You put me on a very little hard work where I had to collect material and put them together so that I can make it a little more interesting for the youngsters. So I must thank you all for making me put in this.
Yeah, I should really thank, because it's a very vast topic and sir has given a bird's eye view for everybody. And I think the junior staff members, the postgraduates and the students will get a lot of encouragement from sir's talk. Thank you very much, sir.
Thanks.
You can join us for the inauguration. Thank you, sir.
Thanks a lot. Thanks a lot.
Thank you.
Thank you. Thanks, everyone. Thank you.
I thank our chairperson for this session, Dr. A.C. Mittal sir and Dr. Kapil Hanukar sir, for sparing the time to attend this session and also to moderate it. Thank you. Request everyone to join our inaugural ceremony at 10:30. We hope to see everyone at that.
Please don't log out. No?
We'll be joining at 10:30. There's a break for 10 minutes now. Inauguration ceremony will start at 10:30.
Pantodac is the original pantoprazole, and nothing beats the original. A recent lab test revealed that Pantodac has 0% drug loss when it was kept for 2 hours at gastric pH. whereas the competitor brand lost almost 1.6% drug under the same conditions. At duodenal pH, in the first 10 minutes, Pantodac showed 7 times faster dissolution compared to the competitor brand. In the first 10 minutes, Pantodac dissolution was 75%, whereas it was just 10.7% for the competitor brand. Faster dissolution ensures faster result. The recent study published in the journal Gastroenterology 2020 shows that pantoprazole has an anti-inflammatory effect that significantly reduces the dyspeptic symptoms. A 15-year-long study of pantoprazole published in Elementary Pharmacology and Therapeutic suggests pantoprazole was well tolerated, effective and safe for long-term use. Also, the recent study published in the Journal of Gastroenterology suggests that pantoprazole therapy is not associated to any adverse event when used with rivaroxaban and aspirin for 3 years. Pantodac is the original pantoprazole and nothing beats the original. Issued by Zydus Corza. Pantodac is the original pantoprazole and nothing beats the original. A recent lab test revealed that Pantodac has 0% drug loss when it was kept for 2 hours at gastric pH, whereas the competitor brand lost almost 1.6% drug under the same conditions. At duodenal pH, in the first 10 minutes, Pantodac showed 7 times faster dissolution compared to the competitor brand. In the first 10 minutes, Pantodac dissolution was 75%, whereas it was just 10.7% for the competitor brand. Faster dissolution ensures faster result. The recent study published in the journal Gastroenterology 2020 shows that pantoprazole has an anti-inflammatory effect that significantly reduces the dyspeptic symptoms. A 15-year-long study of pantoprazole published in Elementary Pharmacology and Therapeutic suggests pantoprazole was well tolerated, effective and safe for long-term use. Also, the recent study published in the Journal of Gastroenterology suggests that pantoprazole therapy is not associated to any adverse event when used with rivaroxaban and aspirin for 3 years. Pantodac is the original pantoprazole and nothing beats the original. Issued by Zydus Corza.
ಹಲೋ, ಗುಡ್ ಮಾರ್ನಿಂಗ್. ಇದು ನಮ್ಮ ಇವನು ಮ್ಯೂಟ್ ಮಾಡ್ಯಾರಲ್ಲ, ಇವು ನಮ್ಮ ಆಡಿಯೋ ಮ್ಯೂಟ್ ಆಗ್ಯಾವ, ಮಾತಾಡ್ಬೋದು. ಐ ಸೌಂಡ್ ಇಸ್ ದೇರ್.
Sir, you are audible.
Is the original pantoprazole, and nothing beats the original. A recent lab test revealed that Pantodac has 0% drug loss when it was kept for 2 hours at gastric pH, whereas the competitor brand lost almost 1.6% drug under the same conditions. At duodenal pH, in the first 10 minutes, Pantodac showed 7 times faster dissolution compared to the competitor brand. In the first 10 minutes, Pantodac dissolution was 75%, whereas it was just 10.7% for the competitor brand. Faster dissolution ensures faster result. The recent study published in the journal Gastroenterology 2020 shows that pantoprazole has an anti-inflammatory effect that significantly reduces the dyspeptic symptoms. A 15-year-long study of pantoprazole published in Elementary Pharmacology and Therapeutic suggests pantoprazole was well tolerated, effective and safe for long-term use. Also, the recent study published in the Journal of Gastroenterology suggests that pantoprazole therapy is not associated to any adverse event when used with rivaroxaban and aspirin for 3 years. Pantodac is the original pantoprazole, and nothing beats the original. Issued by Zydus Corza. Pantodac is the original pantoprazole, and nothing beats the original. A recent lab test revealed that Pantodac has 0% drug loss when it was kept for 2 hours at gastric pH, whereas the competitor brand lost almost 1.6% drug under the same conditions. At duodenal pH, in the first 10 minutes, Pantodac showed 7 times faster dissolution compared to the competitor brand. In the first 10 minutes, Pantodac dissolution was 75%, whereas it was just 10.7% for the competitor brand. Faster dissolution ensures faster result. The recent study published in the journal Gastroenterology 2020
For the patients suffering from antibiotic-associated diarrhea, IBS, and H. pylori, presenting Providac, the genetically stable bacteriotherapy. Providac contains 1 billion CFUs of Bifidobacterium, Bifidium BB12, and Lactobacillus acidophilus LA5. Providac Texule comes with the aluminium canister and big silica gel, which protects texules from atmospheric moisture and ensures zero moisture inside the pack. Providac is more than a capsule. It's a texule. Providac texules are genetically stable and do not contain any genetically modified organisms, hence no chances of gene mutation. Providac has special polysaccharide matrix technology, which ensures more than 73% colonization in the gut. Providac Texule, when reaching the stomach, forms polysaccharide matrix gel, which encapsulates BB12 and LA5 strains to protect it from acidic environment. The matrix dissolves when it reaches the small intestine and releases BB12 and LA5. LA5 starts forming colonies in the small intestine. When this matrix reaches the large intestine, it releases BB12 and forms colonies in the large intestine. The colonization of BB12 and LA5 is very effective to treat and prevent antibiotic-associated diarrhea and reduce IBS symptoms. Providac with H. pylori treatment increases the H. pylori eradication rate and reduces antibiotic-associated side effects.
Coming? This is coming. Yes, yes, yes. We'll just wait.
Yes, sir. Guest have joined.
Yes, sir. Dr. Sofimat is there. Dr. Guram will join. Just see Guram sir join. He has joined, I think. Only problem what we face, sir. If we put our audio on, there is a lot of sound. We have to close all the audio here. Yes, sir. If we keep our sound issue on, there will be a lot of.
Hello, good morning. Hello, good morning. Dr. Godke. Hello, Dr. Gupta. Good morning.
Yes, sir. Yeah. Good morning, sir. We are just starting, sir. Thank you very much for logging in, sir.
I just checked my audio. Is it okay? Everything fine?
Yes, sir. Yes, sir. Your audio is good, sir. We are just starting the function, sir.
No problem. Thank you. Thank you.
A very good morning to one and all. On behalf of Department of General Surgery, JNMC KAHER BELGAVI, I take a pleasure in welcoming the esteemed dignitaries, distinguished guests, speakers, and alumni to the inaugural of our first virtual surgery CME 2020. That is, I hope all you will enjoy the online academic feast of this year. Now I request Dr. A. Goke sir, Professor, HOD Department of General Surgery, to extend a warm welcome to Dr. P. Raghuram sir, President ASC, that is in 2020, and who has consented to be our chief guest virtually, and Dr. Vivek Saudi sir, Vice Chancellor KAHER BELGAVI, the chief guest in person for today's event is okay. Thank you, sir. Particularly COVID times. Now I request Dr. Amit Ammani, Organizing Secretary CME 2020, to welcome Dr. Abhay Jalvi sir, President-elect ASI 2020, and Dr. Tish Desh, President-elect ASI 2022, and Dr. S.S. Sopimat sir, KC ASI Chairman, to this virtual platform and present in a floral bouquet greeting to our guest of honor in person, Dr. A. Potiwale sir, Registrar KAHER, and Dr. P.D. Patil sir, Director Hospital Development. Dr. P.D. Patil sir, and New Projects KAHER, and next to Dr. N.S. Mansetti madam, Principal Lane Medical College. Now may I request Dr. Vinod Karigi to welcome Dr. R.S. Mudhwar sir, Vice Principal and Medical Superintendent, Dr. Prabhakar Kodet, Hospital Belgavi, and next to Dr. V.M. Patansetti, Vice Principal, JNMC, Belgavi. Now I request Dr. Gupta sir to say a few words about the CME and introduce our chief guest, Dr. Raghuram, President ASC 2020.
Good morning, one and all, and a warm welcome to today's CME program. This will be our 24th consecutive CME, which will be conducting this year. This is the first time that the CME will be conducted online. It will be a unique CME where the postgraduates will be actively participating along with the speakers. The anatomy, the operative steps will be dealt by the postgraduate students, and the faculty will demonstrate the actual operative procedures from Pune, Delhi, and Mangalore. There will be a debate by the postgraduate students on laparoscopic procedures versus open procedures, which will be moderated by all the eminent faculties. And it will be really interesting to hear the views of all our young budding surgeons regarding open and laparoscopic surgery. I would also like to welcome our eminent speakers, Dr. Rajgopal Shenai from KMC, Manipal, Dr. Shailesh Puntambekar from Galaxy Hospital, Pune, Dr. Archit Pandit from Delhi, and Dr. H. Ganesh from Father Muller's Hospital, Mangalore, who will be sharing their expertise with us today. Today, actually, we are very fortunate enough to have Dr. Raghuram sir as our chief guest, but due to some reasons, he is not able to join. So, he has just now called us up and told that he is held up in some really urgent work. So, he has sent all his blessings to the CME. Thank you very much. Now I request Vivek Saudi sir to kindly open the
inaugurate today's function and declare the virtual CME 2020.
क्लिक करना है क्या करना है
राइट बटन क्लिक
और डायरेक्टिंग हियर
here
Now may I request our principal madam to light the lamp virtually.
this would be once
Thank you, madam. Thank you, madam. Now may I request Dr. Vivek Saudi, Vice Chancellor, sir, to address the gathering.
then we can find from here. If there is a mic, we can talk from there.
A very good morning to one and all. Distinguished guests who have joined for this CME virtually. Dr. Raghuram, President ASI 2020. Dr. Abhay Dalvi, President, Vice President ASI 2020. Dr. G. Siddesh, Vice President ASI 2021 and President-elect 2022. Dr. Sopimat, Chairman KSC ASI. The distinguished invited faculty, Dr. Puntambekar, Dr. Archit Pandit, and all other distinguished faculty, my colleagues from the university, Dr. Kotiwale, Dr. V.D. Patil, Dr. Mrs. Mahan Shetty, Dr. Mudor, Dr. Pawar, Dr. Patan Shetty, all my colleagues from the Department of Surgery, spearheaded by Dr. Abhijit Gopte, the organizing secretary, joint organizing secretary, distinguished faculty, guests, delegates, postgraduate students, friends. I am happy to be part of this virtual CME this morning, organized by the Department of Surgery of our Jawaharlal Nehru Medical College, a very prestigious unit of our university. I'm told that the Department of Surgery has been organizing these CMEs for the past 24 years uninterruptedly. This is very creditable that every year for updating the knowledge, skill, learning the latest, knowing from the experts, they are organizing these CMEs, and it has been a very sought after event by the faculty, practicing surgeons, as well as postgraduate students, not only from this part of the country, but from the neighboring states, Maharashtra, Goa, Telangana, Andhra Pradesh, Kerala, and there are so very many faculty who have come and delivered lectures and demonstrated procedures, as well as many of the practicing as well as the postgraduate students have benefited from this CME. This year, as you know, we are all going through this difficult times, COVID pandemic, which is showing no signs of any receding yet. And we still have to be careful, though I think many of the things are resuming back. So this is an attempt to hold the CME virtually. I'm sure on the virtual platform, it will be as interesting and as informative as it used to be on-site CME. So the beginning, I would like to congratulate and compliment the Department of Surgery for organizing this particular CME year after year. And as I said, this is 24th. So I think we can give a big round of applause to the Department of Surgery, the head of the department, and all the faculty members, organizing secretary, joint organizing secretary, and everyone. As you know, continuing medical education or continuing professional development is the order of the day, as we are in a era where there is a rapid, or there is, I would say, explosion of knowledge. Every couple of months, every now and then, there are new treatment modalities, new equipments, the procedures are refined and defined, and every time I think there are opportunities to learn. And unless, of course, we keep ourselves updated with all these recent developments, then only we will be able to give best to our patients. So obviously it is not possible to do everything in one in the 3-year postgraduate training or what we're doing. So the role of CMEs, the role of continuing professional development programs is absolutely essential. And I'm sure from this CME, the faculty as well as the students will immensely benefit and learn from the experts. I'm told that the organizers have carved out a very interesting program, and there is a lot of involvement of postgraduate students actually in participating and in moderating some of these sessions. I'm sure that will not only give them deeper insights, but also give them the confidence and opportunity to directly interact with the experts. I think all the postgraduate students should take advantage of this particular opportunity. Friends, as I said, we are going through a difficult phase. This COVID pandemic has disrupted our lives like never before. And obviously, we have to still navigate this difficult time, surmount the challenges that are in front of us. And therefore, in this time, to sustain ourselves, to survive, and not to just sustain and survive, but to progress and grow, we need to be flexible in our approach. Whatever we are doing, that okay, we have been doing a particular procedure or treating particular patients in a particular manner, that has been as a traditional part. But now with this changing time, changing scenarios, current scenarios, whether it is teaching, learning, whether it is patient care, whether it is examination, or whether it is social gatherings or any other any other thing that we are doing in our day-to-day life. So unless, of course, we adapt to this flexible approach, then only we will be able to come out successfully. Otherwise, it's really going to be difficult. I am aware that because of the pandemic, the elective surgical work, or for that matter, the surgical work has come down. Now, how do you really come back? How do you really resume this surgical work and the patient? So that's what I'm saying, that traditionally, if we've been doing a particular thing in a particular way, now we have to adapt, we have to adapt newer strategies so that I think we are able to get back to our normal work, as well as without compromising the patient safety, as well as the physician or a doctor's safety who are working with us. So having a flexible attitude, having a flexible approach to what we are doing, and of course, adapting change. Change is very constant. Change is the thing which we have to really see that, okay, with times, if we don't change, then we are going to be obsolete. So this approach of flexibility and adapting to change, that will help us overcome these challenges, these difficult times, and I'm sure there is a light at the end of the tunnel. I think we are hearing every day that this vaccine and other things are coming up. So hopefully 2020 was a difficult time, difficult period. We are in the last month of 2020, and hopefully 2021 will bring us cheer, hope, and 2021 will be a better year, leaving this past little difficult year. But let the lessons learned in 2020 not be forgotten. We have really gone through difficult times, and what we were required to do, we were taking the things for granted. And now that this COVID pandemic has taught us certain things, taught us in a hard manner, hard way, but coming in the next year on henceforth, I think we must keep in mind the lessons learned here, and so that similar things or similar, we are always careful and we just don't take the things for granted. With this, I once again congratulate the Department of Surgery for organizing this CME virtually. I welcome the delegates, and I'm sure this is going to be 1.5 days or 2 days. This is going to be an excellent academic feast. So with this, once again, thank you very much and wish you all the very best. Thank you.
Now may I request Vinod Kargi sir to welcome our Vice Principal Dr. Rajesh Pawar. Thank you, sir. As a part and parcel of CME, now I request Dr. Amit Amangi to hand over the responsibility of next, that is 25th CME, to hand over the responsibility to Vinod Kargi.
He hands over to the next
2021.
Okay, good. So he starts preparing from now on.
Right.
Thank you. Now may I request Dr. Amit Amangi to deliver the vote of thanks.
At the outset, I would like to thank our Chancellor and Chairman of the Society, Dr. Kori sir, for engaging us to do this 24 surgical CME at JNMC. We also thank the members of the Board of the Management of KAHER Society for their wholehearted support. I thank our Honorable Vice Chancellor, Dr. Vivek Sahu sir, for his support to conduct the CME. I thank Dr. P. Raghuram sir, President ESI 2020, and Dr. Vivek Sahu sir for accepting our invitation to be online and in-person chief guest occasions, respectively. I also thank our registrar, Dr. V. Kotivali sir, for his constant encouragement and guidance in conducting this event. I also thank Dr. V. Patil sir, Director of Hospital Developments and Projects KAHER, Belgavi, for gracing the occasion with his presence. I have a sense of immense gratitude to our principal, Dr. Mrs. Manchikku Madam, for her inspiration and advice in conducting this CME. I thank Dr. R.S. Mughal sir, Vice Principal, JNMC, and Medical Superintendent, KAHER Hospital, Ramakapuri Hospital, Belgavi. I express my gratitude to our Vice Principals, Dr. Rajesh Pawar sir, and Dr. Vishnu Patel sir, for their constant support and inspiration. No amount of words can express my immense gratitude towards Dr. Abhijit Professor, Organizing Chairman and Professor and HOD of Department of Surgery, JNMC, who has acted as the backbone of this function with his meticulous planning and execution. Sir, your constant guidance and support has made this CME possible. I wish to thank profusely the research persons, Dr. S.S. Sopimat sir, Dr. BELGAVI sir, Dr. Shailesh Gupta sir, Dr. G. Sukesh sir, Dr. Rajgopal Shinoy sir, Dr. Archit Pandit sir, and Dr. Ganesh Shanke, who in spite of the busy, extremely busy schedule, came all the way to share their immense knowledge and experience with all of us. I also thank Dr. Vinod Kargi sir, Organizing Joint Secretary, for his immaculate field work and coordination. Your help has made this function of this CME smooth and efficient. I wish to thank all the members of the organizing committee, staff members of the electrical and engineering department for their cooperation. I also thank the domain department, JNMC Belgavi, for providing us the platform, and also Zydus Further team for providing the online platform. I wholeheartedly thank our departmental clerical staff, Raju, Basu, and Prakash for their wholehearted support to achieve this endeavor. Thank you, one and all.
Thank you, Amit. Now, once again, I thank one and all for attending.
No, here only. Yeah. Department will take it here only. Camera. Photo. Department staff can take one photo.
You must be having some sessions now.
Yes, 11:05, sir. We are just logging in. 11. Okay. We exactly finished. Come.
I request all the staff members.
All staff. Raju.
How you want it?
Just like it.
Will say?
Yeah, you can sit. Good. You can send. Stand behind. This.
Can I have one more?
You can just come.
They want to be, I mean, they can
come in front. Raju.
All PGs.
Karthik, come. Salit.
They can keep this way.
Some. They are.
You can come, just kneel down.
Kneel down. Anushi. Thank you, sir. Come.
Okay, all the best.
Thank you. Okay.
Am I no? No, but we had this, no? In the conference hall.
In our academic council.
A recent Pantodac is the original pantoprazole, and nothing beats the original. A recent lab test revealed that Pantodac has 0% drug loss when it was kept for 2 hours at gastric.
Hello, check.
मैं कॉल करके सर ने कॉल किया था
Zydus schedule, madam. Just line वाले.
I called him inside his lobby.
Yeah, just by the time वो Zydus वाला को 2 मिनट
क्या नाम है?
बोलो नंदा मैडम टॉक करो हेलो Dr. Nanda madam.
Yeah, I'm there, sir.
Yeah. We are very thankful for you logging in for our opening ceremony. If you want to say a few words, because the next session will start in another 2 or 3 minutes, madam.
Yeah, sure. Thank you.
We are very thankful to your company.
Few
And
words.
it is a flawless thing what is going on here. We are thankful to all your team from Belgavi, Karnataka, and Harish and Maharashtra who is there. Harsh. Thank you very much.
Thank you.
Thank you, sir. Sir, I would just like to share a few words with all of you. Good morning. I am Nanda Zuwatkar from Zydus. On behalf of Zydus, I take this opportunity to welcome you all for this academic feast organized by the Surgery Department of KLES. It is our privilege to be associated with this towering institute KLES that believes in we care, we cure. As Zydus is also dedicated to life, research and innovation touching lives has been an integral part of Zydus DNA, and that is the foremost reason for our efforts for providing reliable COVID diagnostic care and making tireless efforts in bringing COVID vaccine at the earliest in recent challenging COVID pandemic times. In KLES's vision to provide quality healthcare, we at Zydus are committed to support you with quality medicines such as Pantodac, Providac, and Duonem. We congratulate Dr. Gokte, Dr. Amit Ammangi and their team for formulating such an interesting program for the benefit of practicing surgeons. Thank you for giving us the opportunity to be your technology partner for this CME. It is indeed our privilege to be associated with this CME year after year. And as this is the 24th year for the CME, I am happy to share this is the 25th year of existence for Zydus. So we have a lot in common. I wish each one of you a great time during this academic feast and have a wonderful day. Thank you so much.
Thank you, madam. Thank you for sharing your views on, and they are very helpful for providing this platform to us.
Our privilege, sir. Have a great CME.
Thank you, madam. Thank you.
Thank you.
Now we move on to the next session. We welcome you back to session 2 of our today's program. We will now proceed with the presentation from Dr. Shailesh Kuntamekar sir. I request Dr. Rahul Penwadekar sir and Dr. Amalkin sir to chair and take over the session.
A very good morning to all. Good morning, Shailesh sir. Sir, it's really a proud privilege to welcome you, sir. Sir is my teacher, mentor, and guru, and he is the medical director of Galaxy Care Laparoscopy Institute. Introducing sir is like shining light on the sun with a candlelight. So I still try the first person to have successfully done uterine transplant from India. He's got India on the world map and the first person to patent the Pune technique of radical hysterectomy. I have only a few words which come to my mind when I describe him. In mine, he is the world's best laparoscopic and robotic surgeon, best teacher, best mentor, and surgeon par excellence. Sir, welcome to you, sir, to the CME.
So good morning, everybody. Thank you, Rahul, for this wonderful introduction. It's always a pleasure to be associated with KLE. And thank you, Dr. Abhijit Gokte and the entire team of surgical department of KLE. So it's a pleasure for me. And for the next few minutes, we are going to share all our experiences and try to understand the anatomy as well as the thoracoscopic procedure. So first I will start my talk on pelvic anatomy. And so can you see my slides?
Yes, sir.
Yes, sir.
Okay. So we are going to see this navigating through the pelvic anatomy and its applied aspects. So we are going to learn anatomy not from the perspective of an anatomist, but from the perspective of a surgeon, how we can utilize the knowledge of anatomy to do good surgery. So there is a huge amount of anatomy, and when you are doing a surgery, what you require, whatever kind of surgery you do, whether you do robotic surgery or whether you do laparoscopic surgery or whether you do single port surgery, the basic foundation of that surgery remains anatomy. Because unless you know the entire anatomy, you will not be able to do the surgery. What is important in laparoscopic surgery is we call a word what is called as predictive anatomy. What is predictive anatomy? Because there is a keyhole through which you look at, you need to understand what is the next structure that is going to come in. And this is what will make you a better surgeon, a better gynecologist, or better any kind of surgery that you're doing. So we call this as predictive anatomy. What lies where, what comes next, and the anticipation should be based on knowledge of anatomy. You have very limited vision, and how you can anticipate these structures and use this knowledge to do good surgery. This is what we are going to do. So this is a book that I have written. All of you can refer to this. This is about the applied surgical principles. We all know that in pelvis, it's a very simple way of understanding the pelvis. The majority of all the organs lie in the center, and the vascular supply comes from the lateral side. So with this single word, you come to know that the vessels which reach the organ in the center travel a long distance before they reach the organ. In that case, if there is any problem, in case of bleeding, when you are operating close to the organ, you can always go on the lateral side and take the vessels. So what are the key things that we are going to look at? We are going to look at sacral promontory, the spaces, the fascias, vessels, and nerves of the pelvis. If you go through Frank Nater's anatomy or Gray's anatomy, the boundaries of pelvis, the pelvic starts at the level of the sacral promontory and goes downwards. It has been classified separately from the abdominal area because it has very specific kind of anatomy as compared to the anatomy in the abdominal cavity. So sacral promontory is probably the most important thing, especially for all the patients in whom you are going to do the surgery in the pelvis, because none of the pathologies of the pelvis will reach up to the pelvic brim. Now, even if you have a large ovarian mass, it will only cross the pelvic brim, but it will not involve the pelvic brim. If you have a large tumor in the rectum, it usually goes up to this area, but it will not go and get attached to the sacral promontory because of the dynamics. Now, what happens at the level of the sacral promontory is that the ureter crosses from the lateral to the medial side, and the bifurcation of the common iliac takes place at the level of the sacral promontory, and there is a presence of superior hypogastric plexus. Now, all this everybody knows, but how to use the knowledge of anatomy? The ureter will cross from the lateral to medial side and remains the most medial tubular structure. So if you remain medial to the ureter, then you are unlikely to damage any internal iliac artery or external iliac artery, because that is the most medial tubular structure. So this is how you use your knowledge. So if you are in trouble, if you remain medial to the ureter, you should not have the fear of having any kind of damage to this area. Now, when you do have a sacral promontory, we should also know that at the level of the sacral promontory, you have the superior hypogastric plexus. This is extremely important when you do rectopexy in males, and when you want to do any kind of prolapse surgery in females, because that is the area where you attach the mesh. And if you damage the superior hypogastric plexus at the level of the sacral promontory, which lies exactly in the middle of the sacral promontory, so when you fix the mesh, you should remain on the lateral side of the superior hypogastric plexus. Otherwise, the patient will have constipation or will have bladder problems. So you should understand that at the level of the sacral promontory, three things happen. Common iliac bifurcates, ureter crosses from the lateral to medial side, and there is a presence of superior hypogastric plexus. So this is the anatomy which is seen underneath the peritoneum. You can see the ureter which is crossing. As I said, if you remain medial to the ureter, there is no way you can damage anything. And the nerves, the hypogastric nerve, always lies medial to the ureter. So if you go ahead and see the first structure, the first tubular structure is the ureter, while the first structure, which is on the most medial side, is the hypogastric nerve. If you remain medial to hypogastric nerve, there is no way you will damage the ureter. If you remain medial to the ureter, there is no way you can damage any vessels. Very simple knowledge of anatomy, helping you to do good surgery. What about the spaces? There are 4 spaces: pararectal space, paravesical space, prevesical space, and rectovaginal space. The pararectal space, as you can really see, is a space which is parallel to the rectum. In terms of anatomical definition of the space, this is not a space, because Gray's anatomy says that space is something which should be lined by the peritoneum. So the pararectal spaces are not lined by the peritoneum. Then how do you call this as a space? They are potential spaces. They are the spaces which are called as the surgical spaces, which are not immediately seen when you do any kind of surgery, and you have to expose these spaces so that you can go ahead and do a good surgery. So this is the anatomy of the pararectal space. The pararectal space, you can see, if you want to open the pararectal space, you cut the peritoneum medial to the infundibulopelvic ligament in females and medial to the peritoneum where you see the ureter, cut the peritoneum, and then if you open the lateral pararectal space, you remain parallel and lateral to the ureter. Always remain parallel and lateral to the ureter. The moment you see parallel and lateral to the ureter, you will see the vessel internal iliac artery, and if you remain parallel and medial to the ureter, you will see the hypogastric nerve. So this is how you should remain. The ureter divides the pararectal space into 2 parts. This is the lateral pararectal space called as the Latchgo space, and deep in this lateral pararectal space lie the S2, 3, 4 nerves. While in the superficial part, the only vessel that crosses the pararectal space is the uterine artery in females and the superior vesical artery in males. So this is the pararectal space. The lateral space is called as a Latchgo space. The medial space is called as the Okabayashi space. So you can see this in a better structure. You can see the lateral space. You can see that in a female, it is the uterine artery. When I show you the anatomy in the males, you'll find that the superior vesical artery is the first branch of the anterior division of the internal iliac, and that is the one which crosses. So you have the lateral pararectal space, which is parallel and lateral to the ureter, bounded by the ureter on the medial side, the internal iliac artery on the lateral side, and the base of it is formed by the uterine artery or the superior vesical artery. The medial pararectal space is called as the Okabayashi space. It lies medial to the ureter and medial to the lateral to the uterosacral in the females and lateral to the rectum in the males. And the only structure which is present over there is the hypogastric nerve, which is coming from the superior hypogastric plexus. So again, the anatomical orientation, you can see the medial pararectal space is parallel and medial to the ureter. It contains the hypogastric, superior hypogastric plexus and the hypogastric nerve. It is this hypogastric nerve which is sympathetic till it is joined by the S234, which I will tell you later. And you can see that in a female, it is a uterine artery which is crossing. So you can see that the first branch of the anterior division of the internal iliac artery, whether it is a uterine artery or a superior vesical artery, it arises almost 6 centimeters after the origin, after the bifurcation. So how do you use this knowledge of anatomy? If you want to ligate the internal iliac artery, don't try to go close to the bifurcation of the common iliac, because at that point there is a posterior division which dips down to supply the gluteal muscles. And if you take the internal iliac artery at the origin, patient will have intermittent claudication of the gluteal region. So you should take it more distally, because there is a long length of the internal iliac artery available for ligation. So again, the knowledge of anatomy helping you to do good surgery, take the internal iliac artery little more distally and you will be able to take it out completely. Similarly, the uterine artery and superior vesical artery travel a long distance before they reach the uterus or before they reach the bladder, indicating that you have a long length of the vessels which can be ligated if there is a bleeding close to the organ which you are remaining. So you can go laterally and take it out. And of course, this is how the anatomy looks like. Now, what about the veins? You can see in relation to the ureter, the superior vesical artery goes anterior to the ureter, or the uterine artery goes anterior to the ureter, while the veins lie below the ureter. So how do you use this knowledge of anatomy? The ureter lies in the fork between the artery on the top and the vein below. If there is an arterial bleeding, then you have to dip down the ureter, because you know that the bleeding is coming from the anterior side. If there is a venous bleeding, just lift up the ureter and you will be able to see the veins coming from down. So this is how you use this knowledge of anatomy to do good surgery. Look, the only branch of the internal iliac artery which is arising on the lateral side is the obturator artery. All the branches of the anterior division lie on the medial side except the obturator artery. Where does it go? It goes below the obturator nerve. And before it goes below the obturator nerve, when you want to do nodal dissection, you should always remain superficial to the obturator nerve, because the obturator artery lies below the nerve. Now, this is how you use this knowledge of anatomy to do good surgery. So you can see the external iliac artery and the internal iliac artery at the level of bifurcation. The reason when you want to ligate the internal iliac artery, you should not be coming in near the bifurcation, because the common iliac vein lies just below the bifurcation, and that's what you're likely to damage. It is in close hugging position. But if you go more distally, you have long length of the internal iliac. You can see this. You have a long length of the internal iliac artery available for ligation. So what is the lesson that we learn? When you want to ligate the internal iliac artery, just go parallel and lateral to the ureter and you will see a very long branch of the internal iliac artery anterior division, which can be easily ligated because it goes towards to become the obliterated hypogastric artery, and you have a natural space which is there between the internal iliac artery and the internal iliac vein. Now, this is something which is very important and relevant for general surgeons. What is corona mortis? Now, this kind of corona mortis that you see is usually seen when you do laparoscopic hernia surgeries. Now, what is corona mortis? It is the circumflex iliac vein, which is a tributary of the external iliac, joins the obturator vein, and the obturator vein lies below the obturator nerve. Why is it called corona mortis? Because if you damage the vein at this level, there is a bleeding from two systems, the external iliac vein as well as the internal iliac vein. So it is called as the corona mortis. Above the vein, which is the circumflex iliac vein, you get the femoral canal. So the hernia, if it takes place through the femoral area, it is above the vein. So there is no way you can damage the corona mortis. The corona mortis is a place where you get this damage when you try to do fixation of the mesh to the arcuate ligament, and that's where you get this. You put a tacker over there and that bleeds considerably. So this is called as the corona mortis because of a communication between the external iliac vein and the internal iliac vein. What about the anatomy in the males? You can see this is how the anatomy looks like. You can see the sacral promontory, the pouch of Douglas, the bladder and the rectum. Again, you see the bladder lies between the two obliterated hypogastric arteries, also called as the median umbilical arteries. When you want to dissect between the rectum and the seminal vesicle, there are two layers of denon-villus fascia. As compared to females, the denon-villus fascia is very well developed in the male, and it was described only in the males. One layer of fascia goes on the rectum, one layer of fascia goes on the seminal vesicle. So there is a nice plane between these two fascias, and this should be dissected with the dictum. Fat belongs to the rectum. So if you remain above the fat, the entire fascias will go down. Now, looking at this anatomy, you can see the only structure which crosses the internal iliac artery and the ureter transversely is the vasa deferentia. So what do you understand by this? The internal iliac artery is always below the vas deferens, and this is an important thing to understand when you want to do any kind of surgery, especially the hernia surgery. So if you remain and if you identify the vas deferens, if you go below the vas deferens, please understand you are likely to damage the internal iliac artery. If you remain anterior to vasa deferentia, then there is no way. So this is how a knowledge of anatomy has to be used to do good surgery. Identify the structure, understand the relevance, understand the structure below and above, and do your surgery. This is what we call it as predictive anatomy. The only nerve which is seen and which is of very, very importance, again related to hernia surgery, is the genital branch of the genitofemoral nerve. If you damage the genital branch of the genitofemoral nerve, it is not a major issue, but the person loses the entire idea of scratching, and that can be sometimes a very, very difficult thing for the patient because the scratching sensation is gone away. So you can see that the entire testicular vessels or the gonadal vessels, even in females, they always lie lateral to the genital branch of the genitofemoral nerve. Again, what do you understand? If you identify the genitofemoral nerve, the genital branch of the genitofemoral nerve, then understand that the testicular vessels are on the lateral side. So don't try to find out the testicular vessels medial to the nerve. The vessels will be always lateral to the nerve. This is how a knowledge of anatomy should be used to do good surgery. This is to give you a complete perspective. You can see the genitofemoral nerve lies on the psoas muscle. You can see the gonadal vessels, which are the testicular vessels, which are lateral to the nerve, and of course the external iliac artery, which is medial to the genitofemoral nerve. Look at the bifurcation. Here also in the males, the same thing happens. The ureter crosses the bifurcation from the lateral to the medial side. So there is no difference in the pelvic anatomy as far as the major structures are concerned. It is only the absence of uterus, but rest of the things like crossing from the lateral to the medial side remains the same. So you can see the ureter crossing from the lateral to the medial side in males on the left side. And again, ureter remains the most medial structure, tubular structure in males. Therefore, if you remain medial to the ureter in males, there is no way you can damage the internal iliac artery. This is how the knowledge is used. If you remain medial to the internal iliac artery, you will never damage the external iliac artery. If you remain medial to the ureter, you will never damage the internal iliac artery. Simple rules of surgery. If you follow them, it is very, very good. Now, this you can see, the only branch of the internal iliac artery which crosses the pararectal space transversely is the superior vesical artery, which you can very, very clearly see. So this is the paravesical space which is seen distal to the superior vesical artery, and the pararectal space which is below that. The only structure that crosses the paravesical and the pararectal space transversely is the superior vesical artery. And therefore, if you remain in the pararectal space, you want to take the superior vesical artery, remain parallel and lateral. The only structure that will prevent you from going downwards is the superior vesical artery, which you can very easily take over. So again, to give you this perspective, you can see the superior vesical artery crossing the ureter anteriorly, while the superior vesical vein goes below the ureter. Same corollary in females. The uterine artery goes anteriorly, the vein goes below, the ureter lies in the fork between the artery and the vein. So if you identify which kind of bleeding is taking place, if it's a venous bleeding, lift up the ureter because it's going to come from below. If it is an arterial bleeding, it is going to come from above the ureter. Again, this knowledge of anatomy will help you to do good surgery. Again, similar structures. If you see that the second branch in the females is the superior vesical artery and the first branch is the uterine artery, I'm just giving you the same perspective again. What about the nerve? The hypogastric nerve, you can see it goes after arising from the superior hypogastric plexus. They go on the posterolateral side. So they lie on the either side like this. So arise at this level and they go on the either side of the rectum. They carry the sympathetic fibers till they are joined by the S234 nerves at the level of the superior vesical vein in males and the uterine vein in females. These S234 nerves are parasympathetic, and once they join, then the nerves which arise from this area are called as the pelvic splanchnic nerve. This inferior hypogastric plexus is called as the Van Frankenhauser's plexus. So what about the median and the medial umbilical ligament? The medial umbilical ligament is a continuation of the internal iliac artery, and this is the obliterated hypogastric artery. Now, what are their relationship? Please understand. Look at the lateral side. The only structure that crosses the obliterated hypogastric artery or the internal iliac is the vasa deferentia. As I told you, you do not go below the vasa. If you go below the vas deferens, then you are likely to damage the internal iliac artery. The median umbilical ligament or the obliterated hypogastric artery form the boundaries of the prevesical space, and the bladder lies between the two medial umbilical ligament. While the median umbilical ligament is nothing but a urachus, which is there and it is in continuation with the bladder. So while we use this knowledge of anatomy, if you want to enter the prevesical space, you should go between the two medial umbilical ligaments. This is very important when you are doing the hernia surgery, especially the extraperitoneal surgery, and that's where you see that you have to be very, very careful and understand when you take down the bladder lies between the two median umbilical ligament. So you can see this is when you want to do a complete hernia surgery. The bladder is completely down, the prostate is completely down, and on the either side you will see the puboprostatic ligaments, which are the continuation of the endopelvic fascia and which attach the bladder to the pubic area. The pubic bone lies above. So how do you understand this knowledge? If you remain at the superficial level in the pubic bone, you will not damage the dorsal venous plexus, which lies between the two puboprostatic ligaments. Now, this is a space which is routinely open for hernia surgery. You have to see the arcuate ligament. You need to see the entire endopelvic fascia, and all the veins lie below the fascia. So never go below the fascia. So this is a complete example. You can see the median umbilical ligament on either side, the bladder completely down over there. And this is the cave of Retzius, or the space of Retzius. This is the pubic symphysis. Understand that the internal iliac artery form the two boundaries of the bladder. Do not go lateral to this, because if you try to go lateral to this, you are likely to damage the external iliac artery. Again, you can see what we have been learning right from the undergraduate days, that what is the difference between the blood supply of the prostate and the blood supply of the thyroid. The blood vessels of the prostate lie between the false capsule, which is formed by the endopelvic fascia, and the true capsule. While in the thyroid, you have the vessels which are lying below the true capsule. So how do you understand this? When you want to approach the prostate, understand that you have to cut the false capsule, and just below the false capsule lies the vessels which are the dorsal venous plexus. So you cannot do the surgery unless you ligate the dorsal venous plexus, especially when you want to do Millin's prostatectomy or a radical prostatectomy. While in thyroid, because the venous plexus or the arterial plexus lies below the true capsule, you can immediately take up the thyroid. And this is what you can very easily understand. The joining of the prostate with the urethra, it is the membranous urethra which is there. So urethra is divided into 4 parts. The prostatic urethra is the urethra which lies in the prostate. Then the membranous urethra is about 2 centimeters. And this is the urethra which is very, very important, because if you do not preserve this urethra, when you do a radical prostatectomy, you are likely to get incontinence. So this is the urethra, which is the membranous urethra. Then comes the bulbous urethra, which is probably the most important urethra, because the sphincters lie along the bulbous urethra. And the 4th part of the urethra is the penile urethra. So for a surgeon, what is important is to understand that the sphincters are around the bulbous urethra, and therefore the membranous urethra, which is 2 centimeters, if you pull it too hard, the bulbous urethra gets pulled and there is damage to the sphincters. Now, this is a little advanced thing for postgraduates, but you need to understand the parts of the urethra which can be very clearly demonstrated when you want to do laparoscopic surgery. Again, to give you the view, you can see the femoral canal, which is just superficial to the corona mortis. You can see the Cooper's ligament over there, and you can see the external vessels, which are the only branches of the external iliac artery, and the vein, which is the inferior hypogastric vessels, which you can see arising from the lateral side. So you can clearly see when you want to do a femoral hernia surgery, what happens is there is a corona mortis which is lying immediately below that, and of course you have to be very, very careful. So you can now see the inferior hypogastric epigastric artery. The inferior epigastric artery is the only branch of the external iliac artery in the entire pelvis. It arises from the posterolateral side of the external iliac artery and goes above the anterior abdominal wall. All of you know the hernia is divided as per, if it is arising from the medial side, it is a direct hernia. If it is arising from the lateral side, then of course it is an indirect hernia. So inferior hypogastric vessels are very important. When you put the port placements, they arise from the external iliac artery and they go reversely towards, they rise above and are in close association with the transversalis fascia. So what is important to understand, the only branch of the external iliac artery in males or females in the pelvis is the inferior hypogastric epigastric artery. So again, you can see I'm trying to show you how you can approach the pararectal space either from the medial side or from the lateral side. In females, you can go away from this area, and these are the various ways. So if you want to approach the pararectal space, this is a video to show you in a female how do you approach. The same approach is done even in males. You can see that you remain, this is the infundibulopelvic ligament over there, and then this is the infundibulopelvic ligament which is ligated. Once you have ligated this, then what you have to identify is the ureter. That's the uterosacral structure which is here, and then go and identify the external iliac artery. So once you identify the external iliac artery, you can see this is, and now you remain parallel and lateral to the ureter. So you can see how easily we can do, just remain parallel to the tubular structures, parallel and lateral to the ureter, and you can see the first thing that you identify is the internal iliac artery. The first branch is the uterine artery, and the first branch in males is the superior vesical artery. How do you dissect the bladder, which is very important. I'm including this because I was told that few gynec residents are also there. So fat belongs to the bladder. This is a concept that you have to use as much as the fat belongs to the rectum. So you go below the fat. As you dissect the bladder, remain below the fat. So when you want to do any kind of hysterectomy, any kind of dissection in females, then the bladder should be dissected with the concept fat belongs to the bladder, remain below the fat, and if you go between the fat and the peritoneum, it's a wrong plane. So always go below the fat. This is the fat, just go below the fat and automatically the bladder goes down. That's the plane between the cervicovesical fascia and the bladder. You can see no use of any energy source and still you can push the bladder completely down. What about the paravesical spaces? This is the dissection of the paravesical space. The pararectal space is a lateral space. The paravesical space is a space parallel to the bladder. When you want to dissect the paravesical space, then you remain parallel to the superior vesical artery or the uterine artery and push everything towards the medial side. So the paravesical space is a space which is lateral to the bladder. Of course, it is called paravesical because it is parallel to the bladder. So you open the space remaining anterior to the to the uterine artery or the superior vesical artery and pushing everything. This is a complete avascular space, and you can see the paravesical space, the base of which is formed by the levator ani muscle. So the pararectal space and the paravesical space, you can see the paravesical space. This is distal to the superior vesical artery, distal to the uterine artery, and always bounded by the internal iliac artery, which is the obliterated hypogastric artery, which is on the lateral side. The medial side is the bladder, and the base is formed by the levator ani muscle. Again, to show you the paravesical space, and you can see the only structure that crosses the pararectal and the paravesical space transversely is the superior vesical artery in males and the uterine artery in females. What about the prevesical space? If you want to enter the prevesical space, suppose you want to do hernia surgery or you want to do any kind of prevesical space, understand that it lies between the two medial umbilical ligaments. You can see both the internal iliac artery or the obliterated hypogastric artery. Don't go lateral to this area. Again, do the dissection with the concept fat belongs to the bladder, so remain above the fat. You push the fat down and the fat will go down, and this will open the paravesical space. So the boundaries are hypogastric arteries on the either side, and push the entire bladder down and go with the concept fat belongs to the bladder. So this is the prevesical space dissection. You can again see in between the two, urachus is the median umbilical ligament. On the either side are the medial umbilical ligament. This is very important when you are doing hernia surgeries. This anatomy is of utmost importance when you do this. Again, to show you the arcuate ligament and of course the Cooper's ligament, which you have to take. The bladder has to be taken completely down. Understand that if you go too deep, then there are veins which are below the fascia. So if you do not open the endopelvic fascia, there is no way you will be able to damage anything. This is again a few pictures to show you a prevesical space. And of course, you can see this. Now, I'm not going to show you the bladder dissection. The bladder dissection has to be done, as I said, with the fat belongs to the rectum. So we will push this. There is one space which a lot of people ask me, what is the Yabuki space? Yabuki space is more important in females. This is a space which is medial to the ureter, and this is the final space through which the hypogastric nerve goes to the bladder. and it is characterized by the presence of the inferior vesical vein. It is also called as a fourth space. So you can see, if you want to dissect the ureter into the utrovesical area, then you should go, this is the endopelvic fascia. How you dissect the ureter, always remain anterior and lateral to the ureter, and you will see that it is the mesentery of the ureter always lies on the medial side. So you can remain anterior to the ureter, and this is how you should be doing this dissection. What about the rectovaginal space or cul-de-sac? It contains two denormilious fascia, and this is what we are going to show you. This is the same way that you will dissect that in males also. When you want to go between in the rectovaginal space, fat belongs to the rectum. There are two layers of denormilious fascia, always remain above the fat. Fat belongs to the rectum, that is the dictum, and you can see how nicely two layers of denormilious fascia can open very, very clearly. Similarly, again to show you the same thing, whenever you want to pull this, pull the rectum, and then if you want to do an abdominoperineal surgery, if you want to do any prosthetic surgery, then this is the plane that you have to go into. You can see very, very clearly, give the stretch on the rectum, remain above the fat. Fat belongs to the rectum. Believe the anatomy, go above the fat. One layer of the denormilious fascia will go with the rectum. One will go with the seminal vesicles or the posterior vaginal wall, either of these which are there. So what are the fascias of the pelvis? There are multiple fascias. Why do you lead to minimal adhesions in laparoscopic surgery? If you ask somebody, why is it that we get less adhesions in laparoscopic surgery? Because we do intrafacial dissections. When you do intrafacial dissection, there is absence of fibroblasts, and because there are no fibroblasts inside the fascia, therefore there are no adhesions. Very, very simple to understand. It is the anatomy that is to be understood completely. So you have this cervicovesical fascia which covers the anterior vaginal wall. The bladder always lies above the cervicovesical fascia. Then you have the denormilious fascia, as I said, and this denormilious fascia lies, we showed you, that is lying below, and of course the endopelvic fascia. So the basic concept is there are no fibroblasts in between the fascias. All the veins lie below the fascias, and therefore if you do not damage the fascias, you will not damage the veins, and neither will you get any kinds of adhesions. Now I'm going to show you something about the ureter. Ureter is something which we all fear, not only the gynecologists. We always say that only gynecologists fear, but even the surgeons at times fear. There are few concepts of the ureter. Ureter carries its own mesentery. And because ureter carries its own mesentery, you can dissect the ureter from the pelvic brim right up to its uretrovesical junction. So the mesentery of the ureter lies on the medial side. It is supplied by the branch of the superior vesicle in males and a branch of the uterine artery in the females. But what is important to understand is that the ureter always carries its own mesentery. Secondly, the ureter lies in the fork between the vein below and the artery above. So whenever you get this, you can identify. For the gynecologist, the ureter is almost 4 centimeters away from the uterosacral, and it lies at the base of the uterosacral. So if you remain anterior to the uterosacral, at the apex of the uterosacral, there is no way you can damage this area. Again, a picture to show you the ureter. You can see the superior vesical artery which is going above, and of course the vein which is going below. So this is very important to understand that it lies in the fork between the two areas. To show you the cervicovesical fascia, and then navigating through the fascias for lateralization of the ureter, which is very, very important to understand. We have already seen this. I'm just going to take you through this video again to show you, when you want to dissect the ureter, do not go on the medial side of the ureter. You should always go on the lateral side of the ureter, because the mesentery lies on the medial side of the ureter. That's the branch of the uterine artery supplying the ureter, also superior vesical artery which supplies the ureter. So the ureter is supplied by the uterine artery and the gonadal vessels at the level of the kidney. And then it carries its own mesentery, and therefore you can completely dissect the ureter from the brim up to the utrovesical junction. So this is the ureter, the posterior cervicovesical ligament and anterior cervicovesical ligament in females is nothing but condensation of the endopelvic fascia, and the ureter goes between these two fascias, saying that this is the ureteric tunnel. Endopelvic fascia is the fascia that covers the pelvic wall. It is a meshwork of collagen. It attaches the bladder and the uterus to the entire organs, and therefore laxity of this fascia can cause the rectum as well as the bladder and the uterus to go into kind of a prolapse. So it is these fascias, if the laxity of which will cause the problems. These are the cervicovesical fascia. Now, key points is that the ureter is the only organ to pierce the endopelvic fascia, identify the fascia, and all the entire veins lie below the fascia. And again, to show you the Denon-Villiers fascia, these are very, very important fascias. Unless you remain and understand this, this is not going to be possible. We have already seen these videos. Again, to show the veins lie between the two layers, and these are the fascias and the relation of the veins. You can see that veins, this is a standard anatomical statement. If you remain superficial to the fascias, the veins always lie below the fascia. So you can see that if there is a fascia, if there is a damage to the fascia, then you can coagulate the fascia rather than doing this. The major arteries, we have already covered: the common iliac artery, the internal iliac artery. And just to give you the perspective, bifurcation of the internal iliac artery is 2 to 3 centimeters below the bifurcation of the common iliac. The first branch arises at 6 centimeters, uterine artery in females and superior vesical artery in males. The only lateral branch of the internal iliac artery is the obturator artery. Finally, the neurovascular anatomy, which is very, very important to understand. I don't think this video is playing. This is the superior hypogastric plexus, which is formed by the postganglionic fibers from L234. These postganglionic fibers form the plexus at the level of the bifurcation of the aorta, from where the two nerves which arise and go on the posterolateral side, also on the lateral side of the rectum, they are called as the hypogastric nerve. They are joined by the S234 nerves at the level of the uterine vein or the superior vesical vein, and there they form the inferior hypogastric plexus, leading to pelvic splanchnic nerves. Which are the nerves which you see in the pelvis? You see the obturator nerve, the genitofemoral nerve, the pelvic splanchnic nerves, and of course the inferior hypogastric plexus. The genitofemoral nerve is likely to get damaged during pelvic and para-aortic, and of course during the hernia surgeries. So you have to be very, very careful. These are the various nerves. You can see the genitofemoral nerve lying lateral to the external iliac artery. The obturator nerve lies between the two bifurcations of the external and the internal iliac artery. The obturator artery and the vein lie below the nerve, and therefore it is very important to remain above the nerve. And of course, you have the inferior hypogastric plexus. So just to show you the demonstration of the nerves, you will see the nerves. This is the lateral pararectal space. Then in this lateral pararectal space, at the lower side, in the deeper part, close to the uterine vein or close to the superior vesical vein, this is the hypogastric nerve, which is lying on the posterolateral side. It is then joined by the S234 nerves, which join at the level of the superior vesical vein. You can see these S234 nerves which join the hypogastric nerve, forming the inferior hypogastric plexus. So these are in close association, and then the pelvic splanchnic nerve goes and supplies the bladder. It is responsible for the potency in males also. So this is how it all looks underneath the peritoneum. When you want to explore the entire retroperitoneum, you have to understand how the structures lie below the peritoneum so that you can do this. This is to give you a complete area. This is the inferior hypogastric plexus and how the pelvic splanchnic nerve go. They have to be preserved in males for potency if you are doing a cystoprostatectomy and if you are doing a prostatectomy, while in females, it is important for bladder function in males. So this is the panoramic view after you complete the dissection. The ureter is the most medial structure. If you remain medial to the ureter, no damage to internal iliac, then comes the internal iliac artery, which goes, the anterior division, which goes and ends as the obliterated hypogastric artery, also called as a medial umbilical ligament. The obturator nerve lies lateral to the artery. So if you remain medial to the obliterated hypogastric artery or the medial umbilical ligament, neither will you damage the obturator nerve nor the external iliac arteries and the vessels. So this is, I'm not going to show you all this, you know about this, and we will not take you through these videos also. I will just show you the final part, which is the pre-vesical, the pre-sacral fascia, which is probably the most important thing. So you see, we are going to show you, now this is the ureter. Now this is the pre-vesical or the pre-sacral fascia. The pre-sacral fascia is the fascia also called as the Walden's fascia. And this Walden's fascia covers the pre-sacral nerves. Now you can see the two nerves, which are the hypogastric nerves. The rectum has to be dissected medial to the nerves because the ureter always lies lateral to the nerves. So you can see the two nerves going on the either side, that is the posterolateral side. You have to remain in between the two nerves, and you can see now if you remain between the two nerves, this is called as the Walden's fascia. One fascia covers the entire area, which is covering the presacral veins. You can see the ureter. The gonadals always lie lateral to the ureter. I'm not going to show you the injuries which take place because these are something which you should learn later on, and I'm not going to show you. What is important to understand, if you understand the anatomy, you will be able to understand the complications which are associated with that. So you see, this was a patient in whom, while doing the surgery, you could see a lumen. If it is a star-shaped lumen, understand it is always the ureter. Because if it is a vessel, it is a plain, simple cutting, and you will see this. So another important thing is to identify the bladder perforation, the bowel perforation, and these are something which are very, very important. I'm not going to take you all through this. Finally, 10 surgical mantras of pelvic dissection. The uterine artery or the superior vesical artery arises 6 centimeters from the bifurcation of the common iliac artery. So you have a long length of the internal iliac artery available for ligation. The artery and the vein, they go anterior and posterior to the ureter, and ureter lies in the fork between these two areas. The pararectal and the paravesical spaces are potential spaces. So you have to open these spaces by remaining parallel to the ureter to open the pararectal space and parallel to the superior vesicle or the superior or the uterine artery to open the in males. The denominous fascia consists of 2 layers, and it is always, there are 2 layers. One goes with the seminal vesicle, one goes with the rectum, the uterosacral, the cardinal ligament, and all the supports of the uterus, they arise as a single fan-shaped structure. The vesico-uterine ligament always has 2 veins, and the hypogastric nerve lie medial to the ureter. So if you dissect medial to the hypogastric nerve in no anterior resection or APR, there is no way you can damage the ureter because the ureter lies lateral to the nerve. The most and the last statement is very important. The anatomical variations of the vascular structures and the nerves are very, very minimal as compared to the gallbladder surgeries that you do. There are very minimal variations. So there is no harm in learning the anatomy, because since there are no variations, it is very, very easy to master. Thank you very much, Rahul. Thank you very much, Dr. Abhijit Kokte and the entire surgical staff for giving me this opportunity. I'm open to asking you if you want to have any questions. I've tried to explain everything as much possible as the applied anatomy. Thank you so much.
So wonderful presentation. As usual, my hairs are standing on their end and it's mesmerizing. Never gets old, sir. And the cherry on the cake is probably the 10 commandments, sir. Beautiful. I think it's all your hard work which has come to that slide, that 10 commandments. Wonderful presentation, sir. We are going to move to the next presentation.
Sir, pardon me, sir. Pardon me, sir. There is a question from. Hello.
Dr. Rahul, can we ask for the dissection at the space of Regius? Dr. Belladiyar.
Sir, we are hard pressed for time, sir. We can ask questions. You can ask for questions. Maybe at the end, if we have time, then we can ask sir to show.
Yeah, that's why I had messaged you, but I think you didn't see that. That's why we are just asking.
Sir is talking on video-assisted thoracoscopic surgery. So this being an interactive CME, two of our postgraduates, Dr. Salil and Dr. Shubhashri, are going to talk. The novice will talk before the master. So the novice will talk for 5 minutes, and it will be followed up by the master. So can we go ahead, sir?
Yeah, Shailesh, congratulations, wonderful presentation.
Thank you, Bellet sir, and I will answer your question in 1 second. It is very important that when you want to do, the ureter is more prone to injury at the ureteric tunnel, and therefore you have to dissect it with a Maryland forceps. That is a much better alternative than to use any kind of energy source at that level.
Thank you.
Shailesh, excellent presentation. Shailesh, wonderful. Thank you. Very nice presentation. Excellent one. Really enjoyed.
Thank you, sir. Thank you.
Sir, mast, sir.
Thank you very much, sir, for the presentation. We now move on to the next part of the session. Now I request Dr. Shailesh, Dr. Salil and Dr. Subhashri to go ahead with their presentation.
So, for the members of the audience, this being an interactive CME, it is our HOD and Dr. Gokte sir's idea that the novice, the PG should talk about the anatomy before the actual procedures is shown by the masters. So Dr. Salil is going to talk about anatomy of the thorax, and Dr. Subhashri is going to talk about what basics of VATS she has understood from the books. Okay, so Dr. Salil is going to talk about anatomy of thorax. Over to you, Salil. Thank you.
Good morning, everyone. I'm Salil Agarwal, second year resident from JNMC Medical College, BELGAVI. I'll here discuss briefly about the thoracic anatomy. Thorax consists of the mediastinum and the pleural cavity, which consists of the lungs, which is protected by the rib cage. Rib cage consists internally it is bounded by the manubrium and the sternum, laterally by the ribs, which attach posteriorly to the thoracic vertebra. Here we can see the cross section, which depicts the mediastinum and the left and right the pleural cavity with the lungs in it. This is the section showing all the layers from the skin towards the lungs, starting from the skin, then the superficial fascia, external intercostal muscles, internal intercostal muscles, innermost intercostal muscles. Between the inner intercostal and the innermost intercostal muscles lies the neurovascular bundle in the costal groove, from superior to inferior in the sequence of vein, artery, and nerve, followed by the endothoracic fascia, parietal pleura, visceral pleura, and the lungs. Between the parietal pleura and the visceral pleura lies the pleural cavity. This shows the direction of the external intercostal muscles and the internal and the innermost intercostal muscles lying between the two ribs, and the relation of the neurovascular bundle in the costal group. Here we can see the divisions of the mediastinum. Mediastinum is divided into superior and inferior mediastinum by the sternal angle anteriorly and the T4 vertebra posteriorly by the imaginary plane. Inferior mediastinum is again divided into anterior medial and posterior mediastinum by the pericardial cavity, which contains the heart. The contents of the superior mediastinum consists of the great vessels, thymus, lymphatic duct, phrenic nerve, vagus nerve, sympathetic nerve. Anterior mediastinum consists of the inferior portion of the thymus, fat connective tissue, lymph nodes, mediastinum branches of internal thoracic vessels, sternopericardial ligaments. Mediastinum consists of pericardial sac containing the heart, origin of great vessels, pulmonary trunk, aorta, pulmonary veins, superior vena cava, inferior vena cava, tracheal bifurcations, and brain bronchi. Whereas the posterior mediastinum consists of the descending thoracic aorta and its branches, azygous and hemiazygous venous system, thoracic duct and cisterna galli, esophagus and esophageal plexus, vagus nerve, thoracic splanchnic nerve, greater, lesser, and least, and lymphatics. Here, this is the cross section of the superior mediastinum, which shows the great vessels in relation to the trachea and the esophagus posteriorly and the sternum anteriorly. This is the superior vena cava, which has the tributaries of the left and right brachiocephalic trunk, and the arch of aorta, which gives brachiocephalic trunk, left common carotid, and the left subclavian artery. This is a section showing the thymus in relation to the great vessels in the superior mediastinum, which encroaches interiorly over the heart, in the inferior part of which encroaches over the heart, lying in the interior mediastinum. This thoracoscopic view of the thymus, which shows, and this is the phrenic nerve, which is taken as the lateral boundary during the thymectomy. This is the cross section of the superior mediastinum, again illuminating the structures lying from interior to the posterior. Anterior is the thymus, brachiocephalic trunks, left and right brachiocephalic trunks, brachiocephalic vein, sorry, right brachiocephalic trunk, left common carotid artery, left vagus nerve, left subclavian artery, trachea, posteriorly esophagus, followed by the thoracic duct and the T3 vertebra. Here, these are the various conditions that can occur in the various mediastinum, the diseases. Anterior mediastinum can have a germ cell tumor, lymphoma, parathyroid lesion, substernal thyroid, and thymoma. Whereas the middle mediastinum can consist of aneurysm, bronchogenic cyst, diaphragmatic hernia, lymphadenopathy, pleuropericardial cyst, and the posterior mediastinum can consist of aneurysm, esophageal diseases, lymphoma, meningocele, and the neurogenic mass. This is the right lateral portion of the thorax cavity after removing the lungs. Here we can see the various structures like the right bronchus, pulmonary artery, pulmonary vein, and the azygous vein, which enters through the T12 opening in the diaphragm, receiving the various tributaries from the superior intercostal veins and the posterior intercostal veins and the subcostal vein, later joined by the hemizygous and accessory hemizygous and hemizygous vein at the T8 levels, which crosses the midline and is lateral moving forward to drain into the superior vena cava. Here we can see the vagus nerve, which passes behind the hilum of the lung, and the phrenic nerve, which passes anteriorly. This is the thoracoscopic view, which here we can see the phrenic nerve, which passes anteriorly through the superior vena cava, and here we can see the same right phrenic nerve passing anteriorly through the hilum, and this is the right one. Here we can see the dissection of the right phrenic nerve, which has been done and clearly. Here we can see the aortopulmonary window and the esophagus lying behind. And this is the aorta and the underlying esophagus, which must be detected posteriorly to assess the subcardinal space. This is the cross section of the left lateral view of the thoracic cavity after removing the left lung, which here also you can see the left bronchus, pulmonary artery and pulmonary veins, and the descending arc of aorta, which lies in the superior mediastinum lateral, followed by the descending thoracic aorta. Here we can see the left phrenic nerve, which is passing through the superior mediastinum lateral and approaching through the pericardial sac and posterior the vagus nerve. Here we can see the left phrenic nerve, which is traveling along the anterior border of the pulmonary window, and here is the left phrenic which passes over the pericardium. Here we can see the esophagus lying laterally to the vertebrae, thoracic vertebrae. Right lung is divided into superior, middle, and inferior lobe by the horizontal fissures and the oblique fissure, whereas the left lung is divided into superior and inferior lobe by the oblique fissure. So these lobes are further divided into bronchopulmonary segments. Superior lobe is divided into 3 bronchopulmonary segments of the right lobe. Apical, anterior, and posterior. Medial lobe is divided into medial and lateral bronchopulmonary segments, whereas the inferior lobe is further divided into 5 bronchopulmonary segments. Superior, anterior, posterior, medial, lateral, and basal segments. Whereas on the left side, the lung, the superior lobe is divided into 5 bronchopulmonary segments: apical, anterior, posterior, superior lingual, and inferior lingual. And whereas the inferior lobe consists of the 5 bronchopulmonary segments, which are superior, anterior, posterior, medial, lateral, and lateral basal segments. And these are the depictions of the various segments. This is fluid recesses are the potential spaces which are formed by the parietal pleura. There are 2 such spaces: postodiaphragmatic recess and the postmediastinal recess, which are more prominent in expiration and helps in the expansion of the lung during inspiration. Here we can see the azygous vein and the hemizygous and the accessory hemizygous crossing at the T8 level to drain into the azygous vein, which later drain into the superior vena cava, and the thoracic duct which enters to the T12 level and in front of the vertebrae, later entering the neck and to drain into the junction of the inferior jugular vein and the left subclavian. Here we can see the azygous vein which travels superiorly lateral to the right border of the thoracic vertebra. This is the sympathetic chain which travels laterally to the thoracic vertebra, traveling along upward continuous at the cervical sympathetic chain, and below is the lumbar sympathetic chain, which has the ganglios lying between the 2 ribs posterior. Here we can see the sympathetic chain with the ganglia in between the 2 ribs. This is a procedure done over here. We have done a uniport assisted video assisted lung resection, in which the lesion was initially identified by the diagnostic thoracoscopy. Same port was extended 5 centimeter to insert a bone manager. Later, the same lesion was taken out through the same bone manager, and the dissection was done and sent for HPA, which came out as adenocarcinoma. Thank you. This is the video of the same procedure that was done uniport assisted video assisted thoracoscopic surgery, where the lesion was taken out through the bone manager that we had inserted in the 5th intercostal space through the port insertion that was extended. This is a lesion that has been identified in the middle lobe of the right lung, which will be taken out through the bone manager. The staples were fired along the region, and the section was done of the same. This is a This is a video for diagnostic radioscopy that we have done. Here we can see the pericardial sac with the heart beating in it. This is the azygous vein traveling later to the thoracovertebra upwards. This is the vertebral column. Patient is in the prone position. Here we can see the sympathetic chain with the ganglions. Below is the diaphragm with the left side is the osteo-diaphragmatic recess. And here under visible we are inserting the fourth insertion. Thank you.
Thank you, Salim. And I now call upon Dr. Shobhashri to talk on her presentation.
Good afternoon, my all present here. I am sitting a junior resident in KAHER Medical College here, presenting to you the introduction of VATS, video assisted thoracic surgery. What is VATS? It is a minimally invasive thoracic surgery that does not use a formal thoracotomy incision. VATS provides adequate visualization despite limited access to the thorax, allowing the procedure to be performed in patients who are debilitated or having marginal pulmonary reserve. Considering the historical background here, in 1882, Forlanen performed the first artificial pneumothorax, including needle in anterior axillary line. In 1910, Hans Christian Jacobus did the creation of artificial pneumothorax by severing adhesions with galvanoportry, collapsing of lung and permitting safe access to pleural space. How is it better than thoracotomy? There's post-op pain is less, a shorter hospital stay, there's duration of chest tube is less, early recovery, especially with patients in COPD and elderly patients, overall cost is less, and the incision is comparatively small. Here we can see the common used incision in video-assisted thoracoscopy, and then on the lateral view, incision 1 is here is the 2 centimeter incision is placed approximately in the 6th intercostal space in the mid-clavicular line. Incision 2 is at the 8th intercostal space. Here the vein thoracoscope is introduced. Incision 3 is the utility incision where most of the dissection is done. This is anterior to the latissimus dorsalis. The image on the right side shows the ideal port placement. The blue one is the ideal port placement, where we can see the hilar vessels and wide angle instrument can be used. If it is the above open one, you can approach directly into the hilar vessels and can injure it, and the below one, where if we go, there will be narrow angle for the instrument usage. The most common anesthesia used here is general endotracheal anesthesia, and it requires ipsilateral pulmonary collapse. Without adequate collapse, pulmonary lesion localization is suboptimal and the risk of pulmonary injury is slightly greater. Then a strategic test tube placement is done with standard endotracheal tube. A patient with large pleural effusion may have already sufficient collapse of ipsilateral lung to allow pleural biopsy, breakdown of population and pleurodesis. Double Newman endotracheal tube intubation is required for all VATS intervention. This is the double Newman endotracheal tube as shown in the first picture. Here you can see the tracheal lumen and the bronchial lumen, and the tracheal cuff and the bronchial cuff. There is the camera incision, and this is the flush port. and this is the video connector. In the second image, you can see the tracheal cuff, which is sitting on the bronchial cuff separately. This image is shown after insertion of a endotracheal tube. There's a W1 endotracheal tube. Optimal insertion has happened into the right bronchus, and here into the trachea, where this limb is seen on the right of the carina. Some of the basic instruments used in VATS, these are some of the basic instruments. There electric coagulator with suction irrigations, electric knife, curved head alloy forceps. Small head alloys, square time forceps, standard Metzenberg forceps, and curved Marshall grasping forceps. Preoperative evaluation marks importance in case of VATS because of cardiac and respiratory functions. It has to be normal to do VATS, and to ensure patient will tolerate one lung ventilation. Then ASA physical status assessment is important, and spirometry, plethysmography, DLCO tests all will assess the lung mechanics and parenchymal functions. The most common positioning that is done for VATS is the lateral decubitus position, and patient is also leaned slightly backward to provide additional access to the anterior intercostal spaces, also to prevent intercostal neurovascular nerve injury and rib injury, which will cause acute or chronic pain post-operative. Exception for this lateral decubitus position is the VATS thymectomy and thoracodorsal sympathectomy. In thymectomy, the position most commonly used approach here is 45 to 60 degree from the supine position, and this gives better access to the anterior mediastinum by allowing gravity to produce dependent displacement of the collapsed lung. The posterior approach for VATS, where both the assistant and surgeon is standing at the posterior to the patient, and the incisions are slightly different for posterior approach, which includes the utility incision is in the 6th or 7th intercostal space instead of 4th intercostal space, which is done in the lateral approach, and the camera port is put in the auscultatory triangle, and thoracoscope here uses 0 degree rather than a 30 degree. The advantage of posterior approach is it's easy access to the posterior hilum and bronchial and the pulmonary artery, and better visualization of the lymph node. The general uses of VATS include both diagnostic and therapeutic uses. The diagnostic uses are as follows. It helps in diagnosing management of idiopathic complex pleural effusive processes and pleural-based masses, diagnosis of peripheral indeterminate pulmonary nodule, diagnosis of idiopathic interstitial lung diseases, and tissue lymph node chest wall biopsy and mediastinal lymph node biopsy. Therapeutic uses are as follows. For VATS, sympathectomy, splanchnicectomy, esophagomyotomy, resection of esophageal diverticulum. Some of these are explained in the further slides. Contraindications of VATS include patients who are unable to tolerate lung isolation or dependent on bilateral ventilation. Intraluminal airway mass is present that will make it difficult for the double lumen tube placement. If there are severe adhesions in the pleural cavity or pleural symphysis, coagulopathy, hemodynamic instability, and severe hypoxia. Thoracoscopic is stage malignancy. Here it can be used to evaluate suspected contralateral lung metastasis, to exclude pleural effusion in otherwise operable cases, to stage lymph node stations, which is not possible through mediastinoscopy, to provide panoramic exploration of entire surface of lung and pleura, and to employ as a first step on patients with undiagnosed peripheral lung nodules associated with lymphadenopathy. VATS for esophagectomy. This is the port placement done for the thoracic esophageal myelectomy. And here are the brief steps which are described in this pictures. Esophagus is lifted and pericardium is taken as a guide for anterior dissection. The subterranean lymph node is lifted to the esophagus. Here the esophagus is encircled with a 2 centimeter Pembroke strain. Care should be taken on to include vagus nerve. And here above the azygous vein, dissection is carried out close to esophagus to prevent recurrent laryngeal nerve injury. A small esophagotomy is performed to advance the stapler leg, and at the end gastrotomy is performed. This is an image showing thoracodorsal sympathectomy and splanchnicectomy, which is more commonly done in the posterior approach. As already described in anatomy, it is most commonly done in patients who are with intractable facial blushing with vasospastic disorders or in pausalgia. Indeterminate pulmonary nodules, as here is shown in this CT images. In this cases, VATS with thoracoscopic wedge resection is often the initial step, and indication includes unknown nodules peripheral in location with a size greater than 10 mm and within 10 mm of pleural space. Indication of VATS in pleural diseases, undiagnosed pleural effusion, treatment of spontaneous pneumothorax, drainage, debridement, decortication of early empyema, chemical and mechanical pleurodesis, evacuation of traumatic and postoperative pneumothorax, biopsy of pleural base lesion, excision of primary lesion of the pleura.
Thank you, Dr. Subhashri. Now again call that Dr. Shailesh Kulkambekar sir. Sir, these are our PGs they have presented there, whatever they learned from the books and related procedures we do. Your expert view and presentation from your side. I think, Shailesh sir.
Yes, sir. Good morning.
We are just seeing, observing how the postgraduate present in front of the masters, and already Dr. Rajgopal Shenai sir and Dr. Siddesh are online. All the masters are there, and I think this is the first time that the postgraduates are presenting in front of all the experts. So first, before you start telling us about VATS, would you please tell us how did you feel it and what was your experience? Because the PGs will want to know what exactly how you felt it.
I think the presentation was very good, and it is an excellent idea, Abhijit, to present these kind of things, because when you tell somebody to present, they make it a point to read, and actually they get the entire idea. Otherwise, just listening doesn't work. So it is very important to have a presentation, tell them to prepare. They had prepared it with good slide, doesn't matter. But the very fact that they have gone through each and every step, including the anatomy, this will be a lifelong learning process for them. Because unless you involve somebody, you cannot get them understand what it is. If you just tell them and teach them, half the people will forget what you're teaching. If you involve them to do this, they will definitely get into more and more learning. Both the presentations, Salil and this Subhashri's presentations were very good. I thoroughly enjoyed. I was listening to both of them. So slides were really good. Most important thing is they talked about the wound retractor. They talked about the anatomy, why it should be given in prone position, where the intercostal vessels lie. These are important things when you want to put an ICD. Where are the intercostal vessels? You should go at the upper border of the lower rib rather than the lower portion. So these are very important things, tips. If somebody is listening to the talk correctly, they are very, very important for even conducting basic procedures like putting an ICD. I think you've done a wonderful job to involve them. It's very nice.
And we should really thank you because you are an authority on VATS and pelvis. And for our postgraduates to talk in front of you, they were really tense. And Rahul has really helped them out. And purposely we took VATS because that is one of the areas which is being neglected in general surgery.
Yes.
So I think you can just say a few words on.
So VATS is something which is one of the most important and easiest things to do by anybody, because there is very little thing that you can damage. But rather than doing CT guided biopsies and CT guided understanding the staging procedures, VATS helps you to do these procedures in a much, much better way. Unfortunately, there are not many people who are doing VATS, so it is for the general surgeons to take it up. because a lot of cases of tuberculosis diagnosis, because in today's era of evidence-based medicine, you should not be giving any anti-tuberculous line of treatment without a histology report. A simple thing like lymph node biopsy, a simple thing like fluorodesis, simple thing like you can do a pleural biopsy and putting in bleomycin in an advanced cancer, or taking a biopsy to give a correct idea, that is much better than doing a CT guided FNAC, because you get a needle test. So I think these are very, very important things, and VATS is very easy to master as compared to laparoscopy, because the structures are very nicely seen and you can do this very easily. So I think if you're taking up VATS as the next thing in general surgery, it would be wonderful. And it should be propagated, sir, more to the physicians, especially the chest physicians and the physicians, that, well, there is anything in the thorax, we will give you the diagnosis. Don't give empirical treatments. That has to be impressed on them.
So there's a question for you. What is your opinion about VATS in retrosternal goiter?
In retrosternal goiter, 90% of the time we are able to excise the retrosternal goiter by hyperextension. That is related to anatomy. The pretracheal fascia blends with the arch of aorta. So understand that the retrosternal goiter will never extend beyond the arch of aorta because of the anatomy and the anatomical location. So any retrosternal goiter by hyperextension usually can be delivered into this area. In my 27 years of practice, I have just done one median thoracotomy to take out the large tumor, but otherwise 95 to 96% of the times we are able to deliver it through the neck. The trick is to go between the pretracheal fascia and the sternomastoid muscle and go down, lower down, and with your finger dissection. Fortunately, no vessels come at the lower pole when you have a retrosternal plunging goiter, because the vessel supply comes only from the inferior thyroid arteries. So you can immediately put your finger inside and enucleate the entire thing without fear of damaging anything. And it never goes below the arch of aorta.
Yes, sir. Sir, for want of time, can we move on to the next?
Yes.
Sir, it was wonderful seeing you, sir. It was wonderful to see the presentation, and thank you so much for taking out time from your so busy schedule, which I know. Thank you so much, sir.
Siddesh sir, any question?
No. Just a small comment. I am very much pleased to be seeing Shailesh here. Nice comments and good opportunity for postgraduates to expose themselves. I saw the presentation, last presentation. VATS is something which we also started doing quite earlier. In fact, we did one of the first earliest presentation in ASICON 94 Pune conference itself.
Yeah.
So I think the main issue with VATS, why it has not become so popular, even though we are aware of it, a lot of people practicing, still it is not very popular among surgeons in surgical departments, is mainly because the anesthesia constraint. We need to encourage our anesthetists to go out and get used to doing the single lung anesthesia. So I think that is where I think the anatomy in thorax, as Shailesh put it, is more fixed compared to abdomen. So the anatomy is more fixed, the organs are few in number, but only thing is the hazards are potentially more dangerous compared to laparoscopy. Of course, laparoscopy also one can get into serious problems. So whereas here we have few important structure, we need to recognize them early enough so that we can avoid the complications. So anatomy is fixed. You get to know the anatomy, then your surgery becomes easier. There are many procedures, as he told, which as surgeons we can definitely practice. And empyema thoracic is something which we are blindly continuing to put only ICD as a management. So initial period itself, if you start doing VATS, many of these patients, the duration of hospitalization can be remarkably reduced. And you get to know the exact diagnosis. And I would go one step ahead. Today, it is not only for histology as a prerequisite to start antitubercular treatment. It is that we need to get the cultures done. Gene expert study is now become a mandatory even by ICMR, and I think now today it has become a mandatory part before starting any anti-tubercular treatment. So that should be the concept we need to be driving home. I think we need to work in harmony with the pulmonology department, the physicians, and most importantly, we need to educate and take our anesthesiologists along with us. Then we can make a progress. Thank you for this opportunity. Thank you, Dr. Gupta.
Thank you very much, Dr. Siddesh sir. Shailesh sir, really it was a pleasure seeing you. And as usual, it was like seeing Virat Kohli batting when in form. But your form is always there. So we are very happy, and the postgraduates and all the undergraduate students are very happy. And we are lucky enough to have Siddesh sir and Dr. Rajgopal Chennai to opine, because they are also great teachers. So I really thank Shailesh sir for sparing his time and talking to our postgraduates and attending this CME. Thank you very much.
Thank you.
Now we'll go to the next session. Yeah, anything? Yeah, we'll go to the next session, which will be case presentations. I just call upon Dr. Amit to go ahead with Dr. Siddesh sir and Dr. Rajgopal Chennai will be there. And the cases to be discussed are mass per abdomen and thyroid.
Thank you, Dr. Gupta sir, for giving an opportunity here. And let the students present the case.
Yes, sir.
And,
Now I call,
to participate.
yes, sir. Now I call upon Dr. B.M. Khadgar sir to give a brief introduction about our speakers, Dr. Rajgopal Chennai sir, and also Dr. G. Siddesh sir.
Good morning, sir. Good morning, sir. And now we welcome Dr. Chennai is a professor of surgery, ex-HOD, and Associate Dean of Karnataka Medical College, Kasturba Medical College, Manipal. He is a renowned surgeon, administrator, author, and a music artist. He has authored 4 textbooks and a wide variety of publications in many international and national journals. He is an avid orator and has delivered guest lectures at many well-known forums. He has been a strong supporter of our yearly CME for the past decade. We welcome you, sir.
Thank you. Thank you very much.
Now I request Dr. Prashant Humble sir to introduce our beloved president, Dr. G. Siddesh sir.
Good afternoon, everyone. Let me take the honor of introducing you to the next speaker, Dr. G. Siddesh. Dr. G. Siddesh is a renowned laparoscopic and GI surgeon in and from Mysore. He has also previously headed the Department of Surgery of JSS Medical College. He is the founder of the Department of Endoscopy, JSS Mysore, and is also well known for his performing therapeutic and vast amount of diagnostic endoscopies. Now, let me take the opportunity and honor to congratulate Dr. G. Siddesh on behalf of the Department of General Surgery, JNMC, for being elected as the President-elect ASI 2022. I welcome you, sir, to the virtual CME. Please, sir.
Thank you. Thank you very much.
Now the PGs will start with the presentation, sir.
Just for a clarification, I hope we have the 2 moderators also along with us.
Yes, sir. Yes, sir. They are
Here, so that they can also chip in.
Yes, sir.
Yeah, we can make the discussion more useful and fruitful. Okay.
Yes, sir. Yes, sir. I'm Dr.
Dr.
Basavaraj Kajgar, sir.
And Prashant.
Yes, sir. Yes, sir.
Okay, right.
So my request to moderators is that let the candidate present the completely and then the summary, and that time we will chip in about the first part of it.
Okay.
The second part is the clinical examination, and of course the investigation management of a total of 30 minutes what have been given to.
Okay, we'll do that.
Good afternoon, everyone. Today we are presenting the case presentation on thyroid. Speaker for this session is Dr. Rajgopal Chennai sir and Siddesh sir. Chairperson is Dr. B.M. Kajgar sir and Prashant Tupal sir. We are presenting a case of 27-year-old married lady, homemaker by occupation from Belgavi, presented with chief complaints of swelling in front of the neck since 5 years. History of presenting illness. Patient was apparently ordered 5 years back, following which she developed swelling in front of the neck, which was initially small in size, gradually increasing the size to the current size. The swelling was not...
Admit will have a briefing how they present. And these moderators are good.
Yeah, Shilpa madam. Shilpa madam from Pune.
Yes,
Go ahead.
The swelling was not associated with pain or any difficulty in swallowing, breathing, or any change in the voice. The patient does not give any history of loss of weight, intolerance to heat, anxiety, tremors, insomnia, diarrhea, or any amenorrhea. There was no history of lethargy, fatigue, weight gain, or intolerance to cold, or constipation or menorrhagia. There is no history of any other swellings in the neck or elsewhere in the body. Past history. No history of any drug intake in the past, no history of irradiation in childhood, and no history of any past medical or surgical history. Personal history. Patient takes mixed diet, appetite is normal, sleep is normal, bowel and bladder habit are regular. No history of tobacco chewing, smoking or alcohol consumption. Menstrual history. Patient attained menarche at age of 14 years. Cycle for regular 3 to 4 days for every 30 days. No history of menorrhagia or oligomenorrhea. Obstetric history. Patient is gravid 2, para 2 and live 1. One child was expired due to an accident, unnatural event. Family history. No history of similar swellings in the family or in the neighborhood, and no history of malignancy in the family. Summarizing the history, a 27-year-old lady with painless, gradually progressive swelling in front of neck, which was not associated with any pain, and no features of any hypothyroidism or hyperthyroidism, and no history of pressure symptoms.
Yeah, before we go to the examination, I would like to ask you a few questions. Whenever you have a swelling in front of the neck, no doubt you will consider thyroid first. And started with a painless swelling. Is it important in thyroid swelling? Pain?
Yes, sir. To rule out any malignancy, sir.
It is a wrong idea. Malignancies do not produce pain.
Unless there is no painful malignancy is only in later stages, and that too anaplastic, very rare. So
don't bring the issue of the pain in thyroid swelling at all. It should come only last, because thyroiditis, recurrence thyroiditis is much more common than malignancies causing pain, acute thyroiditis, etc. So please do not mention that. Progression is important. And you mentioned about no history of rapid increase. I would like to ask you, what is the difference between rapid increase and sudden increase?
Sudden increase means the swelling will increase over the period of many years, sir.
Sudden increase means it is due to hemorrhage, and rapid increase is suggestive of malignancy. So you need to know these two important things. Is it
one
clear?
is maybe in hours and days, couple of days.
Yes.
Other thing should be in weeks. So in weeks, you should be thinking of malignancy. Those which are within a very short period, either hemorrhage or inflammatory swellings. Okay.
I don't know whether I missed. Did you inquire about hoarseness or change in the voice?
No issue of hoarseness or change in the voice.
So that is an important point. Why do you ask that question? Yes. Why do you ask that question?
Any involvement of recurrent laryngeal nerve will cause hoarseness.
Don't say involvement. Please use the proper word, infiltration. Okay. Even in a large goiter, recurrent laryngeal nerve does not get affected. But it can be a very small anaplastic carcinoma can infiltrate, or even for that matter, papillary, etc. So infiltration, that word should come. Okay. Right. Now, did you ask history of difficulty in breathing?
Yes, sir. No history of any difficulty in breathing.
Why is that?
Because compression of the trachea, sir, to rule out any compression of the trachea.
So to say a long-standing goiter, and what is that entity called as?
Tracheomalacia. Due to compression, it will cause tracheomalacia.
And the scabbard trachea. Why trachea gets becomes tracheomalacia? Why? Why not esophagus? Esophagus also is there structure. Yes.
That weakening, that calcium will get lost from the cartilage.
It's the cartilage. Esophagus is a muscular tube. You know, it can maximum, it can get displaced or a mild compression causing some kind of a difficulty in swallowing or a discomfort. Siddesh, you want to ask any questions?
No, I think my point is still more basic. How do you know that this patient is not from an endemic area? Have you asked any particular points?
Yes, he has asked. Yes.
Any swellings in the neighborhood or in the family, sir?
Okay. So one is the geographical area where origin. More important would be neighborhood. Would be a history of irradiation for some other cause important, and if so, when? What is the?
If she was suffering from any Hodgkin's lymphoma in childhood, sir, or stomach enlargement or any tonsils, or
don't bring tonsil into discussion now. It's all a old thing, acne, tonsil and all. Okay, childhood lymphoma is accepted answer. Okay.
Okay.
I would like to ask you one more question here. You have asked history of hyperthyroidism, hypothyroidism, and suggestive of malignancies. That last, any other spelling means what did you keep in mind?
Any other swellings, lymph nodes, sir, any lymph nodes or any bony swellings to rule out malignancy?
So that's the good simple question which you can ask. So maybe at the end of the history, what did you think probably your case?
Multinodular goiter in a euthyroid state.
So probably you can't say at this stage multinodular goiter. Simple say that non-toxic goiter. Very okay. Don't commit at this multinodular, right? You don't know, correct? So you just have to say the goiter, basically goiter. I think at this juncture, examiner may ask you basics of classification of goiter. I think everybody should know. I think we'll not ask it here, right? We'll sit, Dr. Siddesh.
Yeah. Okay. Okay.
Excuse me, sir. I just wanted to ask one question regarding this history. Based on this history, there is actually nothing to suggest that this is a purely a thyroid swelling because there is no history of hyper or hypothyroidism. Can it be also we can give a differential diagnosis of a lipoma or a dermoid cyst in the differential diagnosis? Because those swellings can also occur in the anterior triangle of the neck, sir.
Sir, let us come to common things first, sir. Lipoma and dermoids in the midline here. Theoretically, it is possible, but it is. Let us not discuss that, sir. Maybe if somebody says it can be a parathyroid or etc., that's okay. That's a different issue. But I think we should not consider that. Okay. Yes.
Sometimes examiner may ask, name the other swellings in the midline of the neck.
Correct. Correct.
At that particular time, the student should be aware about the list of the swellings in the order of common occurrence. They should be able to list out. I think that is required to know, but not in this particular case where we are started discussing. Anyway,
a swelling in the region of thyroid when the patient shows has to be considered as a thyroid unless proved otherwise. So lipoma is not common at all in this situation. So it's a suprasternal space. Yes, you can get a suprasternal closed space in the burns. Otherwise, let us not think about that. Yes, sir. Please proceed. Hello.
Dr. Reddy, you are there? Dr. Reddy is present. Oh, madam, please identify yourself and then.
Good afternoon, sir. I am Dr. Jaini here, final surgery PG. I will be continuing with the general examination.
Your voice, you come nearer to the mic or take this one nearer.
Talk little slowly. All the youngsters today speak very fast. Talk slowly in the especially in this virtual platforms. Go little slow while speaking. Okay. Yes, but loudly.
Patient is examined under adequate light and exposure with proper consent. Patient is conscious, cooperative, well-oriented to time, place, and person, moderately built and nourished. BMI is 20.9, afebrile. Vitals, pulse rate 78 beats per minute, regular in rate, rhythm, and volume. Pressure in right radial artery. Blood pressure 110 by 70 mmHg. In right brachial artery in sitting position. Respiratory rate is 16 beats per minute. There is no pallor, icterus, cyanosis, clubbing, fetal edema, or generalized lymphadenopathy. Examination for toxic symptoms. There is no fine tremors, no prepegal myxedema, no acropathy, no eye signs. On inspection, approximately 8 into 6 centimeters solitary globular swelling present in front of neck with well-defined margin, superiorly reaching up to thyroid cartilage, inferiorly 2 centimeters above the sternal notch, laterally up to the anterior border sternocleidomastoid, bilaterally. Swelling moves with the deglutition, lower border is seen, surface appears to be nodular, overlying skin is normal, there is no dilated veins or pulsations. On palpation, patient is made to sit on a stool and examined from behind with neck slightly flexed. Inspectory findings are confirmed. There is no local rise in temperature, non-tender, 8 into 6 centimeters swelling in front of the neck with well-defined margins, inferiorly 2 centimeters from the sternal notch, laterally up to the anterior border of sternocleidomastoid. Both the lobes of the thyroid gland is enlarged, examined using Lahey's method. Surface is bossulated, variable in consistency with firm and soft areas, vertically and horizontally mobile. Swelling moves with deglutition and lower border is clavicle. It is not fixed to the overlying skin. No other palpable swelling in the neck. No palpable cervical lymph nodes. Trachea is felt in midline. Bilateral carotid pulsations are felt normally. There is no thrill. On percussion, manubrium sternae is resonant on percussion. There is no bruit on auscultation. Systemic examination, RS, normal vesicular Britson present bilaterally, no added sounds. CVS S1, S2 normal, there is no murmurs. GCS is 15 by 15, perabdomen soft, non-tender, no organomegaly, bowel sounds present. Case summary, 27-year-old female with painless, gradually progressive swelling in front of neck with no features of hyper or hypothyroidism and no features suggestive of compression. On examination, 8 into 6 centimeters solitary globular swelling with bossulated surface involving both the lobes of the thyroid gland, variable consistency with trachea in midline. Provisional diagnosis, multinodular goiter in a clinically euthyroid state with no features of compression.
Okay, I would like to just quickly ask you in the clinical general physical examination at the end of that. Yeah, general physical examination. Yeah. Next slide. Next slide.
Yes, sir.
Yeah, vitals. I think that's what we have looked for. The very important thing: pulse, blood pressure, etc., etc. Next slide. This lymph node examinations should come along with the at the end of the examination thyroid in your case. Okay. Don't make a statement at this juncture now about the lymph nodes. That
Yes.
after the thyroid examination, like something similar also in the breast. Okay. Next.
Yes.
Next. Again, you want to mention the eye signs and all. In cases of a thyroid swelling, it's better that you look for evidence of thyrotoxicosis in the form of these are the few things. So there could be a little bit of difference of opinion here, but it's better that at the end of the thyroid examination you have looked for hypothyroidism, hyperthyroidism, and lymph nodes, etc. Right?
Yes.
Siddesh, please.
Yeah, I think I agree with him. See, there are examiners, sometimes they will say, why you are not looked for in general examination. But I think when you are talking about examination of thyroid, when it comes, first you need to look for the structure, anatomical extension, those things. Next comes the pressure effects. Next you look for functional dysfunctionemia. So that will come, signs and symptoms will come. I mean, say examination for looking for those signs will come next. So I think that is a better way of putting it across so that the flow of events also will come and you will be presenting in a nice way. It will be grasped by the examiner.
Okay.
Here is, shall I talk about inspection? She was talking about.
Yeah, please go ahead. Janani, put the inspection. Yes.
Yeah. Globular swelling. I am unable to understand what you described as globular. Globular is something like a globe. Globe is a three-dimensional structure. When it is something like a polyp, which is hanging above the surface in a round way, all around in all the three dimensions, if you are able to appreciate, then you describe it as globular. So I think when you're talking essentially on two dimensions, you should say either round, oval, irregular, butterfly, whatever the shape is, if you appreciate. But don't put the third dimension into the description at this stage. I think that is my first opinion, because repeatedly you have been mentioning as globular. I think that will be put into an objection by any examiner. Rajgopal, you can continue. I'll come back later.
Yeah. I think Janani, don't commit like globular here. Okay.
Yes, sir.
I want you to understand right there first is, I ask the patient to extend the neck for always clinical examination of the inspection of the thyroid.
Yes, sir. It becomes prominent. Yes, sir.
Why it become prominent? Tell me.
So it is placed deep to the deep fascia, sir. So on extension, it becomes prominent muscular.
It is not that, because you have a cervical spine which is pushing the gland in front. So it's called as cervical lordosis. Is it okay? Like, tetanus, you get opisthotonus and all that thing. Why? Because the lumbar spines undergo something similar here. So simple extension of the neck will produce thyroid prominent because of cervical lordosis. That is the first thing you should know. Second thing is, yes, avoid that word globular. Otherwise, it is fine. Why a thyroid gland cannot go above the thyroid cartilage? Answer this question.
Fixed to the hyoid bone.
No. Because
Fascia is enclosing.
pretracheal fascia, which is enclosing
thyroid gland. Yes, sir.
Oh, next question I would like to ask is, why thyroid gland can go behind the sternum? Not here, behind the sternum. Quick.
So it is situated behind the sternocleidomastoid muscle.
No.
Again,
behind
same answer.
Behind the sternum. Just now.
Retrosternal extension.
Yeah, that's what I'm asking you. Why it can go behind? Quickly. Tell the pretracheal fascia attachment. What is the attachment in the mediastinum? It can discuss today morning. Just before few minutes back, Dr. Shailesh mentioned how the thyroid can be, with the finger it can come into the, because it is attachment to the adventitia of the arch of the aorta. So in muscular men, strong, this sternomastoid, with the negative pressure, thyroid can become slowly it can go behind the sternum. Okay, next slide. Next. At this juncture, I would like to tell all the postgraduates, for the benefit of, you may take MRCS, FRCS, etc. Please give a glass of water to the patient while swallowing. Because, if everybody says swallow, there is nothing much remaining there to saliva also. Is it clear? So please give a glass of water so that you say that moves with the deglutition. Surface, here you have written nodular, that is fine. I would like to finish off because in the palpation you have written boscillated. What's the difference between these two? Why you will get into trouble? Boscillation means what? Nodular means what?
So yes. When it is irregular, multiple nodules, we call it boscillated.
No, what I mean, nodule means around, say, up to 1 centimeter. Your case, if anybody sees your case, you can easily say nodular. Okay. Oscillations are a big one. Larger one, 3 centimeter, 2.53, like a phyllodes or a polycystic kidney. So it's not like that in your case. Surface is nodular, no dilated veins, no pulsation. That's okay. Can we go to palpation? Yes. I want you to mention the first thing, that is all fine. See, during the inspection now, you know that the gland moves with the deglutition. So now that gland is present on both sides. So now you can straight away say on palpation, thyroid gland is palpable. Nobody can say wrong because you already done the inspection and confirmed. But inspective findings are confirmed. Here, what I want you to mention is the right lobe palpable? Is the left lobe palpable? Is the isthmus palpable? Can you explain that?
Yes, sir. Both the lobes of the thyroid are palpable, sir, along with the isthmus.
See, you have never mentioned that anywhere here. You have only written 8/6. Yeah, that is later you are written in a Lahey's method. Okay, you don't require Lahey's method for this. You have gone behind. You have gone behind the patient. You have started palpating. Then you say right lobe is enlarged, left lobe is enlarged, isthmus is enlarged. What's the advantage of doing a Lahey's method?
So when we have to examine one lobe of the thyroid separately, we use Lahey's method, sir.
If you can, there may be a small nodule, so you are going to
One
rotate.
more prominent we make.
Can you push the gland to the opposite side? Okay, right. Why did you do the Kreil's method?
Sir, to confirm nodularity surface to confirm that.
If there are big nodules like your case, you don't have to do the Kreil's method at all. You have a suspected area. One area, there is a doubtful nodule. There you keep your thumb, ask the
And ask
patient
the
to
patient to
swallow.
swallow. Yes.
So you know the answer. That's fine. Right. Can we go to the next slide? Siddhesh, can you take over? Yes, please.
Yeah, I just wanted to know about this. Though it may not be very relevant in this particular case, I just want to know whether you know about Pemberton sign. How do you do, and then what is its significance?
So in case of retrosternal extension, patient is asked to raise both the hands, both the head and hands touching both the bilateral ears, sir. So that we have to look for congestion on any prominent veins of the chest and upper necks.
Yeah, which were not existing earlier, they appear. What do you think the reason? What happens?
There is an intrathoracic pressure compression of SVC. Great.
Impression of SVC. Okay.
So you have to see the veins as well as sometimes facial puffiness. Congestion. Okay.
Okay. Next thing is about, I had a point about mobility. You have told categorically this is mobile vertically as well as horizontally. Can you make such a drastic with respect to thyroid swelling? I want Rajgopal to just highlight about.
Dr. Janani,
yes.
You can move the thyroid along with the trachea.
Not separately.
That is not called as mobility. Okay, that is it's a whole complex is moving. So that when the both lobes of the thyroid are enlarged, along with the isthmus, that becomes irrelevant. Okay, that significance of the intrinsic mobility is only in a solitary nodule thyroid. In a small nodule, not at all moving, you suspect malignancy. Is it clear?
Yeah, you suspect it to be infiltrating the trachea. That is the significance of an intrinsic mobility. That is a nodule moving in the thyroid gland itself. It's freely moving, especially vertical movement. So horizontal movement, if you are looking at in this particular case, it is always the whole complex moving along with the trachea. So
Janani, what is this? No other palpable swelling in the neck and no palpable cervical lymph nodes. What are the two lines? Hello?
No other lymph node swellings, you know this.
Yeah, what is that second line? No other palpable swelling in the neck means what? You expect everybody to have any swelling in the neck? Not required. Second line is not required. No palpable cervical lymph nodes. Which are the nodes which I have examined specifically?
Level 6, a central group of lymph nodes.
Pretracheal, yes, central and?
Pretracheal and pleural lymph nodes.
And?
Mediastinal.
How can you examine the mediastinal nodes? Lateral group. What is the lateral group called as? 2, 3, 4.
Level 2, 3, 4.
Other name, simple way to remember is called as jugular lymphadenopathy. Just remember that one word. Jugular lymphadenopathy. Along the jugular vein, 2, 3, 4. That's what in fact tonologists also will ask. So that's what we expect to mention here. So you are looked for specifically for a central group as well as lateral group. Yes. And trachea, you are written felt in the midline. That's all right. What is it? Confirmed by Coker's test. What is? Why do you?
There's no pressure.
No. Oh, what is the intention of doing Coker's test? Is it to see the trachea midline or what is it?
This is stridor to rule out stridor. Any compression, we have to do Coker's test.
You know the answer, but then why did you write there? So trachea is felt in the midline. If there's any deviation of the trachea to one side, how can you make out by inspection itself?
The prominence of sternocleidomastoid towards the side of deviation will be
So what is that called as?
trial signs.
That is because the deep fascia relaxes when you push it to one side. This focus test here, it is relevance is important, not required. Okay, which carotids you are feeling?
Common carotids.
Common carotid, where?
So at the level of upper thyroid cartilage, medial to the anterior border sternocleidomastoid muscles.
Below that thyroid cartilage level, because there it bifurcates. Below that.
Yes.
You know any tubercles? Again,
next tubercles. C6.
So no Brui or a no thread. Yes. Can we go to the next slide, Dr. Siddesh? Can we start?
Yeah. Only thing is, so we are talking about mediastinal lymphadenopathy. She mentioned it. Is there any particular clinical sign where we can suspect mediastinal lymphadenopathy?
In retrospect. No.
Yeah, there are two things. One is deviation of the trachea. Even though thyroid gland is not big enough to cause the deviation, the trachea is slightly deviated. That gives suspicion. And then percussion. Percussion, look for percussion. You will have a resonant note over the manubrium, so which may become absent. So these are two things which have been told. So I think we need to know if you're suspecting mediastinal lymph, because you mentioned mediastinal lymphadenopathy.
So I just want to quickly to summarize that whatever methods of palpation when you are asked in the thyroid, first thing you say that I observed it from the front with the neck extension. Cervical lordosis is the one which gives the prominence. That's the first. After the inspection of everything is over, that usual methods of explaining. At the end, you know that it moves with the deglutition, means it is thyroid swelling. So later onwards on palpation, you can straight away say now, on palpation, thyroid gland is palpable. Then you make a mention left lobe, right lobe isthmus, because if you say only one lobe is enlarged, it may amount to a change in the diagnosis like adenoma. So your plan is different. Whereas both lobes are enlarged, isthmus is enlarged. You say it could be obviously a both lobes enlarged disease is either a goiter, colloid goiter, or a multinodular goiter. So question to you: when do you say isthmus is enlarged? How do you say isthmus is enlarged? Janani?
Yes.
Yes or no? If you know, say yes. Otherwise, I will tell the answer. How do you know isthmus is enlarged? Simple.
You know,
what is the relationship of isthmus to the tracheal rings? Then you will get the answer.
Some mobilities along with the trachea.
No. It overlaps which tracheal rings?
Simple. You feel your trachea, you know it is a 2, 3, 4 rings. So if you can't feel that your tracheal rings, that means somebody has isthmus enlarged. And what is the most common site of a nodule?
Isthmus. Junction between the isthmus and the left lobe.
Yes. Isthmolobar junction. Easy. These words should come. Right. So next slide. Systemic examination. In the bones, I don't know whether you mentioned somewhere, skeletal system, what did you examine?
So any skull metastasis on long bone, ends of the long bone in metastasis.
Say usually flat bones, ribs, sternum, skull. Why is that you look for in that?
Metastasis and follicular carcinoma.
So because your case is a multinodular goiter, probably, if at all, can turn into, not that it can also turn into papillary, but follicular is
more common.
So you need to examine that. Siddesh, can we go to the diagnosis and management? Yeah, please go ahead. Yes. So I think these are some of the very fundamentals that why do you say thyroid swelling and why do you say multinodular goiter? Answer the second part. Why do you say multinodular goiter?
So both the lobes of the thyroid gland is enlarged and surface is nodular, so multiple nodules are palpable.
Typically, it is deep to the fascia and both lobes are enlarged. Yes, if you really see a good butterfly, you say butterfly. Otherwise, don't say butterfly. It's not necessary that every thyroid should have a butterfly shape, right? So you clinically, do you suspect any malignancy?
No,
clinically?
sir. No, sir.
Your answer should be no, right? So Siddesh will go to the investigation.
As a routine investigation, CBC, thyroid function test, and X-ray neck, AP, anteroposterior and lateral view, USG neck, FNAC, indirect laryngoscopy recommendation.
Okay, we will sort out. I think in the examination, if the examiner asks you how do you proceed, you need to mention ultrasound first because
To confirm the diagnosis. Yes.
The part, in fact, extended. You can be surgeon's arm, even like so, like a triple assessment in the breast. What is it called in thyroid? What is this?
FNAC, ultrasound neck and clinical thyroid function test.
You have a clinical examination, you have a sonological examination, then you have got a FNAC here, and then you have got a functional status. That is thyroid hormones. Is
Yes,
it clear?
Yes, sir.
Why did you mention indirect laryngoscopy?
So before proceeding for any surgery, we need to confirm about the vocal cord status for documentation. It could be unilateral vocal cord palsy and compensated, so clinically changes was not appreciated.
All right, I know that answer, but today you should better video laryngoscopy. Okay. Video laryngoscopy. So you start with the, no doubt, blood test we need to do. But when a patient comes to you, say, I will straight away send the patient first for a sonological examination, ultrasound. Can you tell me now some important features of ultrasound to say it is, what do you expect a sonologist to tell you?
So we can distinguish between solid and cystic component. If it is only one, multiple nodules or single nodule palpable about the other lobe of the thyroid.
Okay, if the sonologist says only one nodule on the right lobe and left lobe is just enlarged, what do you think suspect is? What do you suspect?
It could be dominant nodule of multiple myelogaitis.
Correct. It is a dominant nodule. That's very important. So what your answers should be when they ask you ultrasound? First of all, to confirm means what is enlarged. You may say a nodule moves with the deglutition. They may tell it's a parathyroid gland enlargement. They may tell a lymph node enlargement. So first is the anatomical organ. Second is the whatever the parts are enlarged. Third is the nodules. And having said the nodule, nature of the nodules. Nature of the nodules. You said solid or cystic, vascular or avascular. These are the few important points should come. Siddesh, please.
Yeah, I think there are much more things today. Sonologists have improved. The quality of sonology machines have improved. I think they get us more information.
Vascularity.
Capsular, see, extracapsular invasion.
Microcalcifications.
And then calcifications. And then Doppler study will tell us about the vascularity. And this is very important to know. Even that may be helpful for surgeon also to know the vessels. So I think these, and also they help. Because Rajgopal, when he told about ultrasound as a first modality, I think you should be taking it as very seriously because it may help you to guide which nodule to take for FNA. So I will tell you the suspicious nodule. You know, if there is a necrotic nodule, I'm sure you would not like to take FNA from that necrotic nodule. You would take a more suspicious nodule which has got variegated appearance. Of course, there are ways of identifying a suspected nodule, So that ultrasound may be helpful in detecting a non-palpable nodule and also suspect a nodule which is to be biopsied. So these are the points, ultrasound.
Yes. So for the benefit of postgraduates, it's a quadruple assessment and is in the thyroid, clinical examination, phonological, histological, and of course, the functional state. Whereas in the breast, it is a triple assessment, right? In the breast. Again, a difference here in the thyroid, we always do FNAC. We never do a true cut. Whereas in the breast, for all the lumps, it is a true cut. You know why true cut is not done in thyroid?
Bleeding, in chance of hemorrhage is more.
Very, very important, very, very vascular. Whereas in breast today, it's always a true cut for a, the reasons. Let's not, thyroids and birads, everybody should know. Will not waste our time today, shortage of time. So this is what is your investigation. Okay, I will give a clue to you. You are done FNAC. Which nodule you will do FNAC? There are 5 nodules. Which one you do? Which nodule you will do FNAC? Come on. if there is any,
largest or solid component with.
you need suspicious nodule. That is what we just now discussed. Suspicious. Which is the suspicion? How do you get a suspicion?
It's a large size with solid component in it. And
You know the most of those criteria of malignant Ames criteria.
Echogenicity, hypoechogenic nodules.
Echogenicity, vascularity, solid
Microcalcification.
component, microcalcification. If it is there, you do that needle. Because when we were PGs, when multinodular goiter, there hardly anything to do because where do you put the needle? Because there was no sonology at all. But now today, sonology, ultrasound guided. Okay, so that's what you do. All right, diagnosis is multinodular goiter. Your case is non-toxic, non-malignant. What do you do?
So we have to proceed with surgery, sir, for this case. Near total thyroidectomy.
Yeah, just hold on 1 minute. What is your indication in your patient?
Sir, already 5 years history is there, sir. It might increase in size.
In 5 years,
Patient is not issue.
Patient may have it for 10 years. It may increase is different issue. I'm just
Secondary
asking.
toxic, sir.
No. Right now there is no toxicity. Every goiter will not go for a toxicity. Yes. What are the size of the nodule in your case? If you have a multinodular goiter of size of 4 centimeter, etc., you can definitely say that chance of malignancy are more, and age criteria in male patient, you can definitely say I will do surgery in the absence of symptoms. Here, in the absence of symptoms. But last but not the least, it's always a patient preference, and cosmetic also forms an indication. Is it clear?
Yes, sir.
Otherwise, what are the indications for thyroid multinodular goiter surgery?
Cosmetic reasons, sir.
Cosmetic,
Pressure
definitely.
symptoms.
Pressure symptoms, yes.
Yes. To rule out retrocranial extensions in large goiter extending.
No, don't bring the word down to rule out and all that. We are straight away asking indication. All the complications of the multinodular goiter are indicated. Starting from the compression, hemorrhage, except toxic, very good. Don't say calcification. Okay, that is not an indication. Last but not the least, as I said, patient preference as well as cosmetic thing. And nodule size more than 4 centimeter means it is a definite indication for surgery.
Yes.
Surgery you mentioned is near total. I think don't get into complications. Say straight away, I will do total thyroidectomy.
Yes.
What do you mean by total thyroidectomy? Quick.
So both the lobes of the thyroid along with the isthmus is removed.
Entire
gland of
thyroid gland to be removed. When you are removing the entire thyroid gland, there could be a possibility of a leave behind some tissue. Where exactly you leave behind?
The tracheoesophageal groove, we can leave little bit tissue.
Near that Berry's ligament, where the recurrent laryngeal nerve enters into the larynx, where there is a cricothyroid joint. Okay, greater cornu. That is the area where it enters. So you may leave. Please remember.
Yes.
That is what people have termed it near total means that is a. So I think accepted answer is total thyroid. Dr. Siddesh, please comment on
Yeah,
this.
I think today with the advent of newer modalities of energy source, we can safely perform total thyroidectomy in most of the cases. But only thing is we need to understand the anatomy very well.
Yes.
The whole idea of doing total thyroidectomy is the surgeon should be more confident of preserving the vital structures. Which are the vital structures you should be aware of? I think generally because time is less. Let me tell the recurrent laryngeal now.
Parathyroidism.
Right. And we go and extend to preserve even the external laryngeal component also. Today we need to go to that level because we are now in the era where we have to preserve the functions. So at the same time give the best of the results of the clearance even in malignancy. So just because of the patient of malignancy, you cannot just take it that he will pay a price of voice strain by injuring the external laryngeal nerve. So these are the points which you need to keep in mind when you say total thyroidectomy. So
Janani, one question to you. Why you do total thyroidectomy? Rather, what are the advantages of total thyroidectomy?
So to prevent any recurrence from
Even though the incidence of recurrence is may up to 5 to 10%, but still one argument is that second, missed or a occult malignancy. The specimen, if it shows a small focus,
redo surgery, vision surgery. So avoid that.
Today that mistake you should less because you have got a good sonologist who can pick up that lesion. Is it clear?
Yes,
So that is the argument. But suppose I ask you, when do you do subtotal in a multinodular goiter? What answer you will give?
Only involved in the one lobe.
When nodule is there only in one lobe.
My question to you was a subtotal, not a Dunhill procedure. What you are telling, please don't confuse the matter. Total is the standard answer we expected from everyone. If your patient is 55, 60-year-old woman, she wants to get a goiter removed, you can still tell her that if there's no malignancy, you can give her an offer because you think of a recurrence after 10 years, 20 years. Remember her age. I have told you the age. Is it clear? Elderly patient. Because you don't want to cause damage to the recurrent lesion nerve and parathyroid. Is it clear?
Yes.
So, then what is Dunhill procedure? Dunhill.
So it is hemithyroidectomy along with lobectomy in the other side, leaving behind 1 to 2 grams.
Don't
use that word.
Yeah, it's a lobectomy. Lobectomy means hemithyroidectomy only. So lobectomy on one side.
Isthmectomy and other side lobectomy with leaving behind 2 grams of tissue.
That whatever that nodule which is there, you take it out so that you leave behind some tissue there for protection of the both nerve as well as. We would like to know from moderators, we have time or should we stay?
I think we will go to the next because.
Yes,
next. In short.
Yes, sir. We'll go to the next case.
Before we go, I will ask one or two any doubts. If one or two doubts, if you have got, you can ask. We can clarify. Otherwise, we'll go to the next case.
Yes,
right?
yes, sir. Yes, sir. Rajgopal, sir, I have one question.
Yeah, please.
Yeah. For euthyroid patient with multinodular goiter or non-toxic MNG, the conventional teaching was subtotal thyroidectomy earlier for UGs and PGs. So now you are saying total thyroidectomy. How many chances of occult malignancies, or how to justify?
Sir, that is what just now we said, sir. Number one, your expertization is very good. Your expertization. Number two, high volume center, where you will not cause damage the nerve as well as parathyroid. The first option is thyroidectomy mentioned. As I mentioned, recurrence rate, yes, definitely 5 to 10%, but may take about 10 years or 20 years. Because if it recurs, then thyroidectomy becomes extremely difficult. That is what is told. And second is missing a primary, missing a occult primary incident. So keeping these two in the mind, only total is mentioned. But if you read the book, asymptomatic MNG, asymptomatic, I said, even a drug trial is given, tablets are given, but a very large nodule may not regress. As we mentioned, that size 4 centimeter, etc. So this is what is expected from the students are these three, sir. Total thyroidectomy. Next is a Dunhill procedure and subtotal. We can't say subtotal is wrong, but younger the patient, 25, 30, they say total, and elderly the patient, they say subtotal.
Thank you, sir. Thank you, sir.
Thank you.
So we'll proceed with the next case, sir.
Yeah, please.
It's a case of mass in the abdomen. The presenters are Dr. Arushi and Dr. Naren. Over to the post-lecture. Introduce yourself.
Good afternoon, everyone. I am Arushi and my colleague Naren. We are presenting a case of mass in the abdomen. We'll start with the history. So, a 46-year-old woman, homemaker by profession, a resident of Belgavi district, belonging to a lower socioeconomic strata, came to the hospital with chief complaints of recurrent pain in the upper abdomen since 11 months and fullness in the abdomen since 7 months. History of presenting illness. So she was apparently well 11 months back when she developed upper abdominal pain, which was sudden in onset, severe aching type, and was radiating to the back. This pain was associated with nausea and vomiting, which was initially for the first 3 days. The vomiting history, there were 2 to 3 episodes which are non-projectile vomiting and containing food particles. She was admitted to a nearby hospital at that time and was managed conservatively for 5 days. Following that, patient was asymptomatic after the hospital stay for 4 months, after which her symptoms of pain recurred but in lesser intensity. She also noticed a fullness in the upper abdomen 4 months back, 4 months after the initial symptoms, which was insidious in onset. Initially, a small area of fullness in the above the umbilicus in the midline, which gradually increased and attained the present size. The size of the swelling has been static since the past 3 months. The swelling is now present in the epigastric region, which extends into the right and the left hypochondriac, umbilical, and hypogastric regions. She complains of occasionally dull aching pain over the swelling, associated with complaints of early satiety as well as increased frequency in urination. Patient was admitted for similar complaints 4 months back and was managed conservatively. Coming to negative history, there was no history of fever, no history of heartburn or regurgitation, no history of any altered bowel habits or passage of black tarry stools, no history of yellow discoloration of eyes, no history of trauma, no history of any significant weight loss or intake of any chronic drugs, no history of similar complaints in any family members, and no history of cough, breathlessness or history related to COVID-19. Past history, she is not a known diabetic or a hypertensive. There is no history of tuberculosis or contact of tuberculosis in the family. She has underwent tubectomy 20 years back and history of open appendicectomy 15 years ago. Coming to personal history, there is no history of any alcohol consumption, cigarette smoking or tobacco chewing. She attained physiological menopause 7 years ago. Menstruation used to be regular for 5 days every month before that. Patient has 2 children, both for full-term normal vaginal delivery, presently alive and healthy. Appetite is reduced and increased frequency of micturition since the past 3 months and unaltered bowel habits. Family history, there is no history of any similar complaints in the family members. So summarizing the history, a 46-year-old female with no comorbidities presented with chief complaints of recurrent upper abdominal pain since 11 months, associated with vomiting and feeling of fullness per abdomen since past 7 months, which initially increased in size to later being constant in size since the past 3 months, associated with early satiety and increased frequency of micturition since past 3 months, with past history of appendicectomy 20 years back and tubectomy 15 years back.
So, Dr. Arushi, no? Arushi.
Yes, sir.
Just to, you know that the case is acute pancreatitis. Why do you say Why do you say that initial attack was pancreatitis?
Sir, because of the symptoms, sir, symptoms of pain and vomiting, and pain was more in the upper abdomen
and
was radiating to the back, sir.
So you know that this patient might have had some kind of an acute pancreatitis, or a recurrent abdominal pain also suggests chronic pancreatitis. Is it clear? The two possibilities are there in this. When you present this case of abdominal pain and a gross swelling in the abdomen for the last 8 or 9 months, correct? That's what you would like to say. Pain radiating to the back. By the admission, hospitalization, can you say is it an acute or chronic?
So the first attack was an acute one, sir. Then she had recurrent pain abdomen. So we can say recurrent acute pancreatitis.
So any time did the evaluation done to rule out a gallstone disease? That is what my first question to you.
Sir, initially the first time USG was done and there were it was essentially normal, sir. There was no gallstones that time. Pancreas was inflamed that time.
If I ask you to know the gallstone pancreatitis, suppose you need not get gallstones in the gallbladder, but you can get a stone in the CBD. Which is the better investigation?
Sir, right, these days, endoscopic.
Don't go to the endoscopic ultrasound level. My question was simple. Ultrasound for gallstones. If you have stone in the CBD, what is the investigation available in your hospital whenever you do a patient has pancreatitis also, CCT abdomen. And if If you still have a further doubt, then you go for other investigation, whether it's an endosono, etc. Right? How do you suspect gallstone pancreatitis?
Sir, history of pain abdomen along with history of flatulence, early satiety.
My question is simple. If it is an alcoholic pancreatitis or if it is a gallstone pancreatitis, what is simple investigation which will help you? Yes, somebody prompted you there. Yes, correct.
Sir, liver function test will elevate.
Yeah, even if the stone has passed through the ampulla you do get elevated levels of alkaline phosphatase, right? Yes. Because of obstruction. So you need to rule out that important thing here because your patient is non-alcoholic, correct?
Yes, sir.
Patient is non-alcoholic and there's no history suggestive of a gallstone disease. So if these two keep it in mind, what else may be the problem in this patient, history-wise? What other history you like to ask? If you think it's a pancreatitis. You understand my question?
Yes, sir. Yes, sir. Sir, any chronic history of drugs, sir? Drug intake?
Like what? In what way chronic drugs cause a feature like this?
Can
you give me example? Okay, give an example.
Sir, azathioprine can cause.
If that patient is taking, she would have told you, na?
Yes, sir. That is not.
He has no other major disease. What are the things you can miss? Okay, quickly. I would like to tell this answer because you should not miss a hypercalcemia due to parathyroid disease. You should not miss hyperlipidemia. Is it clear? Two other things you need to know whenever we discuss about the pancreatitis in a non-alcoholic patient and no biliary tract disease. Siddesh, please take over. Voice. Siddesh. Siddesh. Sound.
So I think history-wise, it becomes difficult to rule out the other rarer causes. It becomes a only question of exclusion. So when there is a positive history of alcohol, we can take it up.
Yes.
Otherwise, if there is a positive history, a patient has been diagnosed earlier, has been advised surgery but postponed, that will give a history. And a past history of jaundice, if the patient is having. So that will also give a clue that it may be a case of gallstone pancreatitis. But at the same time, you need to know alcoholic liver disease overlapping can also have a history of jaundice in the past. So there is another thing is you should know about drug-induced pancreatitis is known. There are certain things you should keep to know about which are the drugs. Autoimmune pancreatitis, pancreaticum divisum, these are all difficult to diagnose at history level, but we need to know the causes and then rule them out. There are other congenital conditions like choledochal cyst. So these things can contribute as a cause for acute pancreatitis. Now let us go ahead and assume that this is a case of acute pancreatitis. What do you think is the subsequent attacks of pain? Subsequent attacks of pain. And now the patient has got admitted with history of early satiety. What do you think is the cause? What do you think is the possible sequence of events? Arush?
Yes, sir. Mostly post attack of pancreatitis, there is a fluid collection in the abdomen, sir.
So you can straight away say it's a beyond 4 weeks. What do you call it as?
Pseudocyst of the pancreas, sir.
So you can always tell probably patient has developed a complication that is maybe compressing the stomach, right? That may be compressing compression in the stomach and give rise to this kind of early satiety. See, in your next slide, you have in the history of present in the next slide, you have mentioned a lot of anatomical quadrants there. I think that should not happen. Where is that? Here.
The patient will never tell you quadrants, you should say essentially upper abdominal.
This the upper abdomen is the best, or even lower abdomen. Don't use these words, especially here. Okay, epigastrium, hypochondrium, umbilical, all that. That's not required.
Let us quickly go to the examination. Then
yes. Whether the patient is diabetic, one question.
No, sir, not diabetic.
Why it is important?
The chronic pancreatitis.
So, and just for a question, in pseudocysts are more common in acute or chronic?
Sir, acute, sir.
No, go and read. Pseudocysts are more common in chronic pancreatitis. Okay. Even though acute pancreatitis is more common. You understand the difference?
Yes, sir.
Yes,
Incidents.
sir.
Okay, please go ahead.
So coming to general physical examination, sir. So patient after obtaining consent, she is examined in a well-lit room. Build is lean, hydration is adequate, and vitals are essentially normal. No pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. And sir, on inspection, per abdomen on inspection, sir, in supine position, there is a mass visible in the epigastric region, extending into the right and left hypochondriac, umbilical, and hypogastric regions. The skin over the swelling appears normal. Umbilicus is displaced downwards and everted, and the swelling moves with respiration. There is a linear healed appendicectomy scar noted in the right iliac fossa. There is also a healed tubectomy scar noted in the suprapubic region. There are no dilated veins, visible pulsations, or visible peristalsis seen. Hernial orifices and bilateral renal angles appear normal. External genitalia normal. Back and spine appear normal on inspection. So on palpation, there is no local rise of temperature or tenderness. The site of the mass is epigastrium extending to the hypogastrium. Vertically, the superior border of the mass is approximately 1 centimeter from the xiphisternum, and inferior border is 6 centimeters below the umbilicus. Horizontally, the swelling is seen extending about 8 centimeter on either side of the midline and epigastric right and left hypochondriac regions, and extending about 8 centimeters to the right and 4 centimeters to the left of the midline and hypogastric region. Overall size of the swelling is around 22 by 15 centimeters, extending from epigastric to hypogastric regions. Shape is hourglass shape, and consistency is firm, tense cystic swelling. The surface of the swelling is felt smooth. On head raising test, mass becomes a little less prominent, which suggests it is an intra-abdominal mass. The salient features on examination: the mass moves with respiration. It is not fluctuant, non-pulsatile. It does not have any intrinsic mobility. Fingers could be insinuated between the mass and coastal margin on both the sides. Organomegaly could not be appreciated due to the huge size of the swelling, and no palpable nodes in the supraclavicular fossa. On percussion, there is a dull note over the mass, and rest of the abdomen is tympanic, and there is no evidence of any free fluid in the abdomen. On auscultation, normal peristaltic sounds heard, but there are no vowel sounds heard over the swelling, and also no bruit heard. So on examination, external genitalia appear normal. Examination of the back and spine appear normal, and on digital rectal examination, no abnormality was detected. Even on pervaginal examination, no abnormality was detected, and other systems examination was essentially normal. In summarizing our case, a 46-year-old female with no medical comorbidities or addictions, with severe pain abdomen with vomiting 11 months ago, which was managed conservatively at that time, followed by development of a diffuse mass involving the epigastric region extending till the hypogastrium since 7 months. A mass is non-tender, firm in consistency, with smooth surface, non-mobile, moves with respiration, becomes less prominent on head raising test, and an otherwise normal parabdominal and systemic examination.
Yeah, so I have can you just go to the inspection slide, please? Inspection. We'll do 1 or 2 small minor things we'll observe, and
Yes.
then so that's a typical such a large swelling. So first, best to use the adjective whenever you describe, na? The very large mass compared to usual thing. And when you talk about the mass, this is not like a swelling in the neck or a breast. Normally, we don't expect it is skin here. You understand, no? What I'm talking. What we need to know is where is the location of the mass. We need to know the size and shape of the mass and extent which you are given. Yes. Then moves with the respiration, and you have written there finger insinuation is possible. So what is your explanation? If it is a pseudocyst, why does it move the respiration? first question.
So because of the huge size, sir, on deep inspiration, it might come into contact with the diaphragm, hence it moves with respiration.
So that is what, in a large cyst like this, it is possible that it may be in contact with the diaphragm, it moves with the respiration, and you are able to get the finger up. So that means to say it is probably not the liver. That's what I wanted to understand, because it's a very large swelling like this. Okay. So next slide, inspection. Those the rest of the things we have given. I just want to, for everyone to realize that genitalia especially is more important in men.
Yes. Yes.
Because you want to rule out a testicular tumor or undescended testis when there is an abdominal mass. Is it clear?
Yes.
Yeah. And you have written rest of the things like, yes, you'd like to definitely know about the coffee pulse, dilated veins, visible pulsation. Why it's important?
So because it is arising from the retroperitoneum, so we have to rule out any aneurysm from the aorta, or if this swelling is in direct contact with the aorta, so
that may be the more explanation. No aneurysm will come like this up to hypogastrium. You understand, no?
Yes.
So yes, it is a differential diagnosis for epigastric area, maybe 4 centimeter, whatever the aortic aneurysm and all may have a pulsation. Okay. So that's all about the inspection. That is okay, I think. Palpation. Yes. Go to the next page. Dr. Hitesh, please add or say anything. Again,
I am only to add that in such a large swelling extending from the epigastrium up to the hypogastrium, I wouldn't expect this to be mobile. So it is something which I am unable to understand. Very careful when you explain that in such a large swelling. Another thing is about the dilated veins. What veins do you expect in this particular patient? What veins? In the abdominal wall?
Sir, if this swelling would have been from the liver, so there might be some element of portal hypertension and dilated abdominal veins and caput medusae.
Yeah, this patient may be having liver disease you are suspecting.
Yes, sir.
So in that case, you would expect portal hypertension. That's right. So even in this lady is not a chronic alcoholic or a chronic liver disease patient, do you expect any particular type of portal hypertension to exist immediately of dilated veins?
Sir, might be due to splenic vein thrombosis.
Yes.
Left-sided portal hypertension.
Okay, so that is what you need to know as a possibility existing. So that is all. I think we'll go ahead because time is less. We'll go
next slide. Yeah, I just want to want you to understand that very large swellings, even if it's a hydronephrosis or a mesenteric cyst, very difficult to elicit the fluctuation. You understand, no? Intra-abdominal stick swellings, most of the time they feel firm, densely. You really can't hold it and fluctuate them, right?
Yes.
That's not required at this stage, right? Okay. And even to the finger insinuation, organomegaly, no palpable nodes. Again, supraclavicular nodes should not come under palpation of the abdomen. Again, we repeat, because what is the best method to palpate the supraclavicular node? What is the best method to palpate the supraclavicular node?
Sir, in the sitting, from behind the patient.
So in other words, you see your patient is lying down. So you complete your palpation, percussion, auscultation, and then go give a specially look for supraclavicular node, right? Okay, especially a case like this, you still have a doubt of pseudo cyst versus any other diagnosis, you keep it in mind. You know that pseudocyst will not give rise to left supraclavicular node, but anything possible?
Any gastric neoplasm?
No. Such a large cyst.
Coming from the pelvis, sir. Any
cystic neoplasm of pancreas.
So it can be a cystic neoplasm of the pancreas. So need to look after also the supraclavicular node if it is a malignant neoplasm, right? And that will come to the differential diagnosis. Yes. Right. Next slide. Yeah. So I think diagnosis.
So we'd like to keep a differential diagnosis first as pseudocyst of pancreas following an acute episode of pancreatitis, and second differential will be cystic neoplasm of pancreas.
So I think what the examiners usually ask is anatomically, why do you say pancreas, and pathologically, why do you say pseudocyst? Can you tell me quickly?
Sir, anatomically, finger insinuation is possible on both the sides. So the cyst might not be arising from the spleen or the liver, and such a large cyst with no history of weight loss or no upper GI symptoms, so it might not be from the stomach also. So
No. Just hold on. When we talk about the cyst, don't bring stomach into discussion at all.
Okay,
what is the pathology you know from the stomach which give rise to cyst? Nothing. Maximum is the liver, large hydatid. So we have ruled out the liver. So
yes,
concentrate on the pancreas there, or a retroperitoneal cyst. You
yes,
understand?
yes,
Retroperitoneal cyst. But at this, a female patient, pseudocyst has to be, because no alcohol and no gallstones, you also like to consider in such a large cyst a cystic neoplasm of the pancreas. That's how you should need to discuss this case. Don't
yes,
bring stomach at all into discussion.
yes, yes.
Why not it's a ovarian cyst if somebody asks a question?
Sir, one thing, it is started in the epigastric region, sir. It has started in the upper abdomen and progressed
And
downward.
lower border. Lower
Yes,
border is
lower
very
border is
nice.
felt, sir. Yes.
Again, somewhere I heard you talking about the spleen. Don't bring spleen into discussion here. You look at that epigastrium and coming down like this. Maximum, if the patient were to relatively young, a large mesenteric cyst, they may ask you. But
yes,
mesenteric cyst in the supracholic compartment or infracholic compartment?
Infracholic.
This most of this mass lesion is in the upper abdomen.
Upper.
Right? How it has gone into the lower abdomen? Is it through the? How it has gone into the lower abdomen? Can you tell me? It is not through the in front of the colon or something. It is a retroperitoneum. Is it
Yes,
clear? It's retroperitoneum. It has go down. So that's why pseudocyst can attain a very large size, right?
Yes.
Very large size. So a differential diagnosis should be in a female patient, cystic neoplasm of the pancreas, also to be considered. Siddesh, please, anything you want to
Yeah,
add?
correct. But only thing about cystic neoplasms is they don't attain such large size. They would have produced more symptoms earlier because it is a very short history which has gone on.
7 months, yes.
Only a short history, unlikely to be. So I think but just want to know the nomenclature wise. The chronic pancreatitis is a term which should be used when there is evidence either clinically or laboratory evidence of exocrine or endocrine deficiency, and also by imaging modality if there is evidence of damage to the pancreatic parenchyma in the form of presence of fibrosis, shrinking of pancreas, or presence of calcification. So these are essential parts of diagnosing a chronic pancreatitis. That is more not only on clinical basis but also by investigative modalities, both clinical as well as, and of course history is important, the patient getting frequent attacks of pain. So in this patient, first attack followed by complication.
Yes.
Thinking in terms of an acute pancreatitis followed by complication. So let us go ahead with the investigations what you have done because time is less.
Yes. Investigations?
So the initial investigation were not available with us. She was treated elsewhere. So now we have done CT scan of the abdomen, sir, which shows a huge pseudocyst rising out of the pancreas, body and tail region of the pancreas.
I just want to ask you 1 or 2 questions.
Yes,
first line of investigation, the examination, you should always tell ultrasound,
yes,
right?
sir.
And what is the advantage of the ultrasound when compared to CT scan? Tell me positive points for ultrasound. One important advantage.
So we can look for gallstones, sir.
Very good, very good. So that is the one thing which you need to know, especially a case like this where there's a non-alcohol. So otherwise, what are the CT findings you need to look for in this patient?
Ultrasound also will help you in diagnosing a Doppler study of the portal venous system. So you need to know if the patient is having a splenic vein thrombosis, collaterals, presence of fundic varices, etc., etc. That is another. And also IVC, intravenous, because such a large cyst might be pressing on the inferior vena cava. We need to know about this. Okay.
Yes. Always when they ask you whether the use of ultrasound or CT, always talk about the purpose in which it has been asked. The purpose is about this cyst. Cyst means swelling. So talk all about the swelling. Next, any causative factor which you can identify, for example, a gallstone or a chronic pancreatitis mentioned stricture, stone, etc. Next, effects of this cyst. When I say effects of the cyst, including portal vein thrombosis, might have had a hemorrhage or rupture into the peritoneal cavity. All those details can be made out by CT scan and ultrasound. So, yes. So what is your finding in your case?
Sir, in our case, there's a large cystic pseudocyst, sir.
Sorry to interrupt, sir. We have actually a session at 2 o'clock, sir.
Okay.
So,
okay, we'll close it now.
Just we would like to have a few tips regarding the treatment from both the speakers for post-graduate about this particular case, sir. So what the management would you advise for?
Management of pseudocyst is mainly only in a symptomatic pseudocyst, symptomatic. So that rule of 6 is no longer considered. That's the first thing. So this is a case of a symptomatic pseudocyst. You have got 2 therapies here. You can do an endoscopic therapy or obviously otherwise a surgical therapy. One important question I would like to ask is, if you want to do an endoscopic therapy, you need to know 3 important things. One is there should not be varices when you put the endoscopic puncture in the posterior wall. If there's a varices, it will bleed. Second thing is there should not be important vessels. Dr. Siddesh mentioned about the vessels there, posterior wall. And third is there should not be gap of more than 1 centimeter between the cyst wall and the stomach wall. If you try to puncture it like that, and then it may definitely give rise to complications. So if these things are not there, you can do an endoscopic cystogastrostomy. Otherwise, just laparoscopic or an open cystogastrostomy. Siddesh?
Yeah, I think you're right there. But today, that is why endosono plays a role in the management of these pseudocysts when you are planning for an endoscopic therapy. I think this can be managed endoscopically, looking at the size, but one need to know that it has to be done under anesthesia. And I think they are showing a case. They are doing laparoscopic method. It is good, but such a huge cyst, if the size may be a criteria where you may not get a adequate size, maybe initially they need to decompress the cyst before getting into peritoneum and then do it. So I think they are doing that.
Yes, sir, the same patient we have done laparoscopic cystogastrostomy.
Very good, very good. I think that's what it is. Very good. So,
again emphasizing whichever cystogastrostomy, the posterior stomach wall and anterior cyst wall should be very, very close.
Less than 1 centimeter.
Yeah, there should not be any vessel even in the open method to puncturing like this. So that's a precaution you need to take. That's all.
Yes.
Biopsy.
Of course, we need to take a biopsy here because, as I mentioned, sometimes what you think as pseudocyst turns to be especially mucinous cystadenomas.
Yes, we are taking a biopsy here. So.
Yeah. Another thing you need to be careful about the presence of vessels. Again, I'm talking about vessels. And if the CT has been done or a Doppler study has delineated a pseudoaneurysm in the wall, one need to be very careful when you are doing a cystogastrostomy. And even I have seen a patient where immediate post-op period, patient had hematemesis. So one of the vessels in the wall, the pseudoaneurysm ruptured and then produced massive hematemesis. So I would like to ask Arushi and Naren, in a patient with the following gastrostomy and a second day or third day patient develops hematemesis and you diagnose a pseudoaneurysm rupture into the cyst wall, the cystogastrostomy stoma. So what do you do your mode of management?
Sir, I'm usually interventional. We'll go for a CT angio and angioembolization if possible, sir.
Yeah, I think that is the answers. Today, interventional radiology gives a very good scope for salvaging post-op complications. So one of the most important things is about vascular this one complications like bleed. So we need to keep this. You have a good relationship with your radiologist today. So
Yes,
it's very essential to help you out.
One question to Arushi, that what is hemosuccus pancreatitis, and one question to another your partner, that is what is a double rupture phenomenon, double rupture.
Sir, hemosuccus pancreaticus is if any pseudoaneurysm coming into contact with the main duct and coming into the duodenum. And
Yes.
So there will be a melena, sir.
Not only melena, hematemesis. And double rupture means aneurysm rupturing into the
cyst and then coming into the stomach.
No. Peritoneal cavity rupture, double rupture through the lesser foramina. Okay, yeah. I think we can.
Thank you, sir. Yes, Dr. Gupta sir would like to speak a few words, sir.
Siddesh sir and Rajgopal Sinha sir, really it was excellent.
Thank
but
you,
because of the paucity time, we otherwise they're just loving it, sir. All the postgraduates are loving the way cases have been handled and all examination questions from the stalwarts. So I really thank Siddesh sir for joining us, and Rajgopal Sinha sir. It was really a pleasure, and our PGs, the smiles on there are telling that they just loved it, sir. Thank you very much.
Yes, it is always a pleasure to be a part of CME program at Belgaum.
Definitely.
It has been a journey for me. I have been part of this program and I have learned quite a lot, because you always keep very interesting discussions, a lot of stalwarts in the field, you keep calling them. So whenever I have visited, I have been a learner more than contributing to the. So it has been nice that to be part of this program. Continue doing the good job. I'm sure you will achieve next year Silver Jubilee celebration, which is a much more bigger way you plan it. Wish you all the best. Thank you.
Thank you very much, sir. Chennai sir, thank you. I would like to have a feedback of because the PGs, how they have presented, sir.
Absolutely.
I'll just, yes, sir. Thank you very much, sir. Thank you both.
Thank you. Bye.
And Shanai sir, we are following your book, sir. Your diagnosis and differential diagnosis for clinical examination of surgery, sir. It has a very nice explanations, boxes, and
thank you.
Absolutely.
Thank you very much, sir. Thank you very much, sir. Thank you.
We will have a break for 10 minutes. We will have a break for 10 minutes. After that, afternoon session will follow.
Anyone can, meanwhile, can someone just do a trial run of my video so that I'm sure that the...
Yes, sir. Yes, sir. Yes, sir.
Sir, this is not telecast.
It's not. It's getting telecasted. No, it's okay. No problem.
You have to open YouTube.
We are doing. We are playing the video live.
Yeah, we are playing the video live. Open the YouTube.
Yes,
can you hear me?
Yes, sir. We can hear you, sir.
Okay, great. Excellent.
Thank you. Hello, YouTube to open. YouTube sir, YouTube ಅಲ್ಲಿ ಅವರು ವಿಡಿಯೋ ಅಪ್ಲೋಡ್ ಮಾಡಿದ್ದಾರೆ, ಅದನ್ನು ಪ್ಲೇ ಮಾಡ್ತಾರೆ and sir will speak. When was it updated? This only, no? Laparoscopic right hemical. One more. Idu anterior section. No, this one. No,
that's 1 year.
Can you share the screen? I can tell you which one.
Sure, sir. I'll just share the screen.
Yeah, this is the first one. That is the laparoscopic right hemicolectomy.
Yes, sir.
And the other one is Below. Yeah, that one. Three easy steps.
That one.
Yeah.
Okay, sir.
Yeah, that one.
Yes.
I'll play this video for your.
Sign in karo. Sign in from your account only.
Yes, sir. यूट्यूब से वीडियो का ट्रायल रन करने वाले
नहीं इधर है ना उनका वीडियो
नहीं
भेजा
हाँ पॉज ना
Archit is there online?
Yes, sir, is there.
He can run down from there. नहीं आ रहा?
Sir, good evening.
Yeah, good evening. Good afternoon, Dr. Archit. How are you?
Sir, good evening. So nice to see you and hear your voice.
Yeah. We are waiting for your. Yeah. So how are you, Archit?
Sir, I'm good, sir. I'm good.
Yeah, good. I think your video is. Yeah, you are. Nice to see you. Very nice to see you. Yeah. आगे है ना वो. Stop it. YouTube बंद करो.
मैं करता हूँ चालू
करेगा.
Monopolar.
Yeah, Archit, I think it is downloaded. Hello.
Today we are going to discuss the surgical anatomy for lower. So you can mute this, sir, and I will speak from here.
Yeah. I think that should be fine. Yeah, that should be fine. I'll call the coach widgets now to start there.
Sure, sir. I just needed to see whether the okay, we can start, sir. We can start.
Yeah. No. Archit, what has happened? Low anterior resection for CA rectum surgical anatomy. On YouTube, we have got the link there, and it is
right, sir.
Yeah, it is playing very nicely. No problem.
Perfect, sir.
Okay.
Perfect, sir.
Yeah. Now we'll call the PGs and we'll start that. I'll just call
and
the chair.
We'll do the presentation first, sir, and then I will do the video.
Yeah. We'll do the presentation first and then the video.
Perfect, sir. Perfect.
Hello, sir. Sir, Nikhil here, sir.
Hi, Nikhil.
Yes, sir. Sir, first
कैसा है?
I'm good, sir. Sir, first we'll
तो
talk
सर
about,
क्यों बोल रहा है मेरे को?
Dr. Archit, we'll talk about colon anatomy, and then we'll talk about CA colon, and then pelvic anatomy, or is it the other way, sir? First, we'll talk about the anatomy together, and then we'll talk about the conditions.
We can do colon ka presentation first.
Okay. Yes.
And then I will do the colon video, and then you can do the rectum presentation, and then we can do the rectum video.
Yes. Thank you, Dr. Archit.
Okay.
Hello, Archit. Hi.
Hey, Rahul.
Archit, नहीं रे, मी डॉक्टर रमेश कोजुलगी.
Oh, sorry, sir.
How are you?
Sir, कैसे हो आप?
Yeah, I'm fine. How are you?
I am good, sir. I'm good. So nice to hear you.
Yeah, even I too. Yeah, how are you now? What about your children?
Yeah, she's fine. She's now 10 years old.
Oh,
so
very good.
We had come for a vacation. I mean, in the whole COVID time, this was the first time I've taken a vacation.
Okay.
So we just came down for a vacation.
Now, whether she has reached Neha's height or
VM sir.
Good to see you.
Sir, good to see you all, sir.
Yeah.
पहाड़ों में किधर हो?
Sir, Uttarakhand. See, this is the view that you get.
Yeah.
How are you, sir? कैसे हो आप?
Now chairperson will take over. Okay.
Okay, sir.
Start the session now.
Sure.
See you then.
Sir, ये copy यहाँ पे करो, मैं mouse problem है. Right? This
the paper, second part of the paper. Program schedule.
I recommend MRF ZLS for sheer comfort and long life. MRF ZLS, जब वो जुबान के केसर और जोश दिनों में इंडिया खिलेगा अपने ही अंदाज बोलो जुबान केसरी डिसीजन पेंडिंग है पर तुम्हारा डिसीजन अभी है तुम्हारे लेवल करके कि आपकी टीम बनाओ और मुझे हराओ.
Good afternoon, everyone. We are having the next session on anatomy and operative steps on Hello.
म्यूट सर यहाँ पे एक म्यूट का आ रहा है ना, ये हमारा ऑप्शन है ना, इसमें म्यूट अदर्स नहीं है क्या? नहीं है ना, म्यूट हो गया. ठीक है.
ನೀವು ವಿಡಿಯೋ ಬಂದ್ ಮಾಡಲ್ಲ, ಇವಾಗ ಬನ್ನಿ ಕಾಣತ್ತಾರೆ.
ಮತ್ತೆ
We will start with the next session. Now, I request Dr. V.M. Patansheti sir to invite and speak a few words about Dr. Archit Pandit.
Good afternoon, everybody. Now the next session is on anatomy and operative steps on laparoscopic hemicolectomy and laparoscopic anterior resection by Dr. Archit Pandit. As all of you know, Dr. Archit Pandit is a laparoscopic colorectal or even the oncosurgeon. He is a alumnus of the JN Medical College. He studied from 1998 to 2008. He is a very well meticulous, planned surgeon in his deeds. Of course, he spent his 10 years in JNMC campus planning for even choosing his partner and even choosing his unit and working. And even after finishing MS also, he has chosen the colleges and the hospitals where he wants to get the experience. So with that experience, even now he performs with the surgeries which are in very meticulous way. And he is well known in the northern belt of the India where river Ganges flows from Uttarakhand till the northeast region. So at present he is in the Uttarakhand and he is going to present us. And he has done many of the fellowships in Korea and Japan. And he is well known laparoscopic surgeon in the Delhi. He is working in the Max Hospital. Over to you, Dr. Archit Pandit.
I couldn't have expected a better introduction than from the person who has actually trained me as a surgeon. So if there are postgraduates who don't know, Dr. VM sir, I still call him sir only because He was my immediate senior, and he taught me everything, right from dressings to everything. So everything I owe is all to our JNMC teachers, my seniors, colleagues, and thank you very much. It's an honor to be a part of this CME program here. I think the phenomenal thing that happened this CME was to introduce the postgraduates into making presentations, and because we had a wonderful group, four of the postgraduates, and we had a wonderful group, and we were doing all the discussions on the group. And so I would rather say that it is all the postgraduates who are doing a wonderful job, and the teachers. I would just simply give the platform to the postgraduates to present the seminar, and then we'll go ahead with the video presentation.
Thank you, Dr. Archit, sir. I will be dealing with the surgical anatomy of colon under the guidance of Dr. Archit Pandit, and the moderator for present session is Dr. V.M. Patanchetti, sir, and Dr. Pramod Patil, sir, and myself, Dr. Nikhil, final year postgraduate in Department of General Surgery. So we all know the anatomy of colon, but what we need to know is the surgical anatomy. So there are few things that we need to know in the surgical anatomy. Firstly, the mesocolon. It's a fold of peritoneum which suspends the colon from posterior abdominal wall. Now, why is it important? When there is a ligation during the surgery of during hemicolectomy, there is the root of mesocolon, and closer to the root of mesocolon, when there is ligation, that provides more of the lymphovascular clearance. If we ligate away from the root of the mesocolon, the lymphovascular clearance is slightly lesser, and we can say it is more of an incomplete surgery. So coming to the root of transverse mesocolon, the root of transverse mesocolon is on the posterior abdominal wall, which is horizontal and with an upward inclination towards the left. From right to left, it is attached to the anterior aspect of the head and anterior border of pancreas in relation by its upper surface with liver, gallbladder, greater curvature of stomach, and lower surface of spleen by its undersurface. With the small intestine by its anterior surface, and posteriorly it is in relation from right to left with descending colon, descending portion of the duodenum and head of pancreas. A small note about the root of mesentery of ascending colon. It extends from IC junction to ligament of Treats. So now let's move on to the root of mesocolon. It's a triangular fold of peritoneum which suspends the sigmoid colon from the root of sigmoid mesocolon onto the pelvic wall. It takes the form of an inverted V. The apex of it lies at the division of left common iliac artery. And the intersigmoid recess of peritoneum is found at the apex of V-shaped attachment, and left ureter is behind it. The left limb of the V shape of the attachment along the upper half of the left iliac artery, external iliac artery, and the right limb is posterior to the pelvic wall, extending downwards medially from the apex and median plane of sacrum up to the level of S3 vertebra. So next, let's move on to the arterial and venous supply. So the two dominant arterial system, that is the superior mesenteric artery and the inferior mesenteric artery. Superior mesenteric artery arises from the aorta at the level 1, L1 vertebra, and terminates into right colic artery and iliocolic artery. Iliocolic artery has the least anatomic variations with superior and inferior branches. The right colic artery may also arise either from iliocolic artery or middle colic artery and may be absent in up to 18%. And middle colic artery has the maximum variations, and it originates near the inferior border of the pancreas and supply proximal 2/3 of the transverse colon, and it's absent up to 35% of the population. So the left branch of the middle colic artery may supply the territory, which is also supplied by the left colic artery. And this collateral is called as the marginal artery, and this is a very inconsistent channel and usually referred as watershed area. So coming to the venous supply, it usually mirrors the arterial system, and venous drainage from right colon, proximal transverse colon empties into superior mesenteric vein. The distal transverse colon, descending colon, sigmoid drains into inferior mesenteric vein. So the most important venous anatomy we should know in case of right hemicolectomy is the confluence of right gastroepiploic vein, the superior right colic vein, and anterior superior pancreatoduodenal vein. This confluence is known as the gastrocolic trunk of Henle. During the dissection, for a good vascular clearance, this has to be ligated and dissected. Coming to the lymphatic supply, the wall of the large bowel is supplied with rich network of lymphatic capillaries that drain to extramural channels through the arterials, along the arterial supply. So the lymphatics from the colon drain into para-aortic nodes, empties into cisternae chyli. So there are basically 4 levels. The epiploic lymph nodes are located near the bowel wall, and the paracolic are adjacent to the marginal artery, and the intermediate lymph nodes are along the main branches, that is the left colic, the ileocolic, middle colic, and right colic. And the most important is the central nodes, because they are very important for a complete vascular lymphovascular clearance, and they are present near the SMA and IMA. So the lymph node invasion is the most important prognostic factor. In fact, more the lymph node invasion is a poorer prognostic factor, and a minimum of 12 to 15 lymph nodes should be removed in a proper, complete right hemicolectomy. So let's move on to the concept of CME and CVL. CME is basically the complete mesocolic excision. So this dissection aims to ligate the vessels at their origin of the arteries. That is the central vascular ligation. These two concepts are very important to achieve a complete lymphovascular clearance, to reduce the recurrence, and so this basically provides a better pathologic specimen quality, which includes all lymphovascular pathways, nodal components with respect to embryological anatomy. This concept was an extension of the concept of total mesorectal excision in case of CA rectum, which provided an improved 5-year survival rate. For it improved from 25% to 75%, which is a very significant improvement, and the local recurrence also was decreased. So for this concept, we need to know the embryological anatomic planes, that is the extrafacial plane between the mesocolon and the retroperitoneum, called as Toll's fascia. So there are 3 important points we need to know about the Toll's fascia. One is the mesocolon starts at the ileocecal level and continues up to rectosigmoid level. And the mesocolon of transverse colon and mobile part of the sigmoid mesocolon does not include the Toll's fascia. And confluence of sigmoid mesocolon and mesorectum is the inception of proximal rectum. These are very important when we are doing a right hemicolectomy. It is reported in about 4% of the right colon cancers that the metastasis is to the central mesocolic lymph nodes. So in an attempt to improve the number of resected lymph nodes and completeness of the right CA colon resection, there is the concept of D3 lymphadenectomy. So there are totally 3 levels, D1, D2, D3. Here in the picture you can see. So D1 is primarily near the wall of the bowel, and D2 is at the intermediate nodes, and D3 is at the central nodes. So during the resection, during the ligation of the vessels, we need to go as close as to the origin of the arteries and then ligate so as to achieve a complete clearance. Thank you. Next, I would like to call Dr. Amaya to complete the CA colon clinical features and investigations.
Share only, no? Wait. It's okay.
You sit open and give.
Yes, sir.
The cable goes like it
हाँ sir. आगे sir.
This is not mine. This is not mine.
That is not yours.
That is rectum.
Okay, open this again. Now open your presentation.
Oh, that only open, sir.
Okay.
They fed it in a wrong name. Open that.
This one.
Close it. Close. Pen drive है तेरे पास.
It is not copied. Meanwhile, Archit, if you want to add anything, you can add.
So I think till the time the presentation is being formulated, I'll present the video because video is more related to the surgical anatomy and it will not cause lots of time also.
Yeah, you can go ahead.
So can someone open
Yeah.
the YouTube there?
Yes, sir.
Yeah.
Run the video. Give it to him. Give it to him.
Not that. This is
Share one.
anterior section.
This
The
is
private one.
3 tips.
Okay. This one.
The hemicolectomy one.
Yes, sir.
Someone needs to share the screen. I cannot see the screen.
Just a second, sir.
So meanwhile, I'll till the time we are setting up the video, I think in surgical anatomy for hemicolectomy, the most important things that we need to understand is complete mesocolic excision. That is, we need to remain outside this fascia in order to take all the fibrofatty tissue and all the lymphatic channels, as Dr. Nikhil just mentioned. And the second concept is ligating the vessels right at the root of the mesentery. And that is why it is important to understand the root of the mesentery. So basically, we'll be looking at 3 steps in our video. First is achieving the mesocolic excision. And I have just done this surgery around 6 days back. Hence, I thought I'll do it with the scissors so that to make the postgraduates understand that if you're in the right plane, it will never ever bleed. Okay, so and second step, what we are going to see is identifying the root of mesentery, then taking the ileocolic vessel and the middle colic vessel, as you can see. So let's see how to achieve the mesocolic fascia. This is a medial to lateral dissection. You lift up the transverse colon or the hepatic flexion, and what you see through that is the duodenum. The red arrow marks the duodenum, the second and the third part of the duodenum. And I'm doing this dissection with just scissors, the initial part. Of course, it takes more time. And this is the unedited part of the whole video. Now, you can see that we are just achieving the mesocolic fascia with just the scissors. The green part is the mesocolic fascia, which separates the Girota's fascia, which goes below the scissors, from the colon. The colon is lifted up. The fat that you are seeing above the scissors is the mesocolon. The fat you are seeing below the scissors is the Girota's fascia, that is the kidney. So we have pushed the duodenum down. Now we are pushing the Girota's fascia down and going to the lateral abdominal wall from the medial root. Okay, and what we are lifting up is the colon and the mesocolon. right? So you can see these fibrofatty tissue. Again, we have still not used any bipolar, any cautery, not even any energy source, not even the ligashore or the harmonic. This is just to tell the postgraduates that if you are in the right plane, nothing in this world is going to bleed. Okay, so the most important thing in performing this right hemicolectomy is to achieve this mesocolic fascia. Now again, we are dissecting around the third part of the duodenum. That is where the ureters will also come and go into the Gerota's fascia. So again, I'm just going to push the fascia down and then cut the remaining mesocolic loose fibroalveolar tissue. So again, above the scissors is the mesocolon fat, the colonic fat, the mesentery of the colon, everything is up. Everything is above the scissors, and below is the Gerota's fascia, the kidney, the ureters automatically go down. You don't need to identify them if the Gerota is down. Now we are again incising some part of the mesentery and then again taking the mesocolic fascia, cutting the mesocolic fascia. So after the initial part, just to make everything clear, now we are going to use some kind of an energy source. I prefer to use a ligashore. That is again so that we can do these things faster. Again, you can see I've just incised the mesocolic fascia. Again, below is the Gerotas, and we are going to the lateral abdominal wall. I hope the vision is clear there.
Yes, yes.
Okay. So you can just appreciate it's more of a blunt dissection along with a sharp dissection. So blunt dissection and sharp dissection. And still we are underneath the whole envelope. This is the complete mesocolic excision. We are just remaining next to the mesocolon. We are not going into the mesentery. If you go into the mesentery, you will encounter veins and arteries. We are staying out of it. Now the second step. Now you just saw the mesocolic excision. Now the second step is identifying the ileocolic. So to identify the ileocolic, you have to first identify the root of the mesentery. Now, this is the root of the mesentery, as Dr. Nikhil mentioned, that it travels from the ligament of Treats for the ascending colon, ligament of Treats up to the ileocecal junction. So when you lift the ascending colon or the cecum, what gets lifted? Which artery gets lifted? Any of the postgraduates can tell? It is the ileocolic or the superior mesenteric artery. Now, all the vessels to the right of the superior mesenteric artery will supply the large bowel, that is the ascending colon and the transverse colon, and any vessel which runs left of the superior mesenteric artery will supply the small bowel. So we never have to go to the left of the mesentery. We always have to stay right of the mesentery or on the superior mesenteric artery or bang on the superior mesenteric vein. So again, what gets lifted? You can see there is a tissue which is getting lifted underneath my left arm, left hand grasper. That is the ileocolic vessel. So I'm going underneath the ileocolic vessel. I'm going to identify the superior mesenteric vein, and we are going to perform a D2 lymphadenectomy. I generally don't do a D3 lymphadenectomy. D3 lymphadenectomy is basically performed by the Japanese surgeon. So you can see now you can see the superior mesenteric vein. You can see the superior mesenteric vein, right? Underneath the ligashore device. I have just lifted up. So you can see the blue arrow that is on the superior mesenteric vein. Okay, I hope it is clear over there because I can see it. Right. Okay, sir. So now what takes off from the superior mesenteric vein when going from below upwards? The first branch that is going to take off is going to be the ileocolic vessel, the ileocolic vein, and from the superior mesenteric artery will be the ileocolic artery. As and when we go up towards the duodenum, we are going to find the right colic and the middle colic. However, in around 35 to 40% of patients, right colic is generally absent, and we also found it to be absent even in this patient also. Now we have come back and we are completing the mesocolic excision. You can see all the fibrofatty tissue going down. So, and what is left up is the ileocolic vessels to the right of my ligation. Right of my ligation is the ileocolic artery, which is lifted. So I have dissected left and right of the ileocolic vessels on both sides. We are going to see that in a more clear picture. So coming back to the, so this is the ileocolic, right? So this is the superior mesenteric vein at the root of the mesentery. Now we are going to go caudally towards the ileum and take all the mesenteric and fibrofatty tissue towards the ileum also, because this is a growth of the cecum and the ascending colon. So we need to take as much of transverse colon as much as of ileum also we need to take, because cecum is also involved. And hence the lymphatic spread will also happen to the terminal ileum also. And that is why I'm going lateral to the ileocolic, not right on the ileocolic. Okay. So you can see the ileocolic being lifted. There is a tug on the superior mesenteric vein. Now I'm dissecting cranially towards the duodenum. That is where the right colic, I'm searching for the right colic. You can see the tented superior mesenteric vein. The main superior mesenteric vein is tented up. That is where the ileocolic vessel is being held up. However, I was searching for right colic vein, but I could figure out that right colic vein is absent. Hence, now I'm just going to concentrate on the complete dissection of the ileocolic vein and the ileocolic artery. The reason to dissect at the root of mesentery, as Dr. Nikhil has mentioned already, is to take all the vascular and all the fibrofatty tissue and the lymphatics, because the lymph nodes will, the cancer will spread on these lymph nodes and they will go along the arteries and the veins. So with a Maryland forceps, we're just going to do a posterior dissection posterior to the ileocolic artery and the ileocolic vein and try to dissect the ileocolic pedicle. Again, dissecting right to the ileocolic pedicle and dissecting left to the ileocolic pedal. Now we can see the duodenum also. So the whole of the ileocolic pedicle from the right and the left and underneath the superior mesenteric vein is completely dissected. And this is the first part of our D2 lymph node dissection. Now I am ligating the ileocolic vessels right at the root, also bearing naked the whole of the superior mesenteric vein. The whole of the superior mesenteric vein is now I've just cut the ileocolic vessels, and all the fibrofatty tissue which has all the lymph nodes also get dissected up. Now next thing is to dissect the middle colic vein and the artery. Now, doctor, if you had paid attention to all the postgraduates, Dr. Nikhil mentioned that middle colic takes off from the pancreas, from just underneath the inferior border of the pancreas. So to dissect the inferior border of the pancreas, you need to dissect the duodenum and the head of the pancreas completely. Now you can see here, we had already dissected the duodenum. Now you can see this is again a totally avascular plane. I'm just following the mesocolic fascia. This is all blunt dissection and it is happening right above the head of the pancreas. We'll see the head of the pancreas more clearly. However, if you can appreciate, this is the C loop of the duodenum, the second part of the duodenum, and we are going towards the first part of the duodenum and pushing it down. Now you can see the head of the pancreas just underneath my ligation forceps. And what is, okay. Now after the tenting of the ileocolic vein, what gets tented up is the middle colic artery, because whatever gets tented up is only the vessels. Nothing else will get tented up. So now again, we make an incision right above the superior mesenteric vein, and we are going at the inferior border of the pancreas, trying to identify the mesocolic vein. Mesocolic vein is generally much easier to identify as compared to the middle colic artery. So you can see the C loop of the duodenum on the left side of the screen, and in between, to the left of my ligation, is the head of the pancreas. So this is the head of the pancreas right in the center of the screen, and we are dissecting to the right of the head of pancreas to identify the mesocolic vein, because this is the area where the gastroepiploic vein, the right gastroepiploic vein, you can see that coming up. The right gastroepiploic vein and the middle colic vein forms the gastrocolic trunk, which is very, very important. All the fibrofatty tissue will be taken at the level of the superior mesenteric vein. Now you can see the whole of the pancreas completely bared, the head of the pancreas. And again, I'm just doing some blunt dissection, opening my forceps. Again, the mesocolic fascia, putting the first part of the duodenum down along with the head of pancreas, and what lies above is nothing but the mesocolon, the mesentery of the colon, the mesentery of the hepatic flexure, and the mesentery of the transverse colon. And you can see the right lateral abdominal wall also being incised. So there's no vascular structure that comes over here. So you can be very, very fast in this place. Again, this is an unedited version. So I wanted to play an unedited version so that you can identify the middle colic vein in the previous. It's going up right at 12 o'clock position. That is the middle colic vein. The left branch of the middle colic vein coursing to the left side. This one, where my ligature was. And I'm going to take only the left middle colic vein because that is what we do in a hemicolectomy for colonic, for cecum, terminal ileum, and ascending colon cancers. However, if this was a hepatic flexure malignancy, then we would have taken the root of the middle colic vein. That is both the right and the left branches of the middle colic vein. So we just ligated the middle colic vein, and I don't think there's anything else left in hemicolectomy. So that brings us to the hemicolectomy procedure. And
That was an excellent presentation of all the structures involved in the right hemicolectomy. Now,
thank you, sir.
Postgraduate Dr. Amiya will present the surgical anatomy related to
clinical presentation.
One lesson they have learned. Yeah. Amaya, downloaded?
Yes.
Okay. Yeah. I think Dr. Archit, it was an excellent video and beautiful dissection. But I think the teacher in us again, Dr. Amaya did a mistake that she did not download her topic on the laptop. So now I think it will be a lesson for all the postgraduates that if you are presenting anything, you should download everything on your own. Okay. Now she'll present it. Huh? Sure.
Sorry for the technical glitch. So I'll be presenting on the certain short brief presentation on the etiopathogenesis, clinical features, and investigations in colonic malignancies. So coming to the etiology, genetic susceptibility and environmental factors play an important role in colonic malignancy. As we know, this is more a disease of the Western population. As in present times, occurrence has increased in Indian population. Genetic susceptibility in form of a pre-existing ulcerative colitis or polyposis syndrome, hereditary non-polyposis colorectal cancer syndrome are the genetic susceptibility factors. Environmental factors such as poor low fiber content diet, consumption of alcohol and smoking forms an important environmental factor. Consumption of increased red meat is also an important factor contributing to colonic malignancies. What we need to consider in terms of preparing ourselves for protection against colonic malignancy is to increase exercise, have a good high fiber diet, and to reduce consumption of alcohol as well as smoking. And low dose aspirin and vitamin D supplementation also goes a long way in protective factors. Coming to the adenoma carcinoma sequence, a normal epithelium undergoes changes into a hyperproliferative epithelium due to continuous insults with APC inactivation and CO2 overexpression. This further forms a small adenoma in presence of KRAS mutation and a loss of 15-PGDH gene, which further makes the small adenoma grow into a large adenoma. Further loss of P53 gene and P10 mutation leads to the conversion of large adenoma into carcinoma. So this is the adenoma carcinoma sequence which we need to consider. Clinical presentations of colonic malignancies can be broadly considered in symptoms occurring due to local tumor and those occurring due to metastatic disease. So symptoms of local tumor predominantly is altered bowel habits. Here, important factor to consider is that malignancy of a proximal colon will cause more of anemia and vomiting as a symptoms rather than just altered bowel movements. Whereas distal colon malignancies due to an encircling growth leads to constipation as a predominant symptom. Alteration of habits is also a change in the diet consumption from a solid diet to a liquid diet in the patients. Bleeding PR is a predominant symptom which the patient presents to the physician with. Occult anemia is a significant factor. Abdominal pain as a distressing symptom. Sometimes a local tumor may present with obstruction, perforation, and hydroureteronephrosis. Symptoms to consider of metastatic disease is weight loss, anorexia, cachexia, jaundice, and iron deficiency anemia. Colorectal emergencies are in form of perforation, obstruction, and torrential bleeding occurring due to invasion of vascular structures. Colorectal screening forms an important part of prevention and early diagnosis and management of colorectal cancers. Colorectal screening occurs in form of fecal occult blood tests, colonoscopies, and scannings in form of barium enemas. It is guidelines suggest that those above age of 50 should undergo colonoscopic evaluation at least on a yearly basis. Investigations, coming to investigations, the first and foremost investigation is digital per-rectal examination. Apart from that, colonoscopy and biopsies play an important role. Radiological investigations such as CT abdomen and barium enema gives a good idea regarding the tumor and the surrounding relations. Fecal occult blood test is also an important test. Apart from routine blood workup, tumor markers such as serum CEA plays an important role as it gives an idea about the prognosis of the disease, especially post-surgery. If there is not a drastic fall in CEA, we might consider that there is some residual disease remaining. Occurrence or again a rise of CEA after reaching baseline might suggest a recurrence in further follow-ups. Metastatic workups in terms of CT thorax and MRI liver plays an important role, as liver is one of the common organ of metastasis. These are some of the images suggesting early colorectal cancers. That as you can see in this image, it is showing sigmoidal polyp, and these are the images showing mesenteric infiltration into the lymph nodes of the draining lymph nodes. Yellow arrow in this image is suggestive of a irregular narrowed lumen in case of a sigmoidal cancer, and this image is suggestive of multiple liver mets. This is a barium enema showing narrowing of the lumen in a distal malignancy. And this is a PET CT, which is more for looking for an overall evaluation rather than staging of the tumor. Thank you.
Thank you, Amaya. Archit, would you like to add anything in your clinical practice? I think majority of patients are referred to you with the diagnosis, or any additional workup or anything you would do.
So I would just like to mention to the postgraduates that usually it's actually also a MCQ that NSAIDs and aspirin is a protective agent, and that is what Dr. Amaya also mentioned. Secondly, with regards to staging, MRI of the pelvis should be the answer when asked, and not CT scan of the pelvis. MRI for all colorectal staging is very, very important, especially rectal cancers. And PET scan is not a staging procedure. It is not used in preoperative workup. That would be a wrong answer to give, because even in our international guidelines, PET CT has no mention. Its only importance is to identify if there's any recurrence. And I think she has covered almost all the points very well.
Okay. Thank you. Now I call upon Dr. Rahul. He's going to speak on surgical anatomy of rectum.
Good afternoon, everybody. I'll be talking about the surgical anatomy of the rectum. In surgical anatomy of the rectum, we should know about the total mesorectal excision. We should know about the blood supply as well as about the lymphatic drainage of the rectum, because it is important in regards to malignancies of the rectum. So starting with first things first, the peritoneal coverings. Here we can see the peritoneal covering of the rectum in the upper third is present only anteriorly and laterally. This is well seen in this diagram that the high rectum, it is covering only anteriorly and laterally. In the middle third, it is covering only anteriorly. And in the lower rectum, distal third, it is completely devoid of peritoneum. Moving on, the surrounding fascias which have to be known in order to dissect the mesorectum. There are two fascias which are important in total mesorectal excision. The first is this presacral fascia which we can see here. The second being this mesorectal fascia, which is mentioned as rectal proper fascia here. So, and we should also know about the Denon-Villiers fascia, which is the rectogenital fascia, which is present in front of the lower third of the rectum. It is visible more prominently in males, while it is thin, scanty, might be deficient in cases of female. Now, the mesorectum. What is the mesorectum? It is a perirectal fatty lymphovascular tissue, which encases the rectum as a thick cushion, mainly posteriorly and laterally. Knowing the mesorectum is very, very important. We'll come to know why in the coming slides. Is your plane holy? Actually, in 1988, Sir Bill Hales, he gave the holy plane. Before that, whatever surgeries were performed in cases of rectum, they had an excision which was completely different from what was suggested by Dr. Bill Held. He suggested a plane which is known as Hales holy plane. The dissection in this plane is along the avascular alveolar plane, which is between the presacral and the mesorectal fascia, which we have already seen in the surrounding fascia slides. The importance was that earlier when the surgeries were performed, there was a local recurrence of around 30 to 40%. But after Dr. Bill Hill gave this his Hill's holy plane and people started following that, the recurrence came down to nearly about 5%. In this diagram, we can see that the tumor is left in the mesorectum and it can cause these tumors can cause local recurrence. But if we completely remove, that is, we perform a total mesorectal excision, then it does not leave the tumor cells behind. Recurrence will be very less. Now, talking about the flexures, if we concern the surgical anatomy, it is just that if we release the surrounding fascias, because of the presence of these flexures, we can get a better length of the rectum. Initially, it is just 5 inches in length, that is 15 centimeters. If we open up and dissect the planes, then it can increase the length up to 20 centimeters. Talking about the blood supply, the superior rectal artery, which is a branch of the inferior mesenteric artery, then coming to the middle rectal artery, which drains into the common iliac artery, and the inferior rectal artery, which is a branch of the internal pudendal artery. The venous drainage, the upper and middle part of the rectum is mainly drains into the inferior mesenteric vein, which drains into the splenic vein, and following it continues as the portal vein after the superior mesenteric vein and the splenic vein join to form the portal vein, whereas the inferior rectal vein drains into the internal pudendal vein, which drains into the common iliac vein and continues to the IVC. The importance of this is that it can if there are any mets, those mets can travel directly to the lungs via the IVC without surpassing the portal system. This inferior mesenteric vein is a portal system, and this internal pudendal vein is a systemic circulation. Now, coming to the lymphatic drainage, the upper and middle part of the rectum drains superiorly into the inferior mesenteric lymph nodes, and the lower rectum, superiorly it drains into the inferior mesenteric lymph nodes and laterally into the internal iliac lymph nodes. The importance that was there is that Japanese dissection which is performed, generally they also, along with the superior dissection, they also perform a lateral dissection. So that is the importance of knowing the lymphatic drainage. Now about the nerve supply. Nerve supply, both sympathetic and parasympathetic plexuses are present around the rectum. So we have to be very careful while dissection, not to injure the nerves. These nerves can be injured during rectal dissection if there is a presence of a superior hypogastric plexus, which is shown here, which joins the pelvic splanchnic or the lateral plexus of nerves. Now, the superior hypogastric plexus is the sympathetic plexus, and pelvic splanchnic, which later becomes the lower hypogastric plexus. Now, isolated sympathetic nerve injury causes retrograde ejaculation in patients. And if there is injury to both parasympathetic and sympathetic nervous system, it can cause impotence and bladder dysfunction. So we have to be very careful while dissection.
Rahul, can you tell everyone that how to remember this? You know, we had discussed yesterday.
Yes, sympathize from superior hypogastric plexus. It is as a sympathetic plexus. We have to sympathize with the patient. So the patient actually is having retrograde ejaculation, which means that patient would not be able to conceive. So we have to sympathize with the patient. So we can learn it like that. Whereas for in lower hypogastric plexus, where there is both sympathetic and parasympathetic. We have to sympathize even more with the patient because he has impotence, which is even worse.
Okay, great. Thanks.
Okay, so now about the types of resection and the types of we perform a lower anterior resection that is mainly focusing on the middle part of the rectum, and there is ultra low anterior resection which is focusing mainly on the lower part of the rectum. So these are basically two sphincter sparing surgeries which we perform. Later, if it depends on the position of our carcinoma, which is present where, according to that, we perform the resection, either low anterior resection or ultra low anterior resection. Sir will be discussing more about this in his videos. Thank you.
Okay, thank you, Rahul. Meanwhile that my video is being put up, I'll just tell for the benefit of the postgraduates that the way to remember is that let's start from the sigmoid colon. That is the most proximal bowel. So sigmoid colon, we call it sigmoid colectomy. When we have to remove the upper rectum, we call it anterior resection, not the low anterior resection. So upper rectum, anterior resection, middle rectum, low anterior resection, and lower rectum right up to the levator ani muscle, that is the ultra low anterior resection. And when the disease is already at the level of the sphincters, that is the levator ani and the pelvic floor, then you have to remove the pelvic floor, remove the levator ani muscles, and you call it as abdominoperineal resection because the surgery also happens from the perineal side. So I mean, I just asked one of my DNB students that what kind of questions they asked. So he mentioned that about rectal surgeries is one of the short notes. So I thought I'll just mention it to all the postgraduates here. If you ask me which is one surgery that should be given to a postgraduate, I would say start with low anterior resection because it is the simplest of all. Even more hemicolectomy is really very, very difficult. So let's see how to perform a anterior resection. So first step is to identify the root of sigmoid mesentery, that is to lift up the sigmoid colon. When you lift up the sigmoid colon, what gets lifted up is the inferior mesenteric artery. That is what is marked by the red arrow. And again, a monopolar dissection. We can also do this dissection with scissors. It will be totally avascular. So again, a monopolar dissection. Now you can see we are dissecting right above the hypogastric plexus of nerves. And we are going at the level of the sacral promontory in the plane of heel, that is the holy plane. Now this is the holy plane of heel, and you can see the nerves just underneath the dissection. Now you can see the nerve. I've just pushed the nerve down. That is the hypogastric. You don't want to sympathize with the patient, right? So these are the hypogastric plexus of nerves, and you just stay above the nerve because right above the nerve is the mesocolon. Now again, we do our dissection towards the caudal part, and that is where I'm showing that the nerves will run and the ureter will always be lateral to the nerve. So this is the nerve. Now we come back to our dissection at the level of the inferior mesenteric artery. Now this is because the sigmoid colon is pulled up, and this is if the sigmoid colon is pulled up, the inferior mesenteric artery, the sigmoidal arteries, the superior rectal artery will also be pulled up. And when you go medial to lateral, what you encounter is the ureter, which lies just lateral to the inferior mesenteric artery. Now you can see the hypogastric plexus of nerve very clearly underneath. And that is the importance of knowing the inferior hypogastric plexus. Just lateral to the inferior hypogastric plexus is the ureter. So we should always stay medial. This is the surgical anatomy here, that ureters lie lateral to the inferior hypogastric plexus. So whenever you identify the inferior hypogastric plexus, always stay medial to it. You can see the ureter's peristalsis. Again, lifting the inferior mesenteric artery and cutting the peritoneum. This peritoneum will take us to the level of the root of the mesentery of the inferior mesenteric artery. So again, the right colon mesenteric dissection was the superior mesenteric artery, the left colon sigmoid and the rectum is the inferior mesenteric artery. Now from medial to lateral side, we have gone and we have cut the abdominal wall, the attachments of the sigmoid mesocolon root. Now the dissection is happening right at the root of the mesentery. Below is the aorta, and I'm just taking all the fibrofatty tissue right up to from the aorta above. I've identified the left colic artery and I'm going to save the left colic artery and just ligating the inferior mesenteric artery, which will also include ligating the sigmoid as well as the superior rectal artery. Now, this superior rectal artery is very important as it runs inside the mesocolic or the mesorectum. So what we do is we ask the assistant to lift up the superior mesenteric, superior rectal artery, and what lies underneath the superior rectal artery is the fibrofatty layer of the holy plane of Heald. Now, this all fibrofatty layer is nothing but that holy plane of Heald, which has given us miraculous results by reducing the local recurrences rates from 40-50%, and in some series they were as high as 70% to now around 5 to 7%. Now this whole plane is completely avascular. You can see the sacral plexus of veins below. That was my wrong plane. I've corrected it and I've come more superficial. You can see the presacral plexus of veins. Now again, I'm in the correct plane and I'm going towards the floor of the pelvis. And above all the fibrofatty tissue, I'm cutting and I'm taking all the lymph nodal vessels, the lymph nodes. And I think this is the most easiest surgery to begin with, even in laparoscopy, I would say. Now you keep on going below right up to the level of the levator ani muscles. That is when you reach the pelvic floor. So this is probably an ultra low anterior resection that we are doing, and we are going right up to the pelvic floor. We will see the levator ani muscles also. And I'm just sticking to this fibrofatty tissue. All the rectum is above, and I am between the rectum and the sacrum. Sacrum is behind, underneath. So posterior and lateral dissection is completed just from the posterior side. Cut little bit and then just push. That will help in identifying the presacral fascia or the mesorectal fascia, which lies above the presacral fascia. Now you can see the buttocks of the baby. That is most famously called that. If you are in the right plane, you will identify the buttocks of the baby. Now the same dissection is happening in the mesorectum. So posterior and lateral dissection is over. The same plane in anteriorly continues as the Denon-Villiers fascia. Now this is the most important thing because you really don't want to make a mess out of that male's body. So you just stick to you just identify the seminal vesicles. We have just identified the seminal vesicles, and now we are going to see the Denon-Villiers fascia. Now Denon-Villiers fascia are two fascias. One is sticking to the prostate and the seminal vesicle, and the other one sticks to the rectum. Now, since this is a tumor growth of the posterior rectum, so we are going to take leave both the Denon-Villiers fascia with the prostate, so that we can save the nerves. Which nerves? The importance ones wherein you have to sympathize, parasympathize, and all sympathize, because you don't want to make him impotent. So again, now you can see the seminal vesicle, the glistening white, but I'm not going to cut there. I'm going to cut below. Now here when I cut, I take both the fascias with the seminal vesicle, saving the sphincter. Now this is again, I personally feel that Denon-Villiers fascia is the same extension of the whole envelope. Posteriorly, it is called as the mesorectal fascia. Anteriorly, it is called as the Denon-Villiers fascia. So rectum is a beautiful organ covered by fascia from all sides. The only vessel that you encounter is the middle rectal vein, that too also in around 25 to 30% of patients. I may be wrong, maybe misquoted. So I think it is present only in 35% of patients. I very rarely find a middle rectal artery. In this patient, we fortunately found a middle rectal artery. So that was the only place where I actually used my ligature. Otherwise, the whole dissection is done by monopolar cautery. Again, just want to specify to all of you that if you are in the right plane, you really do not need any gadgets, because if you are in the right plane, you will not bleed. Nothing will bleed. So again, this is the middle rectal pedicle. Now, this middle rectal pedicle defines the beginning of the lower rectum. This is where the middle rectum ends, and you can see the fibers of the levator ani, the pink fibers of the muscles of the levator ani underneath. I have cut few fibers of the levator ani so that I do not compromise on my inferior most margin. I think we are coming to the end of our video. I think another 1 minute or so maximum. Is there a lag? I think there's a lag. Okay. Now again, the dissection of the Denon-Villiers fascia. I've gone right up to the floor of the pelvis. So now this bleeding signifies the septum between the two lobes of the prostate. No matter what, bleeding always happens here. I don't know why, but this is where bleeding always and always happens. So this is the whole clinical anatomy of the rectum by the laparoscopy view. Thank you very much. Thank you.
Thank you, Archit. That was an excellent presentation of the dissection of the rectum. If anybody has got any questions to Archit, they can ask.
Thank you,
There is one question from Dr. Akshay Medgood. What was the position of the patient?
Okay, that's a very good question. So this is a semi-lithotomy position. And, okay, this is a very good question, actually. Again, it involves anatomy. Anatomy is the mother of all surgeries. So even in positioning, anatomy is so important. I'll tell you why. So this is a semi-lithotomy position, not a complete lithotomy that you do in rectal or hemorrhoidal surgeries. And you put a sandbag underneath the anterior superior iliac spine. Now, what that does is, if you remember, we had mentioned about the root of mesentery or the mesocolon attachments of the small bowel that runs from the ileocolic up to the ligament of Treats. When you put this sandbag underneath the anterior superior iliac spine, it lifts the sacral promontory. So the whole root of mesentery falls behind. The bowel never comes into the pelvis. And that is why we could never see a small bowel coming into the pelvis. Again, if a small bowel comes into the pelvis, it makes your dissection messy. So again, the application of anatomy in this positioning of the patient.
Thank you, Dr. Archit. I know that you have taken time out. I think you're in Uttarakhand or somewhere. So
yes, sir.
We hope that it's a lovely background there. And see his dedication. In spite of his busy schedule, he has stopped the vehicle and he has taken the class for the postgraduate. So we really thank you very much for your excellent talk and the beautiful steps which you have shown to us. And I think most of our PGs will get encouraged with this and take up laparoscopy. I want Dr. Amaya to end the session. Amaya will just say thank you.
Thank you, Dr. Achit. It was great working with you, and I hope to get more tips from you regarding the same. So,
Thank you. It was really wonderful working. I could feel myself becoming a postgraduate again. And we had lots of chats, during the presentation. Thank you, sir. Thank you, Gokte sir. Thank you, Dr. Vishwanath sir, and all the faculties. I owe everything to this alma mater. You have all structured me this way. Thank you for having me and inviting me. Thank you, sir.
Thank you.
Thank you, sir. Now we will move to the next session. I request Dr. A.P. Pellat sir and Dr. Manoj Togle sir to chair the next session. Now I request Dr. Manoj Togle sir to give a brief introduction about our next speaker, Dr. Ganesham MK.
It's always a proud moment for us when we introduce our own alumni. Dr. Ganesh, who is a surgical gastroenterologist, has finished his specialization from our college, and then his super specialization from GEM Hospital, Coimbatore, under Palnivelu sir. He at present is working in surgical department of Father Muller Medical College in Mangalore. He performing all advanced laparoscopic and major hepatobiliary and gastroenterology procedures. He has also been a part of liver transplantation team of CMC Vellore. Ladies and gentlemen, I present Dr. Ganesh.
First, there will be a presentation from our PGs. I request Dr. Prithvi to start with his presentation.
Share it first.
This only?
Good afternoon, everyone. I'll be giving a brief about gastric anatomy regarding this session. Coming to the gastric anatomy, stomach is a dilated muscular J-shaped sac which is located at the level of T10 to L3 vertebra. It is a maximum distendable structure in the abdomen. Its capacity varies from 1.5 to 2 liters in adulthood. Coming to the anatomy of stomach, it is divided into 4 parts. Cardia, which surrounds the opening of the esophagus into stomach. Next comes the fundus of the stomach, which is the area above the level of the cardiac orifice. The body of the stomach is the largest region of the stomach. Pyloric part is divided into pyloric antrum and the pyloric canal, and is the distal end of the stomach. Coming to the surfaces, it has the significant feature of 2 to 2. Surfaces are 2 anterior and posterior, antero-superior and postero-inferior. Openings is cardiac, gastro-esophageal opening and pyloric opening. Sphincter is cardiac and pyloric. 2 curvatures are there, greater curvature and lesser curvature. Lesser curvature forms the right border and the greater curvature forms the left border of the stomach. Coming to the relations of the stomach, anterior relation is formed by the, anteriorly it is related to liver, diaphragm. Posterior, stomach bed is formed by diaphragm, part of diaphragm, left renal, left suprarenal gland, pancreas, and the splenic vessels, and the transverse mesocolon and the splenic flexure. At times, part of spleen forms the bed of the stomach. Coming to the blood supply, the main blood supply is from celiac trunk, which is divided into right and left gastric arteries. Left gastric artery is a direct branch from celiac trunk, and the right is a branch from gastroduodenal branch.
And in the greater curvature, it is supplied by gastroepibloic left and right gastroepibloic artery, and some branches from splenic artery. This is the same diagram showing the blood supply to the stomach. Coming to the venous supply, it is drained into the superior mesenteric vessel, splenic vessels, and in turn into the portal vein. Next. Thank you.
Good afternoon, everyone. I'll be dealing with a brief anatomy of lymphatic drainage of stomach. The lymphatics of antrum drain into the right gastric lymph node superiorly and right gastroepiploic and subpyloric lymph nodes inferiorly. And the lymphatics of pylorus drain into right gastric suprapyloric node superiorly and the subpyloric lymph node situated around the gastroduodenal artery inferiorly. And the efferent lymphatics from the suprapyloric lymph nodes converge on the para-aortic nodes around the celiac axis. The efferent lymphatics from the subpyloric lymph nodes pass up to the main superior mesenteric lymph nodes situated around the origin of superior mesenteric artery. The lymphatic vessels related to the stomach communicate freely with those of the esophagus. Here in this picture, you can see the lymph node stations. This is given by Japanese classification. And the first picture, you can see the anterior view, and the second picture is showing the posterior view. And these stations, numbered stations, I'll be discussing in my last slide. The prognosis of operable cases of carcinoma of stomach depends on whether or not there is a histological evidence of regional lymph node involvement. Retrograde spread may occur if the upper lymphatics are blocked. The extent of lymphatic adenectomy for gastric cancer. Well, this adequate lymphadenectomy with histopathological nodal evaluation are important components of gastric cancer staging and therapy. This classification of lymphadenectomy for operable gastric cancer falls into two categories. One is topographic location of the lymph node stations and the extent of nodal removals extending away from the stomach. This Japanese Research Society for Gastric Cancer described the topographic classification of histopathological and nodal evaluations. This classification is based on nodal stations within various parts of stomach and its arterial supply and extends to the para-aortic nodal region. The second classification is based on the extent of nodal removal and is also known using the D nomenclature. There are four types of lymphadenectomy exist. D0 denotes incomplete removal and therefore is considered as an inadequate nodal dissection, and unless this palliative gastric dissection is considered. D1 entails the removal of perigastric lymph nodes. D2 is D1 combined with removal of nodal stations around the celiac trunk along with a distal pancreatectomy and splenectomy. And D3 includes D2 plus resection of nodes from the celiac axis to the inferior mesenteric artery. This picture shows a D1 versus D2 lymphadenectomy. And here you can see the brown colored lymph nodes. In this, D1 lymphadenectomy is done. Additionally, these green lymph nodes, D2, along with this, D2 around the celiac axis. Here in D1 lymphadenectomy is the resection of perigastric lymph nodes, and D2 lymphadenectomy is an extended resection of nodes surrounding the celiac artery area with splenectomy and distal pancreatectomy. And the lymph node stations that needs to be removed in D1 are labeled as N1 and D2 are labeled as N2. Here on the screen, on the left side, you can see the numbering of the lymph nodes, and beside that, you can see the description of those lymph node stations. Thank you. My colleague will be continuing with the types of gastrectomy, and our main speaker will be speaking about the D2 gastrectomy.
Good afternoon, everyone. I'll be speaking about the types of gastrectomy and the types of reconstruction after either partial or total gastrectomy. Firstly, here we are main indication we are talking about discussing about carcinoma stomach. Other than this, the indications are CA stomach, gastric lymphoma, leiomyosarcoma, Meniere's disease, chronic benign gastric ulcer, benign tumors of stomach like leiomyoma, stomal ulcer, that is bleeding ulcers, and also bariatric surgery. Also, there is a part of gastrectomy. Gastrectomy is a part of bariatric surgery. Depending on the amount of the stomach excised, there is a partial gastrectomy or the total gastrectomy. Partial gastrectomy includes proximal gastrectomy and distal gastrectomy. In partial gastrectomy, the antrum is preserved, which is less distensible. So there is a it is not of much use in case of the capacity of the stomach, to store the capacity of the stomach. And coming to total gastrectomy, and based on the type of reconstruction after total gastrectomy, again gastrectomies are classified as a Billroth 1 gastrectomy, like Billroth 2 and Roux-en-Y reconstruction. And based on the radicality of the lymph nodes clearance, D0, that is dissection of inside lymph nodes inside the gastric and the gastroepiploic arcades, D1 N1 nodes, and D2 N2 nodes. Gastric resection requires the understanding of the following. Physiology of vagal innervation and gastric emptying has to be known. Surface and vascular anatomy of the stomach. Principles of reconstruction following resection, following specifically the Billroth 1, Billroth 2, and Roux-en-Y configuration has to be known by the surgeon. Principles of surgical stapling techniques as well as the hand sew and suturing techniques need to be known. Specific early and late postoperative complications that arise from different forms of reconstructions has to be known by us. These are the modes of various modes of reconstruction after partial gastrectomy. The first figure shows Billroth 1 reconstruction. The second figure shows the Billroth 2, and the third figure shows Roux-en-Y. Briefly talking about the Billroth 1, initially the mobilization of the duodenum is done with a coccus manio, and gastroduodenostomy is performed in 2 layers. That is, a posterior layer of interrupted 3-0 silk or Lambert seromuscular suture is placed. First, the inner 3-0 vicryl sutures are placed next to each other, sewn away from each other over and over fashion until the sutures are brought around the edges to the anterior aspect. And briefly talking about the Billroth 2 reconstruction is a closure of the duodenal stump followed by an antecolic or retrocolic gastrogenural anastomosis. This is a picture showing Billroth 2 anastomosis after complete reconstruction. This is a sleeve gastrectomy indicated when the tumor or the ulcer is on the greater curvature of the stomach. That is, sleeve gastrectomy involves a resection of approximately 80% of the greater curvature of the side of the stomach. and a smaller tubular gastric sleeve is created along the lesser curve that is based on the lesser curvature blood supply. Ideal approximate capacity of the stomach is about 30 to 60 ml in the gastric sleeve pouch. Gastric sleeve gastrectomy is also known as a greater curvature gastrectomy, vertical or a longitudinal gastrectomy, or a pylorus preserving gastric tube creation. It is a rapid and a less traumatic operation. Further, it is a second surgical steps are easily feasible in this. Coming to the goals of total gastrectomy, clearing of margins on both the esophageal and the duodenal side is required. Removing of local and regional lymph nodes, removal of omentum end block with the stomach is required. Removal of lymphatic tissue overlying the pancreatic cap is required. Extended lymph node dissection, that is D2 resection, which will be talked by Dr. Ganesh sir now, along with the Roux-en-Y reconstruction. Modes of reconstruction after total gastrectomy. Roux-en-Y reconstruction and creation of the jejunal pouch are the two types. Roux-en-Y reconstruction after total gastrectomy. End to side esophago-jejunal anastomosis with the Roux limb is done. Enterostomy is constructed between the jejunum on the duodenal side of the Y and the jejunal 40 to 45 centimeter distal to the Roux limb staple line. This is the picture after completed Roux-en-Y reconstruction. Total gastrectomy with jejunal pouch reconstruction, also known as Hunt-Lawrence pouch type of reconstruction. Esophagus here, esophagus is anastomosed in the end to side fashion with anti-mesenteric border of the pouch. The pouch is constructed with the goal of providing a reservoir function. Here, the capacity of the stomach is increased. These are the two types of jejunal pouch. First one is a S-shaped pouch. This one is a S-shaped jejunal pouch, and this is a J-shaped jejunal pouch. Coming to the complications, since there is anastomosis, there is a chances of anastomotic leak also. And the other complications include a stromal obstruction, that is a reflex gastritis, efferent and efferent loop obstructions, dumping syndrome, severe weight loss, and retrograde into cessation. Thank you. Now I will hand over the session to Dr. Ganesh sir.
Yeah. Can I invite Dr. Ganesh? Dr. Ganesh, please switch on your audio.
Am I audible now?
Yeah.
Okay. My screen is shared now?
Yeah.
No, sir. Screen is not being shared as of now, sir. We can only see your camera video.
What I'm supposed to do, can you help me out?
Sir, there's a green button in the midline.
I did that.
Yes, sir. And then there'll be a lot of options coming.
Yes.
Whichever screen is the video that, or whichever screen you want to share, you have to click on that video.
Desktop 1 is there. I clicked that.
Yes, sir. Now we can see your screen, sir.
You can see my screen.
Whichever window, whichever screen has to be shared, only that screen you click on, sir.
Can you see my screen now?
I can see your desktop, sir. But yeah, now we can see, sir.
Okay, fine. I'll start my presentation.
Yeah.
Yes, sir.
Good.
Sir, if you could, no, we'll have to do it.
And I'll do that.
Yes.
Okay, fine.
Yeah.
I thank my teacher, Professor Dr. S. Gopte sir, for giving me this chance. And also a special thanks to all my surgery department where I did my post-graduation for giving this opportunity. And Anil Bennett sir, and I was working under him, who is chairing the session. Thanks for being there, sir. And also all my seniors like Dr. Manoj, who was my, just gave exams when I was joined as a postgraduate in JNMC. I'll be talking about gastrectomy, D2 gastrectomy, indication being very simple, CA stomach, and what stage of disease we do. To put it very simple, it is to give neoadjuvant treatment. Any operable lesion, you end up doing a surgery. To give neoadjuvant or not to give neoadjuvant depends upon this, what sort of presentation the patient comes with. If the patient has obstruction, there's no role for neoadjuvant treatment. If the patient has no gastric outlet obstruction and the lesion is more than T3 or plus, or if the presence of lymph node, you should consider neoadjuvant treatment in this set of patients. The neoadjuvant treatment is present, what we give is a chemotherapy, what is preferred, and it comes as a OG junction, even radiation can be considered. Coming to the steps of surgery, to put it simple, how I'm going to go about. First, I'll be talking about the position of the patient, followed by what sort of ports is what I prefer. Every person has their own preferences for port placement and position of the patient. And if you can see my arrow mark on my screen, I'll be dissecting, showing how do I go about the dissection there. Usually the omental dissection goes along the colon, then you reach the right gastroepiploic vessel there, then you go dissect the just supraduodenal, divide the duodenum there, then go along the lesser sac there between the liver and the stomach, close to the liver to open up the lesser sac there. You then go for the D2 part of the lymphadenectomy. Once it is done, you divide the esophagus there, then the reconstructions comes into play. These are the steps. So it is a methodical way which goes from this side all the way to this side. So if you go in an organized way, it cuts short the time and you can do it in a continuous process. It's a continuous process. Coming to the position of the patient. Position of the patient, the monitor will be in the head end and the cameraman will be standing on this side. I hope that you can see my cursor, and the scrub nurse on the opposite side. The operating surgeon will be standing between the legs, the right side of the patient, the cameraman and the first assistant. The scrub nurse will be on the left side of the patient towards the splenic side or the liver side to put precise. And the operating surgeon will be in the between the legs. It is important to have a good laparoscopic table where the patient can be given a good head-up position. Otherwise, you're going to have shoulder joint are going to trouble you over a period of time. In the end of the surgery, you will feel more fatigue if you cannot get a good end up. And more so, the colon and the rest of the small bowel will fall on its own, and it will be easy to dissect the stomach well. Okay, it's hung. Okay, coming to the port placement. Port placement. See, I have drawn this picture so that we get a general idea how to place the ports. This is the umbilicus here. Usually a longitudinal incision is placed so that you can extend it to get the specimen out, not a transverse incision there. And it should be just above the umbilicus, around 2 fingers above the umbilicus, so that enough distance is there between the stomach greater curvature and the camera to give a decent vision. This is a right hand working port of the surgeon, which is initially 5 mm. Later on, if you don't have a 5 mm Hemolock applicators, you can change it to 10 mm to put good clips. So it should come at the greater curvature, somewhere around the mid-clavicular line. The left hand of the operating surgeon comes little medial to the mid-clavicular line at the same level, so that it's again at the inferior border of the stomach. This port as high as possible to retract the liver, and this will be used by the sister or the nursing assistant who is standing here to retract the stomach to give better vision. The 12 mm trocar will be used for the staple, which is used to divide the duodenum. That's a D1 part of it. So this is a port placement. If every surgeon will have their own preference to place the ports. It is what Dr. C. Palnivel follows, the port what my teacher follows. And we've been comfortable operating in these ports. I have divided the video into different halves. The first half I'll be talking upon the mobilization along the greater curvature. The second half I'll be talking upon on the lesser curvature, and lastly the reconstruction part of it. So coming to the first part, the mobilization along the greater curvature, the omentum is put, we go to the infracolic compartment, put the omentum above it, and you dissect just close to the colon. So at this level, that's the reason this photograph here, to enter the lesser sac at this point. Dissection should start from the splenic, little away from the splenic flexure side, and move towards the hepatic flexure, so that the complete omentum can be removed in its close proximity to the colon. At this point, we should be very careful not to injure the transverse mesocolon. Transverse mesocolon to be differentiated from the omentum is quite easy. The omentum has small lobules, whereas the transverse mesocolon will be more smooth in appearance. So it is important that you differentiate the transverse mesocolon and the omentum. Otherwise, I have seen one of my junior colleagues trying to do laparoscopy and taking a decent amount of transverse mesocolon, devascularizing it, and ending up with a small colectomy because he couldn't differentiate the transverse mesocolon from the omentum. This particular point, if you can see, that's quite obvious. Once you have gone down till and removed all the omentum down, then you start moving along the splenic short gastric. When you pull it up, this is the transverse mesocolon. I told you it will be more smoother compared to that of the omentum. This is the left gastroepiploic vessel, which will be coming through the transverse mesocolon there. Care should be taken to seal it well, otherwise it bleeds and it troubles. Short gastric vessels are taken down, following which you reach the fundus of the stomach. Fundus has to be mobilized from the diaphragm. Again, when you are dissecting or dividing the short gastric vessel using the harmonic, spend some time, don't be in a hurry, don't give too much traction. When you give traction, the harmonic cuts more efficiently and it bleeds more. The posterior gastric vessels, this is all the posterior gastric vessels have been cleared from the pancreas, which are also branch of the like a short gastric from the splenic artery. If you see here, we have already removed the omentum completely. This is the transverse mesocolon being attached. Transverse mesocolon being attached to the posterior wall of the stomach, which is quite common, which has to be slowly separated from the stomach. If we don't do it well, what happens is you form a rent in the transverse mesocolon. The dissection should go down till you reach the right gastroepiploic vessel. When you dissect down in that plane, you will find the gastroepiploic vessels slowly getting originated from the gastroduodenal artery, which comes on the anterior surface of the pancreas. If you see here, you can see the pulsation in this particular point. That's a celiac trunk which is pulsating there. At somewhere here, you can see the pulsation there. That will be the splenic artery going that side and the common hepatic there. From the common hepatic, gastroduodenal artery will be coming somewhere this point. The dissect that also gives a good point of the duodenum and the point where we can apply the staplers to divide the duodenum at that particular point. Care should be taken at this particular point because bleeding is quite easy from the transverse mesocolon because there will be a lot of vessels, venous connection between the gastrocolic trunk, which will be between the right gastroepiploic vein will be draining along with the middle colic vein into the portal vein. So it easily tears and bleeds. Your assistant can easily give a little more traction than required and can cause this ooze, which is quite obvious in this patient. Clips can be applied. It's not difficult to control this bleeding. 2 clips, metal clips on either side and divide it is good enough to get control of that sort of mild ooze of venous ooze which comes at this point. This can be completely avoided by reducing the traction by your assistant surgeon who comes with a 5 mm trocar which is laterally placed at this particular point. If you can, this traction on the colon, if he has reduced, that this bleeding could have been avoided. And you can clearly see this is a duodenum there. So we have reached all the way duodenum. This was linitis plastica involving the stomach completely. So I had to go a little low on the duodenum to be sure of a good negative margin. These are the attachment of the duodenum onto the pancreas, and this pulsation, what you can see is of the gastroduodenal artery running on anterior surface of the pancreas. Then the superior part of the duodenum has to be opened up. The lesser sac has to be opened up there and mobilized slightly so that we can apply the endogenous stapler. Preferred as will be a blue for a small bowel. Even white has been tried. Bleeding will be lesser, but crushing will be more when you apply a white stapler. Blue stapler, crushing will be less, but chance of oozing will be more. The 12 mm trocar, which I have this 12 mm trocar here, will be very helpful to apply a straight stapler, which will cut down the cost. A roticulating stapler can be used from a different angle to apply it. Care should be taken to remove the Ryle's tube at this particular point when the stapler was being applied. If we don't remove the Ryle's tube, it is very easy to staple the Ryle's tube along with it. I'll change the video. Ryle's tube along with it. I have done that mistake. I had to open up the duodenum, remove the Ryle's tube and suture that point. So once I would do the mistake, you would never repeat it in life. Whenever I start a CS stomach case now, I just pull out the Ryle's tube to 30 centimeters so that it stays in the esophagus. Coming to the next part, that is the lymphadenectomy part of it. Okay, put it somewhere here. 1 minute should be fine. Okay. Once we finish the lesser curvature part of it, I have to do it's divided. Then you start lifting using the 5 mm instrument. You give a 5 mm instrument. You retract the left gastric vessel. The vessel which goes up is a left gastric vessel. You lift it up nicely. The left gastric vessels will stand straight compared to that of the splenic artery and the from the celiac trunk, from the celiac trunk, and separating it from the splenic artery and the common hepatic artery. So that denotes splenic celiac trunk or splenic trunk. Superior surface of the pancreas. This is superior surface of pancreas. What we can see there. Your dissection should go on the superior surface of pancreas, where you can easily see the splenic artery. When you dissect slowly, the left hand has a lot of importance. I have kept this video at 1.5 speed so that I can cover most of the lymphadenectomy in a normal, without cutting much, editing much of it. It usually takes around half an hour to 1 hour, half an hour to do a proper lymphadenectomy. Deep lymphadenectomy, this part what we're doing, total gastrectomy takes around 2.5 to 3 hours. So this is the left gastric vessel there. Care should be taken not to injure the left gastric vein. The left gastric vein into the portal vein and a splenic vein juncture, or into either of the other vessels there, either a portal vein or into the splenic vein. Problem comes is it retracts if it gets cut before we clip. So we should be very careful in clipping it before we cut it. This point is a right crus of the diaphragm, So the right crus of diaphragm, the peritoneal reflection has to be divided at that point. When you dissect all around, the left gastric vessel will be easily stand out, which will be very easy to clip it. If you see, we are at this particular point right now, and that's the crus there. Dissection should continue to mobilize the fundus of the stomach till the splenic flexure, so that when you dissect along and move along, you can reach till the hilum of the spleen. Once that dissection is over, you have to mobilize the esophagus well. It is important to mobilize the esophagus well so that you have enough intra-abdominal length of the esophagus, which can be easily anastomosed to the limb if you're doing a total gastrectomy. If we are doing a subtotal gastrectomy, this part of dissection is not required. Only the lymph nodes along the lesser curvature, right from the Station 1 lymph nodes, the lymph nodes along here has to be pulled down to the part of the stomach which is being dissected. If you see, even in a subgastrectomy, station 1 lymph node is always removed. Okay, this is the esophagus. This is the esophagus there what being defected, and this is the Vujji junction. Umbilical tape can be applied to get a good traction at this particular point if you're not, if your assistant is not able to give you a good traction. That's the aorta what you can see there, and that was the left crest of diaphragm in the before picture. It's the left gastric vein which is being clipped. As I already told, extra care should be taken. If it retracts, it irritates to get control over it. It's not impossible, but it definitely troubles you before you get a good control on that vein. So be careful on that vein, clip it well and divide before you divide it. After applying the clips, next comes the artery. Artery is always after. First, you will always get the left gastric vein. The dissection goes to, this is the root of the origin of the left gastric artery. A hemolog can be applied if you have one. Even a 5 mm hemolog can be applied if it's available. It's a little more expensive to have all the hemologs. Good energy source can be used to divide it. So that, as we already see, this is a splenic hilum, what you can see there, and that's the superior, that's a splenic artery which is being seen there. In a total gastrectomy, we have to dissect all this lymph node which is present here. In a subtotal gastrectomy, this hilar lymph node need not be dissected out. A proximal splenic artery lymph nodes, if we dissect, that's more than enough. So this is a proximal splenic artery lymph nodes which is being dissected out, and this is the aorta which is coming down. All the lymphatic tissue which you feel yellow has to be removed from this particular point to call it as a T2 lymphadenectomy. If you see, this is the aorta which coming out, this is the celiac trunk which, and the splenic artery will be coming here, and the common hepatic will be going the other side. So we have to dissect all the lymphatic tissue over the splenic artery to call it as a D2 lymphadenectomy. You can see the pulsation in this particular point on the superior surface of pancreas. That's the splenic artery. So it is a very nice thing that the splenic artery hardly has any branches coming onto the anterior surface as well as onto the superior surface. Most of its branches will be going towards the short gastrics or into the pancreas. So it's quite safe to dissect at this point because you will not find much vessels and no much bleeding will happen if we dissect on superior surface of the pancreas up superiorly from that point of the vessel. Excuse me. Yeah. Then the dissection should continue on the splenic artery till the celiac trunk to remove all the lymph nodes along the celiac trunk. Care should be taken not to injure the pancreas at this point. It bleeds very, it oozes rather than bleeding badly. It oozes, and it always will be difficult to control that bleeding. The left hand is very important. Too much traction can anchor the tissue, and you can have bleeding oozing from the lymphatic. Again, a bipolar usually controls that. Bipolar also can be used to dissect these lymphatic tissue from the splenic artery. So those are the lymphadenectomy. What we can see, clearing all this lymph of D2 lymphadenectomy. In a D1 lymphadenectomy, only the left gastric artery is lymph nodes along the left gastric artery is removed, and the perigastric lymph nodes will be removed. In a D1 plus lymphadenectomy, what we call somewhere in between the D2 and lymphadenectomy, the lymph nodes along the celiac trunk, that is proximal splenic artery lymph nodes, common hepatic artery lymph nodes, and the celiac artery lymph nodes will be removed. These are the lymph nodes which are coming from the venous supply of the lymphatics which is oozing there. If you are smart, I would have put a clip before cutting it because it always retracts and keeps oozing. Bipolar usually works well. Once it starts oozing harmonic, it's not a good instrument to try to control it. Only if you can hold the tissue in between the two jaws of the harmonic. it works well. When you cannot hold it, it is not that good to control the use. So it's always better to apply in such situation. Okay, that's about the part of lymphadenectomy. This is another video. I put it here, somewhere here, to show a hilar dissection. Okay, I'll put it still further, still further, still further, still further. Yeah. The dissection, this is a similar where the left gastric vein is ligated. Dissection is out. No, it's the same video again, sorry. Sorry, yes, okay. Okay. This is another video of a similar patient where a T2 lymphadenectomy is being done and dissection is carried out on the splenic artery right now. You can see small branches of the splenic artery. Here I have also removed the lymph nodes along the splenic hilar. Splenic hilar lymph node removal depends upon where is the tumor, as well as the distal splenic artery lymphadenectomy, we call it as a D2 lymph nodes. Removal depends upon where is the tumor. All this fibrophytic tissue has to be removed if it is a cardiac growth or if it is a total gastrectomy is being planned. Otherwise, it is not required. This is the adrenal gland, what you can see here, and that's a crust of the diaphragm. So all the lymphatic tissue was removed from this particular plane to clear to do a good lymphadenectomy at that particular point. We call it as a D2 lymphadenectomy. Splenic artery is being cleared there. Once you clear the splenic artery, it's a repetition video. As vessels could be seen better in this video, I have put this particular small clip of the video. Once the splenic artery part is over, you move on to the common hepatic artery. Common hepatic artery, it's the same plane, continuous plane, it's easy to pick up. This is the caudate lobe, what you can see of the liver. So in this between, there will be a hepatoduodenal ligament and all the tissues in it. So this is the common hepatic artery there. Care should be taken not to have bleeding here. The gastroduodenal artery will be coming at this particular point. If you see, we are at this particular point now. This is the origin. So this particular point what is acting. Here you will have the gastroduodenal artery which is coming. All the lymphatics from this. So this, as of now, if you only remove this much lymph node and a proximal splenic lymph node, this becomes a D1 plus lymphadenectomy, not a D2 lymphadenectomy. To call it as a D2 lymphadenectomy, splenic artery should be cleared completely, as well as you should clear the this is the same initial surgery which we started with, the continuation of the same video. Those are two small clips I showed in between. This patient was receiving aspirin and clopidogrel for cardiac cause. So he was very woozy, where I was stretching, he was oozing. So the lymphadenectomy was more of oozy lymphadenectomy what was there. So I thought I showed this in between two clips to see the anatomy better. This particular part is a continuation of the first video. We are dissecting at this particular point right now, where you can see the common hepatic artery and the gastroduodenal artery. And that is the right gastric artery, which is being already divided long back. And we are dissecting on the hepatic arteries. The right and the left hepatic artery, the lymph nodes being cleared. So basically, where dissection is happening at this particular point to clear the station 12 lymph nodes. The station 12 lymph nodes, there are 3 in that station 12 lymph nodes. The station 12A, that is represents the artery which has to be removed in a D2 lymphadenectomy, which it has station, then it has 2B, 12B, that is on the biliary tract, and P, which is on the portal vein. P and B need not be removed. The artery alone, if you 12A alone, if you remove, it is more than enough. And again, this lymphadenectomy depends on where exactly is the tumor. A distal tumor, this has to be removed. A proximal tumor, it need not be troubled. Okay, so that's a lymphadenectomy which is going on the. Here again, the left hand has a lot of role to do. Left hand traction gives helps us to see the plane, and it is important to dissect on the artery. When you dissect on the artery, it is comfortable. So if you see, that's the bile duct. That's a CBD. CBD is there. Okay, there's a gallbladder there, and that's a. We need not do the lymphadenectomy at that particular point. Around the artery, if you do, that is more than enough. So all the lymph nodes around the artery is being removed. This is the clipped duodenum or a stapled duodenum, which is transected. And as we are told, we already saw that the gastroduodenal artery was running at that particular point. The right gastric lymph nodes, we just remove the right gastric lymph nodes. Harmonic can be easily applied on the right gastric artery, and it usually doesn't trouble. So this is a good plane. Normally, I would have just put the harmonic blade and would have continued dissecting. This particular patient has used very easy, as little more careful. Dissection is continued. Dissection is continued on the vessel on the common hepatic artery, where it becomes the common the hepatic artery proper at a particular point after giving the gastroduodenal artery. Left hand traction has a lot of say. The right hand and left hand working port remains the same all the most part of the surgery. In this particular part of the surgery, we can use the 12 mm trocar as the camera port and the 10 mm trocar, which is the umbilicus, as the right hand port trocar, if good triangulation can be achieved by doing that. So the dissection is completed on that is the right hepatic artery, which is was divided using harmonic. I just sealed it again nicely to be double sure. Once I did that, this is a lymphatic tissue which is going on the gastroduodenal artery, which need not be removed. A clip was applied to be on the safer side. That actually completes the lymphadenectomy. So I hope that you guys have understood what's a lymphadenectomy. So I kept this part of the video to understand that lymph nodes along this, lymph nodes along this, and has to be removed to call it as a D2 lymphadenectomy. If the growth is here, only till here it's enough. If the growth is here, only till here it's enough. Right? Esophagus is being divided. Esophagus is being divided at just below the hiatus or the pleura. I'll stop the video here for a minute. A small incision is made at the level of the umbilicus. The specimen is brought out. Through this incision, we can do a Roux-en-Y limb, which I've shown in this photograph here. A Roux-en-Y limb can be created. Creating a pouch has a short-term good improvement, as she has told, that it helps in the reservoir function of the pouch helps in reservoir function, but on a long-term basis, the studies have shown that there is no difference between the pouch or not doing a pouch. A direct esophago-jejunal anastomosis can be done. So I'll continue the video. So a stapler is applied. This time the stapler is applied from the umbilical cord. Camera can pass on to the other one, or we can use the right hand trocar itself to convert into 12 mm to apply the stapler. A 45 or a 45 stapler, blue stapler is used to staple between the esophagus. It forms the posterior wall of the anastomosis. Care should be taken not to injure not to hit the Ryle's tube. It is quite common when we do these steps that we forget about the Ryle's tube. Ryle's tube has to be pulled up. In a bad day, if we hit the stapler at this particular point, it will be very difficult to correct. So the stapler forms the posterior wall of the anastomosis. From this point, we suture the anterior wall. A circular stapler also can be used to do the anastomosis using an anvil and things like that. It becomes very expensive. We generally don't use. For Gem Hospital, where I got trained under Palnivelusa, we generally don't use a circular stapler. Hand sewn anastomosis, I kept the full 3 stitches to be seen, so that it is little difficult to do a total gastrectomy suturing. The reason being that the ports or the angling of the angling will be quite different. It will not be in proper perpendicular point to the anastomosis what we want to do. So what happens is when we anastomose, we have to hold the needle in different angle to get a good bite of the esophagus as well as the jejunum which we are suturing. Preferably, the lateral 2 bites are taken first so that we can take a traction and pull and keep it a long bite, a long thread of once you cut it, so that we can give a traction using those thread. Okay, that's a lateral bite first being taken. So this was actual full bite without editing. One full bite had kept. I take around 45 minutes to complete the anastomosis. It also totally depends upon the body habitus of the patient and the assistant surgeon. If my colleague is assisting, I'm very comfortable. If a postgraduate is assisting, I take more time, because though they feel it quite difficult to continuously show one particular point, they try to move and they hit your they hit your right and left hand. So if you see, the left hand is hitting the camera. The cameraman could have adjusted it to have a better view. So this is what I was talking. The angle of taking bites becomes difficult because the ports are not in proper triangulation to take the bites. Okay, to take the bites, not for it's actually in good ergonomics, if not for taking bites. So it should be, always difficult at this particular point. Once you take enough bites or halfway through, a Ryle's tube has to be pushed from the esophagus down into the jejunum, just to be sure that in case trouble happens, it's always there to help you out and to not cause a stricture of the anastomosis. So Ryle's tube should be pulled and pushed into the jejunum. Okay. Once it is pushed into the jejunum, make sure it is placed well. Ask your anesthetist to fix it well. Once surgery is over, you can also ask your postgraduate or you yourself can fix it to the nose with the stitch well so that it doesn't get pulled out. Rest of the esophageal jejunal anastomosis, hands-on anastomosis is completed. I've kept whatever bites I've taken, I've kept the full length of it to show the difficulty of it and to see if you see the angle of the needle and the needle holder, it is not straight. It's important to have a good needle holder which doesn't slip away the needle. Because once we keep using multiple in a medical college setup, everyone tries to take a bite and needle holder gets spoiled, feels difficult. Keep the thread a little longer in this sort of way, so that in between, so that you can use it to give traction whenever required. You can ask an assistant to give a good traction, small traction onto it, so that the angle of bite becomes more easier. If you keep too many of them, they irritate when we take a knots. So that was the last bite which was taken, and that completes the anastomosis. So to go back, I would like to see, so total gastrectomy, when you call D2 lymphadenectomy, always D1 dissection means removal of 1 to 7. Whereas when a subtotal gastrectomy, if you see, they don't talk about the four, the upper part of the four. The four is divided into 3 parts, isn't it? The greater curvature lymph nodes is divided into 3 parts. The hilar, on the fundus, whatever the lymph node which comes around the fundus of the stomach, where short gastric vessel comes, you don't remove in a subtotal gastrectomy, because you want those vessels to give the blood supply to the remnant stomach. When it comes to D2 dissection, here again in total gastrectomy, you remove this is the common hepatic, then this is the celiac trunk lymph nodes, and this is the splenic artery lymph nodes, and 12A being the hepatic artery lymph nodes, which has to be removed. Again here, if you see the station 10 lymph nodes, they are not mentioned. Some book do mention if it's a cardiac or a growth in a more proximal position where to do a total gastrectomy. More of a lesser size results, again you can leave a hilar lymph node. Hilar lymph node again depends upon the position of the growth to be dissected or not be dissected, to call as a D2 lymphadenectomy. So post-operative care, that will finish my presentation. I hope that I'm on time. Yeah, I think I'm on time. FJ feeding to to be started on a day 1 itself, because we do feeding genostomy for this patient. And post-op day 5 by some people, I follow 7th day, do gastrographin study. If the anastomose stands well, we remove the Ryle's tube and start orally after that. Thank you. I'll be happy to answer any questions. Any questions?
So there are no questions, sir.
Ganesh, thank you for a very good talk and very nice presentation of the lymph nodes dissection.
Thank you, sir. It all started under your guidance, sir, long back in 2006-07, sir.
Thanks. Yeah.
Hello, sir. How are you, sir?
Nice to see you. It was an excellent talk. And thank you very much for taking out time and talking to our postgraduates. It was really a pleasure seeing you and your fantastic surgery. Thank you very much.
Thank you, sir. Thanks for giving the opportunity, sir.
Thank you.
I thank Dr. Manoj Togle sir and Dr. A.P. Pilak sir for chairing this session. Now we move on to the next session. We have lined up for you eminent speakers and staff from the Department of General Surgery, JNMC Belgaum, to discuss and present their views on two interesting topics. One of these is lab versus open debate. First topic will be open appendectomy versus laparoscopic appendectomy. I call upon Dr. Shashi Upin sir and Dr. Ramesh Kodli sir to chair this session.
पहले दोनों का कॉपी करके after that it's done. This is glittery pen, right?
ये खबरें दी ना ना
ये नहीं है किसी का ये डाल रहा हूँ मैं के लिए ठीक है
Final.
ये
Yeah.
ओपन है पीपीटी बैकग्राउंड में खोल के रखा हूँ मैं सर अब मैं जूम करके आपका स्क्रीन शेयर कर रहा हूँ ठीक है अब जब भी स्क्रीन चेंज करना दूसरी पीपीटी पे स्विच करना हो मेरे को बताइए
Amit sir. Amit sir. Amit sir. Start करें. Good afternoon, everyone. Our topic for today's debate is open appendicectomy versus lap appendicectomy. Our guide is Dr. Shashiyuddin sir, presenter myself, Dr. Kaivalya Saoji, and my co-PG, Prem Ghai. We will be vouching for open appendicectomy. The scheme of presentation will be introduction, relevant anatomy, preoperative preparation, anesthesia, operative steps, and points favoring open appendicectomy. Introduction: open appendicectomy is defined as removal of the appendix via an incision in the abdominal wall. Acute appendicitis is one of the most common entity encountered by a general surgeon. In history, Lawson Tate in London. In history, Lawson Tate in London performed the first successful open appendicectomy for a gangrenous appendix in 1880. And in 1889, Charles McBurney presented his series of cases of surgical treated appendicitis and also gave McBurney's point and McBurney's incision. Open appendicectomy has been the gold standard for treating patients with acute appendicitis for more than a century. But the efficiency and superiority of laparoscopic approach compared to open technique is the subject of much debate. Or is it? Let's see by the end of this presentation. Relevant anatomy. Vermiform appendix is a narrow blind ending tube. It is a true diverticulum located at the base of the cecum, 2.5 centimeter from the ileocecal wall. It is found at the confluence of the three tinea coli of the cecum. There are various positions of appendix as shown in the figure, but the most common is pelvic. Mesoappendix is a part of mesentery in which appendicular artery is present, which is a branch of ileal branch of ileocolic artery, which is the branch of superior mesenteric artery. Preoperative preparation, complete blood count, blood group, renal function test, ECG, chest X-ray, and clinical evaluation related to USG or CT. Anesthesia, open appendix can be done in a wide range of anesthesia, but most commonly done is a spinal anesthesia. If the patient is unfit for spinal, we can also give general anesthesia, or if the patient is unfit for general, spinal, or epidural, we can also do it in local anesthesia. Now the operative steps will be told to you by Dr. Prem Ghai.
I'll be briefing the operative steps. The patient will be placed in a supine position. Bladder catheterization and nasogastric tube will be inserted. And there are various types of incisions being taken. As you can see, the McBurney's point, then the Rocky Davis incision, which can be extended medially or laterally. If extended laterally, it is Rutherford Morrison, and if medially, it is Fowler-Weiss incision. We can also go ahead with right paramedian or midline incision in case where diagnosis is not certain, like that of an ectopic pregnancy or any pelvic other masses. So about the skin incision in children and young adults is small. In patient it's small. In obese the incision can be more. So the skin is opened with the scalpel. Then all the three abdominal muscle wall, external oblique, internal oblique, and transversus abdominis are split open in the direction of the fibers, and it's a good technique, or it's always better to hold the muscle edges with the clamps so that while closure you can identify the edges properly. Once you reach the peritoneum is grasped in between the two hemostatic forceps, and it is cut using a Metzabam scissors. You're taking care that nothing is below and you're not cutting the bowel. Once you're inside, appendix may be visible, apparent at some times, but you may have to swipe it out with two fingers going from superolateral to inferomedial position. You can able to feel the appendix, or you can trace the anterior tinea to till the base of the appendix. Once you find the base of the appendix, and we go ahead with the mesoappendix. Dealing with mesoappendix, we can directly go at the base, clamp, cut and ligate, or we can trace down till the base with small clamp, cut, ligate, clamp, cut, ligate technique until the base we reach. Once we reach at the base, we'll apply clamp the appendicular base 5 mm from the base of the appendix. Then 5 mm from the base of the appendix. Then we put a distal clamp and we cut and ligate. Another technique, if appendix is too much inflamed or edema is too much there, we can go ahead with the stapler with resection of the base of the appendix also, and later cauterize the stapler line. Another thing is if you have cut suture ligated the appendix, we can invert the stump using the Z technique or the pursing suture. Then the abdominal walls are closed in layers, and the skin is left open if there is more contamination, or closed with subcuticular sutures or normal matter sutures. We'll go ahead with the points favoring our open appendicectomy. So there will be minimal preoperative workup with anesthesia. In emergency situations, patients with various comorbidities can be taken up for surgery in spinal, local, or even trans-abdominis plane block. In this COVID-19 era, always spinal anesthesia is better than GA, as aerosols are generated less.
No advanced instruments are required. All we need for open appendicectomy is a scalpel and a suture.
So there will be reduced technical difficulties. TV monitor not working, CO2 insufflation machine not working, camera assistant required. Open can be managed by a surgeon and
appendicitis होगा तो open ही करो.
Yes, sir.
Your appendix I'll do open. The way you are fighting for open, तेरा open ही करो.
It's better to go and open with the trained surgeon. Okay.
Just spicing up the situation.
Yes, sir. Open can be managed by a surgeon and an assistant surgeon. That is only 2 persons with basic instruments.
No long learning curve. Laparoscopic appendicectomy requires at least 30 independent procedures, unlike open, which is the number is in single digits.
So it is good for under-facilitated centers. In developing countries, most medical centers are not well equipped with laparoscopic instruments. In our countries, most of the patients would prefer scar over empty pockets, which proves to be cost-effective.
Reduce operative time, especially in COVID times. Operative time is decreased along with the operative room time is also reduced. So exposure to COVID patients is comparatively less in open surgery.
Reduced incidence of readmission or resurgery. Due to unnoticed injury to adjacent structures like bowel or bladder during port entry. Also, early discharge may be the culprit.
Reduce incidence of intraperitoneal abscess formation. As stump is buried and even there is minimal handling of other organs other than cecum and appendix, intraabdominal abscess is most commonly seen in laparoscopic surgery, and in open surgery, wound infections is seen. So, what would you prefer, wound infection or intraabdominal abscesses?
So during the laparoscopic technique, during burn and pull cautery dissection, sudden movements can injure adjacent structures like bowel, ureter, and even the external iliac vessels.
CO2 inflation-related complications, respiratory compromise, hemodynamic instability, hypercapnia, which is the main cause in pregnancy, leading to fetal distress.
So, open appendicectomy is a preferred technique in previous extensive abdominal surgeries, previous history of pelvic surgeries, frozen pelvis in which adhesions are too much and there is distorted anatomy, in which dissection can be much better with open. Also, in uncorrected coagulopathy, open appendicectomy is preferred.
As a wise person has said, what hands can feel, eyes cannot see. But in open surgery, it gives us the privilege to do both. There is a decreased tactile sense as an instrument is interposed between fingers and tissue.
In case of incidental malignancy or any other pathology, can be dealt better with a lower midline incision if pre-op diagnosis is uncertain.
And one of the most important points, knowing open surgery is must before knowing laparoscopic approach, because the moment one realizes that one cannot proceed with laparoscopic surgery, he and she must know how to do open surgery.
So ending with this note, this was a Sir Leonard Rosgo. He was on Soviet Antarctic expedition. He was a medical practitioner, and he was on the Antarctica, this continent. And when he realized he had nausea, anorexia, and other symptoms of appendix, including the pain in the right iliac fossa, he knew that he was the only one who can do the appendicectomy on himself. And he did it with all his confidence and skills. With the assistance of meteorologist and an engineer, he removed his appendix and he went to work within 2 weeks
by himself.
Do you know what happened on the table?
Yes.
What happened?
Hiding. So on table he used a mirror to see his own organs, and he even during on table he was unconscious for a bit time, so he took rest in between.
He actually had difficulty in fitting the appendix, and he inadvertently opened the cecum.
Cecum also, but yes, sir, he sutured it.
Which is most dangerous, you know. Opening cecum itself is dangerous. You are making or you are causing an hazardous, you know, isn't it?
We'll hand over to the next.
So now I call upon the speakers who are going to discuss on the laparoscopic appendectomy is better than open appendectomy. We'll see how they'll fight. Yes.
Good evening, everyone. Today, I'm going to advocate why laparoscopic surgery is better for acute appendicitis. Chairperson for today's session is Dr. Ramesh Kajalgi, sir, and presenter is myself and Dr. Aishwarya. So minimal access surgery is the symbiotic relation of the modern medicine technology and the surgical innovation that aims for the better surgical therapies and more of a psychological benefit for the patient also. The advent of laparoscopy has revolutionized the concept of the modern medicine, and the minimal access is the procedure in which the entire abdomen can be viewed through a keyhole. So therefore, a decision on whether to proceed and how to proceed can be made by minimizing the trauma to the patient. Of all the procedures performed today in the field of the general surgery, the most common procedure performed is the laparoscopic approach. The incidence of acute appendicitis ranges from around 8.6 to 11 cases per 10,000 persons year, and younger patient has a higher risk, nearly 70%. And we'll see in the later slides that in the younger generation, in the pediatric age group, the lap is a better option. So according to a study, it is documented that there is increase in the laparoscopy for appendicectomy over the past decade, from 43%, which is in 2004, to 75% in 2011. He's Dr. Kurt Sim. Before 1980, everybody was following the open appendicectomy, but he has revolutionized the treatment for the acute appendicitis. He was the first surgeon who performed the laparoscopic appendicectomy in 1980, and afterwards, more or less, everybody is in favor of performing the laparoscopic surgery. Regarding the pre-anesthetic workup, it can be done under GA, and if in case the fitness is not given, it can be taken under, patient can be taken for surgery under spinal anesthesia also. The main principle on which the laparoscopy is working, that is the ergonomics. These are the few principles, that is the straight line principle. As you can see in this picture, as you can see, the operating surgeon, the field of the pathology and the monitor, they all three should lie in the same plane. That is a straight line principle. Then triangulation. In triangulation, I will be showing how I'm putting port in my patient. Then manipulation angle. Manipulation angle is the angle between the two instruments, as you can see here. So this is the manipulation angle. That is the angle which is between the two instruments. It is the standard is 45 to 60 degree, in which we can perform a better procedure. Then this is the gaze. That is the elevation gaze. As you can see in the condition A, the patient, and in the condition B. In this condition, the patient is the operating surgeon is having more of the neck strain. So low down gaze is preferred, low lying table and gaze down view. The equipments which are required for the laparoscopic appendicectomy are standard laparoscopic video system, carbon dioxide insufflator, trocars, atraumatic grasper, Maryland, bipolar forceps, and endobag. So as you can see, we have to take the patient in supine position, and the left arm is stuck by the side so that the surgeon and the assistant has a better field of doing the surgery. And then nasogastric tube and the catheter is inserted. Afterwards, 3 ports are inserted, as you can see. Umbilical port, left iliac fossa port, and the suprapubic port are inserted. With the umbilical port only, by putting the first port only, we can see the whole of the abdomen in one go. And this is a gold standard. That's why we can go for diagnostic lap also with only a single incision at the umbilical site at the 10 mm port. Then the 2 other working ports are created, 5 mm each in the left iliac area and the suprapubic area. Then the incisions were also very good, as the incisions are lying more periphery of the abdomen, and it will give a better cosmesis afterwards. 2 dissecting forceps are placed. As you can see, the view of the laparoscopic appendix in cases. This is a mesoappendix, appendix, and this is the forceps. This is a terminal ileum. Basically, we have to, there are 2 techniques, antegrade and retrograde. So we have to clear the mesoappendix till the base of the appendix. This is the ileocecal valve. Appendix is identified at the base, and then at the confluence of the tinea and the cecum, we have to divide it. The appendicular artery is also there. So caution is to be taken not to injure the artery. In this, we can see a very much magnified view as compared to the open surgery, and we can see the adjacent structure in a better way. In case if there is any retrocecal appendix also, so the lateral band which is there of the peritoneum with the cecum, we can release that band and it can give a better vision for the surgery. Then we can use after reaching up to the base of the appendix and after appreciating the tinea of the cecum, we can apply Rodder knot, or we can go with the stapler also. And then if in case it is a gangrenous appendix, or if some infection is there, if some abscess is there, we can retrieve the appendix in a endo bag so that it will not spill all over in the abdomen. And in laparoscopic technique, we can give a better wash and better lavage to the patient as compared to the open technique. So as you can see, this is the retrieval bag in which it can be taken out. So this is going to be the outline of our presentation, why open surgery in the modern era. So we are basically updating ourselves every day. So there is no point in going on bullock cart when there are jets and aeroplanes available. So if we are not updated, then we are outdated. So my friend Aishwarya will be dealing with these conditions in a more better way. So as you can see the comparison between the open incision and the laparoscopic incision.
It didn't look so dirty open in their slide.
That's why I choose that specifically. The illiterate for the 21st century will not be those who cannot read and write, but those who cannot learn, unlearn, and relearn. So it is the advancing era. We have to keep on updating ourselves.
Now that we've spoken about what laparoscopy is and what a laparoscopic appendicectomy is, we'll move on to the situations as to why we are advocating that it is more beneficial in this case. In case of special situations like pregnancy, as was said earlier, where they said open appendix was a better choice, we are advocating laparoscopy. Even though the port sites might change, the tissue handling can be better, the visualization can be better, and minimal uretral handling will be done. Coming to retrocecal appendix, as was said earlier, it can be detected faster with a laparoscopic approach. The main aim is, if you can see it, why do you want to feel it? You should know what you're seeing first. In case of appendicular abscess, whenever there is a perforation, a laparoscopic lavage can be given, which can give a better washout for the process. Basically, what we've come to an era where we as postgraduates are more acknowledged about what open surgery is and laparoscopy, but we forget the fact that our patients are equally knowledgeable as well. They come with us knowing what the procedures are, what the investigations required are. So when you have an approach of laparoscopy, why would you want to offer an open surgery? Other than appendicitis, if you do a diagnostic scopy for the patient with a minimal keyhole incision done at the umbilical site, where you can just place a camera and see if you have a differential diagnosis of acute appendicitis, it can lead to multiple other conditions as given here. A diagnostic scopy will be less invasive. The patient, does not have appendicitis, you can go for further procedures and plan later with a better approach. Here you can see the surgeon's operative view. Now you can see for yourself how magnified the structures are, how beautiful the anatomy looks on a laparoscopic approach, whereas in an open approach, everything looks the same. Especially for young generations, isn't it easier to identify with a magnified view? We are living in an age of video games and computers. So whenever you can zoom in, why not zoom in? These are the conditions where laparoscopy has been advocated as to various studies, which we will be talking about later. In the pediatric age group, it has been said that laparoscopy is the gold standard in case of acute appendicitis. Pregnancy, again, debatable, but we are advocating laparoscopy. In obese patients with larger and longer instruments, we can do a laparoscopic approach and plan a surgery in a better way. Elderly patients as well, if minimal scarring is done, post-op complications will reduce. Patients will have lesser chances of hernia. If we give post-op local anesthetic at the incision site, at the port site, it can also reduce post-op pain and the patient can go home walking the next day. So these are the advantages that we are advocating in case of laparoscopy. Less pain, precision in performance, scarring is minimal, less injury to the tissue, faster recovery, and of course, increased safety. Now, if you divide the advantages as per the doctor and the patient, what we have to put first and foremost is that the patient's importance, what the patient wants. If the patient can come out of surgery looking like he had no surgery at all, wouldn't he want to go for that approach in a better way? If he can walk home the next day with lesser hospital stay, lesser operative trauma, and lesser chances of post-op complications, there is no way that it can be a disadvantage to us. These are, again, the 10-12 rules of laparoscopy that we are advocating. Least incidence of surgical site infection, incisional hernia, wound dehiscence, adhesions, adhesiolysis. If you visualize earlier, you can do a better version of adhesiolysis. Aesthetically, no doubt it is better. The patient can start orally immediately the next day. Lesser use of analgesics, lesser chances of residual abscess, safe and feasible operation, less metabolic derangements can take place. Bowel handling will be minimal, so lesser chances of post-op ileus and shorter hospital stay. I'm sure you will be thinking that open appendix will be at a lesser cost, but given the amount of cost in laparoscopy compared to the amount of hospital stay in open versus laparoscopy, the charges somehow come to be the same. These are a few studies that we have found which advocate laparoscopy, where it shows that it can be a definitive and safe solution for suspected appendicitis. In pediatric age groups, in obese diabetic patients, laparoscopy is advocated. These are, again, the visuals of what you see in laparoscopy and open. In case of perforations, even in an emergency condition, the amount of time that has been given, operative time in open versus laparoscopy, is somewhat the same. Now, second is learning curve or duplicability that we are talking about. There are multiple studies that say that interns and surgical residents should be the ones performing laparoscopic appendicectomy. Because we are a younger generation, we have a better hand-eye coordination. With the advent of technology, it is easier for us to grasp the fact rather than what has been said, and it can be easily adaptable by surgical interns and residents as well. Second is cost effectiveness. Cost effectiveness, as you said the army doctor who performed his own appendicectomy, this has been devised by the Armed Forces Medical College, which is a cost-effective method for students to practice laparoscopy on, which reduces the amount of training, duplicability, and cost effectiveness. Cosmetic outcomes. This is known as a bikini line incision, especially since it occurs in a younger age group. Women can come with the use of glue without use of sutures. Patients can go home the next day, don't have to come back for suture removal, and can be fully satisfied. Whereas in open appendix, if the patient mobilizes early, if he walks around, he can develop scars like this, which younger generations no longer want. Everything is about cosmetic improvement. The other techniques that have been devised are single incision laparoscopic appendicectomy, where through only a single incision, because of lesser chances of sword fighting, there will be a better approach. As well as scarless surgery. True scarless surgery is transvaginal nodes appendicectomy, where through a transvaginal approach, it can be done. We have a conclusion for the moderators.
No, they have to fight with each other. Why you want to? What are the points? Why you want to say that? Yeah, come, both of you come here. Yeah. It's only verbal. Come here.
Go to the first.
Another person.
I've used this open instrument.
Is condemning those. Yeah, those instruments have been condemned. Surgeons not the servo, open surgeons. Okay,
bread and butter of the general surgeon.
No, that's what the idea of conveying this slide, showing this slide is we want to condemn these instruments.
This is the bread and butter of the general surgeon.
We know open also.
Yeah. So that wire
screen is paused.
Yeah. I think you can sit there, bring agreement and go and
Take care of wires. Take care of wires. Otherwise, it will get disconnected.
two positive points from laparoscopy and two positive points.
First, we'll ask why you want to go ahead with open appendicectomy. Few points.
For open appendicectomy is mainly open appendicectomy. We want to tell that we should learn open appendicectomy. We are not saying that we shouldn't do it, but we should learn about it. If we can't go ahead with laparoscopy, we should know how to do open. First point, it's very important as a general surgeon PG.
Point well taken. From your side, what is the point?
The point of the debate is not whether you should know it or not, it's whether you will do it on a patient or not.
If required, yes.
While doing it, if you fail, what will be the answer? You are doing a laparoscopic appendicectomy, you fail, you can't proceed. Then where do you stand?
So conversion to open can occur in any laparoscopic surgery, but The point is that when a patient is coming in to have options available, then why not offer it to them first? Complications happen in any surgery and can be handled in any way later also. So we will start with a laparoscopic approach, and then if required, we have a lot of assistance. We are just postgraduates.
You say that directly without learning open appendix, you should go in for laparoscopy.
Their
The younger
intention,
generation.
their intention is not like that.
You think
Their intention is not saying that you should do only laparoscopy. Open appendectomy is must, but now coming to the present era, you have to have a knowledge of advanced surgery, which is essential now. That's what you
do
want.
laparoscopy, you can do open, but it's not vice versa.
not vice, it is again vice versa. It is vice versa.
Yes, it is.
So now, where do you land? Again, you are back to square one. You stand firm. So by doing a laparoscopic appendectomy, you find that you are not able to handle, or your equipment fails. Your equipment fails. So where do you stand?
Yeah, professor.
So we can call for.
No, you are in your own setup. The equipment fails.
Then it can be converted to open. That will obviously be
So
explained
if we
to the
don't
patient.
see open only, then how will you learn to do an open?
Now, what should be your conclusion?
Surgeon's instinct.
We should know both, but we should do what is more relevant nowadays.
No, don't talk diplomatic. Now you are changing both of them. Now they are saying that you can do lap appendix. You are saying you can do open. But whereas you are fighting for.
So, but if a patient will come to the OPD and he will be like, I want a laparoscopy only, then.
If you are given an option that you are getting operated from a trained surgeon as open surgery or novice laparoscopic surgeon,
I would
what
still
will-
choose the laparoscopic surgeon.
How is it?
Because I'm sure if he knows laparoscopy, they will know how to do open surgery. They will have that much knowledge of how to handle a bowel and do a laparoscopic appendectomy. This is the basics for becoming an MS general surgery.
Now that is what. See, now there are senior professors, institutions, and there are VOPs and see, there are for and against for it. Because if you see, it is depending on the case. Still till now, it is not the gold standard. Laparoscopic appendectomy is not the gold standard. It can be done, and in good hands, you will have good results. But whereas in lap cholecystectomy, it has become a cold surgery. So now, what should be your, as a postgraduate, what should you think about it? It should be like this, that you should be well trained in open appendectomy. Because that is the problem that you should go step by step. If you are climbing up a ladder, you can't jump from first step directly to the last step. So now then the next, your generation is talking about open and laparoscopy. The next generation, when you all become teachers, they will be talking about laparoscopy and robotics. Then after that, again, it may come back to the, so it's a vicious cycle. So we should follow the step slowly, and then both of them are correct.
That is why we always say that history repeats. Even if you see the temples which depicts the olden style of wearing the dresses and also the present status wearing type of the dresses, so that we say that always history repeats. We never know, because at the present era it is always better. We say that knowing an advanced technique is always better.
We have conclusion slides
So
at the
you can put the
moderate.
conclusion slide.
Put
I
that
think
slide.
Nikhil sir and
Put that slide.
presidential remarks.
Put that slide.
What is your
He is saying already you have thrown me out. There is a question of talking.
All said and done, the present scenario is such. I am for any advancement, there is no doubt about it. Not that we have to forego the past which has been there over the years. It has got its own due and it's got its own importance also. Straight away, as it is, even when the cholecystectomy laparoscopy came into picture, it was a dictum that at least something should be done open, then only venture for laparoscopy. So the whole scenario or the whole gamut is that you should be able to do open, then go for laparoscopy. Both have got their own places. Yes. If there is a mass, mass, a particular mass, and if the tissues are friable, handling with hands is easier, more delicate than with instruments which are sharper, maybe injurious. I'm not talking about people who have much experience in laparoscopic surgery. They are doing all advanced cancer surgery also by laparoscopy. So in a novice or a person with an average laparoscopic surgeon, he should be able to do and tackle open also. In open, if you happen to come across CA secum by virtue of doing an open, you can handle it better than laparoscopy. Laparoscopy, if you happen to find a CA tumor, we'll have to convert it for better handling. Those who have been well versed with advanced surgeries can do laparoscopic also. But a person who's doing a regular laparoscopic surgery need to open it, then do the necessary surgery for postgraduates or younger surgeons, laparoscopic surgeons. We'll have to do an open necessary thing for the CA, secum, whatever it is. So, and further things will be, many things can be missed, may be missed, and maybe missed in open, and maybe missed in laparoscopy. Laparoscopy has got a better 20 times magnification. So things can be seen better. Open is one where you can just feel the tissue, the consistency, whether it is soft, whether it is hard. That cannot be made out by laparoscopy. So there are pros and cons for each. And one should step ahead in life. If it is good enough, adopt it. But you should be able to go back to the base level and say, yes, I will do that also. That is the ultimate story. Next. Next.
Next slide.
Anyway, panel, we would like to ask forget the evidence wise, but presentation wise, who won the debate?
Both.
The answer is one person from first group and one person from second group. You decide who it is. So both of them have won.
I will share one experience of my patient. In fact, you can think about patient's perspective also. It was in the year, you can say 2007 or 8 when this laparoscopic we started doing. One of my friend who is also a orthopedic surgeon and his wife was also a surgeon. I advised them to undergo. He was diagnosed with appendicitis. I told him to undergo laparoscopy, but they were not ready to accept that time laparoscopic surgery. He insisted me to do open surgery. And at that time, I was trained under Dr. Gopi. I used to tell him that I will do under 32 centimeter incisions. I will do with that much of confidence, I told him. And when I went for his bad luck, it was a subhepatic appendix. And I was constrained mentally while he's standing beside me whether to extend the incision or not. And so much of the difficulty, with little bit extension, I was able to do it. But what happened after 3 years, 4 years, he developed adhesions and then he had acute obstruction. He used to get repeated. Then later he only chose laparoscopic surgery.
He is an example of both.
Yeah.
I think that brings out a beautiful point. Like when we were learning and we were not doing it as postgraduates, I would see my boss do it with a 1.5 centimeter. His incision is so small that I can't even put forceps. What you will do is neatly open, hold the appendix, pull it out through that 1 centimeter, do appendicectomy, and then when he used to put the subcutaneous suture, even skin was not required. And then we who were learners, we used to say, "Arey kya appendix? 20-25,000 लगता है, 15 लाख का instrument लगता है, और इतना सब GA लगता है. What is this? This is better." But then when we started doing exactly the same thing, one experience in my early days when I went in severe bad appendicitis, lot of fibrosis, no guts to cut. So we converted, but laparoscopy at least helped me to take the incision in the proper place. So for example, in Sir's case, first spot, if you don't have been a diagnostic scopy, you would have definitely taken a higher incision. So I think I wanted to give this example for the next debate. There was a fight between a big ship and an aeroplane. मैं उड़ सकता हूँ, मैं तू उड़ सकता है तो सिर्फ 20 लोगों को ले जा सकता है, अरे मैं जहाज हूँ, मैं हजारों को लेके जा सकता हूँ. When they were fighting, a plane came and then landed on water and then sold them. So I think we should have best of both worlds where, and I think my heart goes out to the open team because you are like Rahul Gandhi now. Nothing in your favor much, even literature wise, but still
You compare with anybody, not him.
I have his name, what can I do?
Say Rahul can what?
His name is with
Then is for the postgraduate level, you should know the steps. You should know the steps of open in case, because we are seeing the generation coming up that directly they are trained. You can do a laparoscopic appendicectomy, but you cannot do an open appendicectomy. We are reaching this stage now, and maybe in another few years it is going to reach like that it is always a dictum. If you have a failure of laparoscopy, you have to know the open. But now we are slowly going into that generation where they are trained. Like the second batch said that we play video games, we do this. Now, for example, the battery is not there, video games are not there, light is not there. There is no connectivity. What are you going to do? You have to listen to songs, or you have to sing your own songs. For that, you should have your own voice. No, it is a simple example. So you should know, it is a dictum, you should know open surgery first, and it becomes easier. Like Shishupin said that, if you know the handling of pixel, what it is, you know where it is, and then it becomes easier. It is like going from a car where you have gears, now you don't have gears. Afterwards, Tesla, you can just say, okay, come here. You are going to that stage. But if Tesla breaks down, so it is a good conference, it was a good discussion. But for PG level, it should be like that.
Those who have seen laparoscopy and giving wash, we showed some videos. I know of an instance where the surgeon went in open and saw pus, so much pus. He closed the wound and put scopes again because he could give better wash with that. So I think no blind thing that this is better, that is better. We totally open should be known. You should do your 10, 20. Unfortunately, you don't get nowadays. 10, 20 appendix, whatever you should have. All varieties you should have. And definitely then laparoscopy will be easy. Great. Good.
We wanted to end our slide as a joke that the people advocating open have got certificates in endo training.
But they have. I thought it is in the beginning only. You tell me one question I will ask you now. कल तेरे को appendicitis होगा क्या करवाएगा? Well, truly now. That's it. So you have. Only actually I wanted to point out in a slide. Accepted different stand-up. You said नहीं कम center चलेगा, फालतू instrument चलेगा, training line भी चलेगा. In the beginning only hand down and you accepted different. I wanted to point out with that point only. You should have said, give an example. We said kidneys. I would have.
Thank you, sir. It's a long effort that
Together.
I get it.
Now we move on to the next and the last session of this today's program. I call upon Dr. V.M. sir, Dr. Manoj Tole sir, and Dr. Rahul Kanwadekar sir to moderate the next session.
Talking on.
We'll be doing it anatomy aspects, then Nikhil will do anatomy aspects of lab.
Who is with you?
Secure battery. He's doing second.
Good.
Good evening, everyone. So I'll be presenting the opening statement for points in favor of an open inguinal hernioplasty. So when we look at the picture of an open inguinal hernia, this is the incision that we take. It is just around 1.25 centimeter above the groin crease. And this is what the anatomy that we come across. As we open the layers, once the inguinal canal is exposed, we see the spermatic cord. And depending on the type of the hernia, if it's a direct inguinal hernia, we see it arising from the posterior abdominal wall. Whereas if it's an indirect inguinal hernia, it is somewhere along the anterolateral direction of the spermatic cord. So these are the minimalistic neurovascular structures that we come across when we just take an incision, the inguinal hernioplasty incision. We usually come across the three important nerves, the iliohypogastric, ilioinguinal, and the genital branch of genitofemoral nerve as we progress onto the external oblique aponeurosis. So coming to the most important and widely practiced, most popular what we do method today is a Lichtenstein repair. So as we can see in this picture, the biggest advantage of this procedure over a laparoscopic inguinal hernia repair is that it can be done without a general anesthesia or a spinal anesthesia. Nowadays, a local anesthesia or a field block is advocated. In case of a field block, we usually, the block is given to the three nerves, as I mentioned. Once we expose, after the exposure is limited only to this region. We do not come across any major visceral organs or any major vessels as well as. So once the defect is closed, this is how we usually place the mesh. It is placed around the deep inguinal ring, and we suture the mesh along the posterior abdominal wall, starting medially from the pubic tubercle, inferiorly along the inguinal ligament, and superiorly to the conjoint tendon fibers. So basically, the advantages that I'd like to share here is that structures such as the external iliac vessels are not come across when we go ahead with the Lichtenstein open inguinal hernia repair. The features such as corona mortis, triangle of doom, and triangle of pain, these are not the factors that we have to worry when we go ahead with an inguinal hernia repair. Similarly, the anesthesia that we give is only local or a field block, whereas in a laparoscopic surgery, we have to give a general anesthesia or a spinal anesthesia. Moreover, this surgery, it can be done nowadays with as small an incision as a 6 to 7 centimeter incision. Patient can be sent back home on the same day, and the learning curve is very less. Even people like postgraduates can do it. We are being trained to do it. And most importantly, in a setting like India, where economy plays a major role, the cost is more than 50% less of the cost of a laparoscopic surgery. We need not worry about it in our setting. So now the next, Shravya will be taking care of the next of the points.
Good afternoon, Manajan. Thank you for giving me this opportunity. First of all, I'd like to show this slide because most of us have forgot almost the other procedures like non-mesh techniques and even open mesh techniques. We know only Lichtenstein right now, but others are going to come into role in future, which I'll be highlighting at the end. And in this laparoscopic era, we need to know the tap and tap. And whereas open approaches like anterior approach and posterior approach and suture repairs, tissue suture repairs like Besney showed this technique. Coming to the main topic, which is gold standard, which we are going to decide now, which is open or laparoscopic. Coming to the gold standard, for a method to be considered gold standard, it should be having minimal discomfort, both during the surgical procedure and in the post-operative course. It should be technically simple to perform and easy to learn, low rate of complications and recurrence, and cost effectiveness. Coming to demographics, the overall incidence of Indian hernia repair in adults is men it is around 27 to 42.5%, in women it is 3 to 5.8%, and overall recurrence, including open and lap, is around 11%, and chronic pain is around 10 to 12%. And we see this statistics like how many Lagenstein open repair performed compared to the TAP repair, laparoscopic, and around only 2% of other repairs have been performed. I'd like to say is like a state most commonly performed hernia surgery in the world based on the previous statistics. Even though laparoscopic is preferred by most of the surgeons, the total number of open hernia repairs performed are more compared to the laparoscopic repair. Why open repair is preferred more? It is easy to learn, minimal risk of major complications, good results obtainable by non-experts, ideal for day surgery, especially under local anesthesia, suitable for almost all inguinal hernias. Major advantage in open surgery is anesthesia. It can be done under any type of anesthesia. And general, spinal, epidural, local, and step-by-step infiltration, which is becoming more popular nowadays. And TAP block for the post-operative analgesia, which can be given for both open and lap. Mesh placement. You can say in lap, the mesh placement is more anatomical and it is more advantageous. But the main role of putting a mesh is to prevent the recurrence, which is same in almost open as well as lap. So I don't think that is going in favor of laparoscopic. And size of the mesh and foreign body reaction. In case of open hernia, we use a size of 16 to 11 centimeters. In lap hernia, it is almost twice. It's 15 to 12 centimeters minimum. They say larger the mesh size, the less is the recurrence rate. But what about the foreign body reaction? The larger the mesh size, the more is the foreign body reaction. And what about in case of strangulated hernia? The role of open surgery is more in case of incarceration or strangulated or gangrenous hernia. But even though surgeons try laparoscopic approach, but laparoscopy to open conversion rates are more in this case. And Shoulders herniorrhaphy, I'd like to highlight this because it is a best non-mesh technique in terms of recurrence. This is a tissue suturing technique and can be most commonly used and helpful in women. In case of incarcerated or gangrenous intestine, where we cannot put a mesh in such cases where the field is contaminated. Role of lap in recurrent hernias. Studies say that in a recurrent hernia, lap is preferred, but in lieu of additions, dissection is made difficult, resulting in more incidence of bowel and more vascular injuries. Surgical site infection. In the current era of aseptic techniques and appropriate antibiotic coverage, the incidence of surgical site infection is almost same. The additional complications which encountered during laparoscopy, the most common include bowel injury, vascular injury, incidence of occurrence of umbilical hernias, which can be prevented in case of, and all other associated complications related to pneumoperitoneum and all the laparoscopic complications can be avoided in case of open surgeries. What is the ultimate factors which makes the patient decide to choose for us? Is the patient preference. If a patient doesn't give consent for general anesthesia, I don't think we can directly go for open. And surgeons' experience and elderly individuals who are unable to tolerate general anesthesia or spinal or epidural. We can go under field block in case of open. Need for groin incision in case of large inguinal hernias. This is the outcome which we see finally. It's the quality of the care we are giving and the financial, which is beneficial both to the hospital and to the patient, both which is economical. And finally, the patient, how the patient leaves the hospital with the satisfaction. I'd like to conclude my presentation with this slide comparing both open and lab. In this, we can see there are more advantages in the favor of open. There is only thing highlighted is a pain. But pain, we can go. We have some procedures which counteract the pain also nowadays. In this laparoscopic era also, lacustrine repair is fighting its way to be the gold standard method of hernia repair. In view of superior technique, ease of learning, able to perform in limited resources, any age group, any general condition, complications, same or less than laparoscopy. Various outcome benefits, lacustrine can be considered a gold standard. In COVID-19 era, during this pandemic, I want to highlight this. Due to ongoing controversies of open overlap globally, most surgeons and anesthetists prefer open overlap in view of risk of general anesthesia. And the use of cord can be minimized in open hernia repair compared to laparoscopy, therefore minimizing the risk of surgical smoke formation and inhalation. In simple terms, in the Google voice, I want to conclude my session like open hernia repair can be done anywhere, anytime, and any place, whatever the location of the hernia, either incapsulated or reducible, limited resources or a tertiary centers. This is a picture showing where lap cannot be performed, lacustrine comes into play. When lacustrine cannot be performed, shoulders can be done. Thank you.
Good afternoon, one and all. I will be discussing the anatomical advantages of laparoscopic inguinal hernia repair. Moderator for today's for our session is Dr. Rahul Kenwadkar and Dr. Manu Togle, sir. So I would like to start the polemic by saying one must always have a discussion in which there is light rather than heat. Change is the only constant. Wheel of time is racing past us, and it's time to catch up. So having said that, I would like to discuss what is an ideal method of hernia repair. So the patient should have minimal pain, discomfort during the surgery as well as post-operatively. The procedure should be technically simple and easy to learn, and the procedure should have very less complication rates, and there should not be any recurrence or very minimal recurrence, and there should be a short period of convalescence or recovery, or what we commonly say early return to normal activities. Yet another significant factor is how economical the procedure is. Now let's quickly get on to the debate. I know more than 100 surgeons whom I would cheerfully allow to remove my gallbladder, but only one to whom I would like to expose my inguinal canal. As rightly said by Sir Hanege Ojivi, the inguinal canal anatomy is one tough nut to crack. A good surgeon will have a perfect understanding about the inguinal canal anatomy. So let's go ahead with the details of important aspects of the anatomy and the advantages of lap hernia that has to offer to us. So it's a posterior approach, a mirror view, but a magnified with a better visibility. Even my female colleagues here will agree that they look better, more beautiful in a mirror image. In 1956, Henry Froschert espoused the theory that all groin, that is inguinofemoral hernias, originate from a single weak area called myopectoral orifice, which is bounded superiorly by internal oblique and transverse abdominal muscle, inferiorly superior pubic ramus, medially rectus muscle sheath, and laterally iliopsoas muscle. So the laparoscopic hernia repair, I would like to stress here, is the lap hernia repair allows us to completely
seal off all the defects, that is direct, indirect, femoral, in one go, not just on one side, but on both sides, and simultaneously repair all the sides with just one big mesh, and all of this with just 3 small 1 centimeter incisions. And also the obturator hernia also can be visualized well and can be covered. The important peritoneal landmarks for a laparoscopic inguinal hernia repair: the medial umbilical ligament, the median umbilical ligament, the medial umbilical ligament, and the lateral umbilical ligaments. They are very important because they give us a proper anatomic landmarks and to give to do a precise surgery. The medial umbilical fossa between the medial and the lateral umbilical ligaments is where the direct hernia is present, and the lateral umbilical fossa, where which is lateral to the lateral umbilical ligament, is where the indirect hernia is present. The most important plane, the pre-peritoneal plane, which is essential for a laparoscopic inguinal hernia repair. For that, we need to know the anatomy of a transversalis fascia. So it is a 2-layered structure. Earlier thought as 1-layered structure, is a 2-layered structure which superiorly has the 2 layers are completely distant from each other, and inferiorly they insert onto the Cooper's ligament. Anteriorly adherent to the rectus and posteriorly associated with peritoneum. It is a weak layer and often called as the Achilles heel of groin. So the pre-peritoneal space is anteriorly by anterior layer of the transversalis fascia and posterior by the peritoneum. And we also need to know the importance of space of Borges and space of Ritzius. So coming to the Pascal's law, it states that the pressure changes at any point in a confined incompressible fluid or gas is transmitted throughout the fluid or gas such that the same change occurs everywhere. So in an anterior repair, the Pascal's law is not in place as the mesh is over the defect, and due to this, it leads, the force is distributed unequally and leads to the lifting up of the mesh, which could lead to the recurrence. But in case of a posterior repair, the mesh is placed below the defect, and because of this, the forces are uniformly acting on the mesh, obeying the Pascal's law, acting as a reinforcement, thus leading to less recurrence. So the advantages, it is almost ambivalent now, that the laparoscopic hernia replace should be the #1 gunnery in any surgeon's armament because of its versatility. It's a tension-free repair that reinforces the entire myopectineal orifice. It causes less disruption of tissue planes. Only 3 ports are adequate for all type of hernias, less pain post-operatively, low intraoperative and post-operative complications, low or no recurrence, early return to work. So lastly, I would like to say that we should always operate with a compass rather than a clock. So after putting forth my facts, there's no brownie points for any new guesses. The best repair is the lap repair. And you don't make a progress by standing on sidelines, whimpering and complaining. You make progress by implementing ideas, said by the first president-elect, Shirley Chisholm. Thank you. United States of Congress. Yes.
Now we are, all of us are in the era of the evidence-based medicine. So where the evidence, there lies the reality. So the future is always evidence-based medicine. So what is the evidence that suggests that laparoscopic hernia, inguinal hernia repair is superior to the lichen stain repair? Coming to the statistics, there are over 20 million patients annually who undergo an inguinal hernia repair. In the population, lifetime risk is around 27 to 43% for a man to develop inguinal hernia in his lifetime. And in spite of all the advances, there is still an incidence of 11% recurrence and around 11% chronic pain following inguinal hernia repair. For many decades, mainstay of treatment was open repair. Laparoscopic repair was in the field since the early 90s, and it reduced the incision size, reduced the acute pain, and there is a faster time to recovery with similar complication rates when compared to open repair. There is a change in focus over the decades. Earlier, the focus was on recurrence and infection. With the latest surgical techniques, the recurrence and infection has come down significantly, and now the change in focus is towards recovery time, pain, and quality of life. A lichen stain repair is probably the first choice in a majority of the cases all over the world, and it can only be bettered by a more difficult and more complex technique like TEP or TAP, for which only excellent training and high caseload are the foundations. It seems clear that when considering post-operative pain, recovery speed, and chronic pain, the laparoendoscopic techniques are superior. Now I'll show the evidence from the literature to prove my point. When coming to the operative time, the most put forward argument is that laparoscopic inguinal hernia repair takes a lot of time when compared to an open technique. But time and again, literature shows that this is a study done in Greece with a total of 200 male patients, which shows that laparoscopic inguinal hernia repair is almost comparable in the operative time with the open repair. And this is a randomized controlled trial with around 1,500 patients from 11 hospitals in England, which shows that the operative times are comparable. And one more study, this study is done in Denmark, comparing around 400 men. Even this shows that when the surgeon has sufficient experience in the technique, laparoendoscopic techniques do not take longer than lichen stain surgeries. And when comparing with the intra and post-operative complications, there is a 4-arm randomized trial done in USA, which shows that laparoscopic inguinal hernia repairs have comparable intra and post-operative complication rates. The one more study with around 66 patients, this has been published in 2007, and the other trial which includes 1,370 patients done in England. All these point towards the fact that no significant differences are observed in the perioperative complications needing reoperation between the laparoscopic and lichen stain techniques. Coming to recovery time and chronic pain, even here the randomized control trials and the latest meta-analysis show that laparoendoscopic techniques have less chronic pain and a faster recovery than the lichen stain repair. And coming to bilateral inguinal hernia, there have been recommendations world over from all the hernia societies that laparoendoscopic repair is recommended for the repair of primary bilateral inguinal hernia over open repair, provided that a surgeon with specific expertise and sufficient resources is available. There have also been large database studies. A 2015 analysis with 17,388 patients, which shows that total extraperitoneal repair was found to have benefits on the post-operative complication rate, pain at rest rate, and pain on exertion rate. There is also one more large database study with 17,587 patients, which shows both total extraperitoneal and transabdominal preperitoneal repairs. Both are comparable, and in comparison with the complications, there is no significant difference between TEP and TAP. A hernia surge group consisted of members from all the continents with research in hernia-related studies. They formed international guidelines for the management of groin hernia, which is endorsed by hernia societies from all the continents across the globe, even including the Asia Pacific and Indian hernia societies. They tell that TEP and TAP in expert hands, especially when performing high volume surgery, are very safe and also cost effective. This was question put forward, like, do the advantages of endoscopic surgeries, avoidance of laparotomy, diminishing the pain of the incision, early mobilization and avoidance of post-operative adhesions outweigh the disadvantages? greater expenditure on technology, and more complicated methods of operating. This question was put forward in March 1983 in the Medical Tribune Journal when Dr. Kurt Sem proposed laparoscopic appendicectomy. Then people said it was too dangerous, unethical. People asked him to get a brain scan done, and people said it was going too far. It was also when he tried to publish his results of laparoscopic appendicectomy, it was said that such nonsense does not and will never belong to general surgery. His publication was rejected on the grounds that it was unethical. The president of German Surgical Society went as far that recommended for his suspension from medical practice. This is the statistics of laparoscopic appendicectomy and open appendicectomy done in the last 2 years in this hospital. 750 laparoscopic appendicectomies and 15 open appendicectomies. And I guess those 15 were done due to the COVID. So history repeats itself. And there is also reliable nation level registry data which exists for 2 countries, Sweden, where around 28% of the surgeries are already laparoscopic, and in Germany, where more than 70% surgeries are laparoscopic already. So history is already repeating itself. So we all agree that lichen stain repair is the most favored, is the most favorite, is the dawn of all surgeries. But please make way for the new. There is also a godfather too.
Any rebuttal from the
Godfather 3 is robotic. Yes.
Any rebuttal for the open competition? You want to contest? Yeah. Sit there. Go ahead. You can.
Anna, you are not. Only. You want to go ahead with another surgery? Anna.
Some of the points which were declared as advantages of laparoscopic inguinal surgery was that there is less time of recovery. Patient can go back home earlier, and also the cost is favorable. So regarding these points, what I have to say is, for a country like India, economy still matters. And although laparoscopic facilities are available in all the metropolitan cities and even in towns as well, not everybody is able to afford it. Number one. Number two, nowadays, the incision that we can take as small as a 6 centimeter incision, and we can suture it with a subcuticular suture, which is just 1 centimeter, 1.25 centimeter above the groin crease. So many of the times for a man, it is not even visible above his belt line. And it can be done very well. Patient can go back home the next day, if not the same day, in the evening. Anesthesia complications are less. We do not need to give him a general anesthesia. And most importantly, cost. Also the recovery, if we compare the complications, every statement which was put by the second presenter, every sentence had a clause attached to it which said that if done with high expertise, with high experience, with high knowledge, with high experience. So that is something for us at our level. Obviously, we are not as well equipped to be aware of laparoscopic procedures, but even for a well-established surgeon, it takes years together to be able to do a laparoscopic tap or tap. Whereas for a surgeon, even a MS general surgeon, he's supposed to know, and he will do a fairly good job. For us, when we would be more comfortable in doing a good job with a lichen stain repair rather than a tap or tap repair. So, although I agree with all the studies that were put forward, they all come with a clause that we need good experience. So, regarding the complications, lastly, I would like to conclude. The complications were compared between a good laparoscopic surgery and a good open surgery. So, I need not say anything more than this. So to compare the complications also, first of all, the laparoscopic surgery should be done in a good way. Only then can we compare the complications. That's
An apple.
According to me and Shravya, we prefer to go with an open surgery. Obviously, there are need of more studies, and there is a time that is coming in the recent few years when more and more of us, we would be well equipped in doing laparoscopic surgeries. Then we can surely compare both of them together. But as of now, we should know open Lichtenstein inguinal hernioplasty first, and then think about Dept and Dept.
Sir, no doubt we should, no doubt the open surgery should be learned, sir. There's no question to that. But what we have to see is, she said we are comparing a good laparoscopic surgeon with a good open surgeon. That comparison is needed. We can't compare a peanut with an apple. An apple should be compared with an apple. So on comparison grounds, good laparoscopic surgeon should be compared with a good open surgeon. Only then we can see which procedure is the best, because surgeon is the most important factor here, based on their arguments. And now coming to the cost, in our free ward, we are doing a laparoscopic surgery for 5,000 rupees only, with using same mesh and using same suture materials also. So in that way, cost is also tackled with. And obviously in laparoscopic surgery, there is always a very good vision, which cannot be countered with the open surgery. So with all these aspects, and most importantly, the chances of missing a contralateral hernia, which is obscure, is more than 30%. So when a patient presents with only unilateral hernia, there are always chances of him developing a contralateral hernia, which can be easily seen in a laparoscopic surgery, and it can be tackled also. So
regarding the good visualization, we need not worry about things like corona mortis, triangle of dome. We need not worry about external iliac vessels. We need not worry about entrapping the anterior femoral cutaneous nerve of thigh and the lateral femoral cutaneous nerve of thigh when we are putting the mesh.
Inguinodynia is more in which group?
So, sir, inguinodynia is the pain that stays even after 3 months of a surgery. So, studies have now shown that if while doing a Lichtenstein repair, we are able to properly observe and identify the ilioinguinal iliohypogastric nerve, then we should not be expecting a inguinodynia to happen.
Sir, I would like to support you.
Yes, sir. It is more, according to recent statistics, they say that around 26%. This was a study done.
Laparoscopy in tap and tap. Even if I want to injure that iliohypogastrik, even I want to injure that ilioinguinal, I will not be.
But in comparison to the injury that can.
Laparoscopic surgery, what you have testified, both of you are. Tell me how many studies are there where you put the mesh and it directly lies on the iliac vessels? How many studies have been done of thrombosis? Because wherever you put the mesh, there will be fibrosis, isn't it? So how many patients develop, and are there any studies being done where there is iliac vessel thrombosis or there is a block?
Yes, so we have.
Second thing is where you are handling the cord, from within inside. So if it is a young patient, what is the blood supply for the vas difference? So if it is an indirect hernia and you are handling the vas from there, is there a study where the sperm count has been done prior and later on? Are there studies, or are they being, if you think practically?
Yes, we have made a literature search, sir. There are very isolated, rare case reports of iliac vessel thrombosis. But in no large database studies, there were no patients reporting iliac vessel thrombosis. So they were just isolated, very rare case reports which are being presented.
Are they being underreported, or are they not being studied? Because once you do a hernia, because if you see the laparoscopic hernia has come recently within 10 years.
So I don't think they are being underreported, sir, because iliac vessel thrombosis is such
or they don't undergo sonography. Or should it be it is just a question.
No, so symptomatic iliac vessel thrombosis is a very big entity. So any large database study will obviously catch it. So I don't think they are being underreported.
What's difference and this?
So there are studies comparing sexual activity post-surgery, comparing open and laparoscopic, but both are showing similar results.
Today you have seen an excellent presentation both by Dr. Shailesh and Dr. Archit Pandit, where the full anatomy was told. And I think Vipin was there who said that, so when you are handling the pre-vesical area and all this, so are there any reports for that? And are you going to, one is, are there studies? Second is, if you explain this to the patient, which he will like. We are not saying, see, it's a very good thing that laparoscopy, we know all positive points, but it is open for discussion.
What is the amount of dissection you are doing in laparoscopy? And what is the amount of dissection you are going to do in open?
It is more in laparoscopy.
The amount of dissection is more in laparoscopy.
But that is
presently, what is the gold standard for management of
no, Liechtenstein is the gold standard, sir. That is why we are saying we need to go for highly skilled and more complex surgery to beat Liechtenstein. That is our point.
So
sir.
you stick to us.
Yes, we have to beat. We have to beat Liechtenstein.
No, today I came across one article where these people who have undergone this Dept tab, they are presenting with pelvic pain. Okay, chronic debilitating. So there's one surgeon in Australia who is specializing in removing the mesh.
Yeah. Just today we have got one.
Sir, I would like to raise that question, sir, to the
Now the mesh, now see, if you see the concepts of surgery, the deeper the mesh, the safer it is, isn't it? So now you have to think it, the deeper the mesh, the safer it is. So in laparoscopy, it is 100%, it is deeper. The above the safe, the more unsafe it is. Okay. Now this is one thing what you can say. But if the deeper mesh is there and if it gets infected, now what you are doing, the size of mesh what you are putting inside and the size of mesh which you are putting in the like instance. So what is the difference in this? If the chances of a bigger mesh getting infected is more, the chances of, so these are the way things which you have to search for the articles.
Yes, sir. Even when comparing,
if it gets infected, for example, like you, when you said when the pelvic anatomy was being told, if you put a tacker inside, if it hits something, so where do you land up?
And even the second thing is, whenever you are putting in a mesh in bilateral inguinal and hernia, most of the thing happens so that these two meshes are overlapping with each other.
Yes, it has to overlap.
Once mesh gets infected, the other side mesh will also get infected. Okay. One. And second thing, with this present era, that the Consumers Act which has come into the existence, if you are operating on one side, it doesn't mean that you are seeing the hernia on the opposite side without consent of a patient.
Yes,
you cannot operate on the opposite side.
Yes.
Do you agree?
Yes, sir. Yes, sir. Beforehand, we have to inform them, and during the intra also we can take the consent, sir.
See, that you are not informing in advance, saying that you may have an.
We should inform, sir. Ideally, we should inform.
Yes. And also for the Consumer Protection Act, sir, when we go to the court, evidence is on our side.
Yes.
So obviously we'll be winning.
That is what the consent is very important.
Yes.
When you are taking a consent, when you are operating on one side, it is always better that you take a consent that if the incident happens that if you come to know on an laparoscopy on opposite side, always have to have an evidence saying that you have taken a consent.
Yes.
What if you have
important?
What you have put in a mesh? You have put in a fantastic large mesh, and patient has a perforation and he requires a laparotomy. Or you want to go for some pelvic dissection, or the patient develops CA prostate, and you require a pelvic dissection. So what is the status of that? See, it has just started. It has just started 10 years, yes, maybe 10, 15 years. So if this patient develops a pelvic malignancy, CA prostate, take CA prostate.
CA rectum.
Or CA rectum. CA prostate. No, we agree. Again, you will do laparoscopically. But the problem is the planes.
Yes.
You should understand. So are you going to be justified when after 15 years he develops a pelvic mass or pelvic something or CA rectum he develops? Now today you have been seeing beautiful planes. See, when those people do these planes like Dr. Shailesh does, Dr. Archit does, it looks very good. It looks very fantastic. Isn't it? But when you start doing it, when you do it for 100 times, you will reach this level. But for example, and over and above that, there is a mesh.
Yes.
So where do you land up?
Those planes are totally obliterated.
Yes, sir.
Fibrosis. We are not thought about these problems.
So these are the things which you are discussing. See the level of discussion for the previous appendix and this. We are in second year. You are in final year. So your view is still broader view you have got. You have put on studies, you have done all like this.
But for this situation, we have an example, sir. We had a patient who had undergone renal transplant. The transplant failed. He was explanted. So he had multiple incisions. Multiple incisions led to renal failure. Renal failure with big incision, and he had, because of these incisions, he developed an inguinal hernia. And this inguinal hernia, he wanted laparoscopy because outside incision is there are no planes there. And this was done by Dr. Shailesh Tandekar sir only, where he went in and he put in a proceed mesh. So we discussed what can we put. We don't have a plane where we can. So there was a bare peritoneal area. There is no peritoneum. So all the additions are taken down. So what Naren is saying, the same thing. To beat Lichtenstein, we need complex.
Advanced.
And if you do complex, complex problem are going to come, which will need again complex solution.
Again complex solution. And these are isolated cases. These are not that one case becomes a.
And the other aspects are when we have to go in for when we have put mesh and we have to again go in. I think that we have done many times. That's not much difference. Wherein even for peritonitis, we can still go in by laparoscopy. Why we can afford to do that? Because anyway you are going to open. So you still have a benefit of.
No, you have a complicated lap hernia repair. Mesh gets infected.
So there are going in laparoscopically, explanting the mesh, treating it.
So many adhesions.
No, that's what exactly what Pradeep Chaubey and his team are doing in Delhi, Max Hospital. They are specializing in this where you doing that. And to solve this, there are some protocols in place where you see that the mesh is not getting infected.
So what is
problems which are there? So the instruments are the problem. The optics are open. Those are so they are bringing it down. So there are teams which are handling even this laparoscopically.
So now the question, see what Dr. Rahul has said that if Mupin said if it gets infected, if a laparoscopy set gets infected, now what is going to happen at your postgraduate level? See, we can discuss it at a postgraduate level, at a consultant level, at the periphery, and at the top level. So now there are 3 stages. So if you do a laparoscopic hernia, fine, nothing happens, everything is okay. After 3 years or 2 years or 1 year, it gets infected. So what is going to happen? It goes to one level. Okay. Now it goes to that level. He is not able to manage, or we are not able to manage. It has to go to the upper levels. But then again, like Mupin sir said, that the planes which are there are going to be distorted. So what has happened now? Now, because I have done it like this, I have done my surgery with the laparoscopy. I will convince the patient that laparoscopy only is good. Whereas if he undergoes a penicillin incision, if he keeps it open and if the mesh is removed, no doubt it will be difficult. No doubt it will be difficult. But then to do one problem has occurred, we go to the next level. The second problem which has occurred, we go to the third level. But the third level people who are there, who are handling these cases, they also with so much amount of experience, so much amount of this, and it will take hours together. So this type of discussion you should think about whether are we justified still. Because everybody says, because it is again like, because I do it, everybody has to do it. It's not like that. It is a standing example for postgraduates today. That because you have seen, like, see, Dr. Rahul is saying that Dr. Vishwanath said today, Dr. Ramesh, everybody is saying that yes, your generation, we are the second generation. We are in between the generations.
If I'm not wrong, Aishwarya already has called us old. So these young surgeons have better hands and better. She's already called us old.
This is the way you should think.
Yes. The Chaubey is the there have been general surgeons first. Yes. There have been enough and more opens. Yes. Then they have confidence.
My
so confident that doing open problems will always open.
My bottom line is I should and my next generation also should do more. I should not be stuck. I should not. What he put a beautiful statement. So the storm can come at the seashore also.
Yes.
If you stay at the shore and never sail.
You will also in that.
No, I'm not.
See all these things. Progress is accepted. We accept progress. So then we never say that progress. We have seen. You take the simple example of your mobile phones.
First that Nokia 100, now tuck, everything is there. Samsung has come, which is folded everything. But what is the basic thing? What are we forgetting? That the phone call should come. Hello, where are you? All additional things have come from home, wherever. So basic thing is that you should know open surgery. Yes. Later on, all these additions are good. Yes. If you don't know, hello, what is the use of that phone? Internet, this net, that net, everything. So it's as simple as that. So progress is good, but don't forget the past, and especially in surgery, you should have a base level that open surgery has to be done. It should not so happen. Again, I am reiterating that. It should not so happen that you learn only laparoscopy, and if you are in problem, you have to call somebody else.
It used to happen in my unit.
Yes, I remember. He
was a very good lab surgeon. Lab colleague beautifully used to. But if there's any problem during surgery, I was a standby. He could never do an open cholecystectomy.
That is what is happened in the same way.
No, I'm just
this is what I wanted them to tell. This will come.
So the take-home message is always you should know the open surgery. You don't mind saying that we are not against that. You should not know the laparoscopy. Basic knowledge is important.
I think Manoj
conclude silence.
New order surgeon should in the middle of the surgery. Yeah, the new order surgeon should be a blend of old with the new.
No, don't look at me and
it's the best of both. That should be a new order.
The days are now coming. Very shortly. Only laparoscopy will be learned by them. And they are afraid that they will be in a soup for that very problem. Then one more thing, a few things I would have to tell you, the youngsters who are coming up now. Don't be immediately by calling anything for help. Call immediately. Don't hesitate to convert. Don't say it's below dignity guy. And be open to suggestions. Don't say my people telling me your government hates my experience in surgery.
That's the biggest a team is required, beautiful team is required, and that is must and should be done. And I think biggest advantage is you can teach it beautifully. Even my nurse or the ward boy says, sir, udhar wo hai. So that should happen, and that will happen then. Be away, there's a problem there.
Now to conclude everything, both of them remember all have done well, but this fight was better than the previous one. So I think these people should require, because they were their second year PGs, we were final year PGs.
No, even they are outnumbered.
No, outnumbered, no, but the way of presentation and this, I think next year they will fight better. Okay, so a good applause for healthy discussion, and it was at least see what we are happy is the postgraduates are coming out and talking, and you become confident, and you can see you are talking with some of the who's who in the country. If you see for today's list, whoever is there, so you start developing that confidence. Even though if you make some mistakes, they are there, and small mistakes can occur. Thank you very much.
Thank you. Thank you.
Tomorrow morning.
So we come to the end of the day. This was our last session. We hope to see you tomorrow morning at 9 o'clock. Thank you, one and all.